to all our esteemed guests, dignitaries, faculty members and delegates with students present here on the National Oral Oncology Conclave hosted by the Department of Oral and Maxillofacial Surgery, MGM Dental College and Hospital, Navi, Mumbai. It is an honor to have you all to join us today as we embark on a day of insightful discussions, expert deliberations, and knowledge sharing in the field of oral oncology and reconstructive surgery. Before we begin, I'd like to take a moment to acknowledge the presence of our distinguished speakers and guests. Their contributions to the field of oral and maxillofacial surgery, head and neck oncology, and reconstruction has been invaluable. We are grateful for them for sharing their valuable time and expertise with us today to undoubtedly elevate the discussions at this conclave. Beginning with our very first session, I would like to invite our chairpersons for the first session today, Dr. Ujjwala Maheshwari Madam. It is my privilege and pleasure to introduce her as a distinguished pathologist and today's chairperson for the first session. She is the professor at MGM Medical College and Hospital, Department of Pathology, with her expertise extensively in the pathology field and unwavering commitment to advancing medical science. Dr. Ujjwala Maheshwari ma'am have invaluable insights and leadership to our conference. We are honored to have you here to add to the value of today's discussion, ma'am. Thank you for coming. I would also like to introduce and invite today as the second chairperson for our first session today, Dr. Prashant Pawar sir, a highly respected head and neck oncologist who will be serving as the chairperson with his vast expertise in oncology and his dedication in advancing the patient care. Dr. Pawar is a leading figure in the field and we are privileged to have him to guide us today's discussion, and we welcome you, sir. Thank you, sir.
Good morning. Thank you so much for kind introduction. I would request our first speaker, Dr. Amit Janu, who is a professor, Department of Radiodiagnosis TMH, to start the session on imaging for cancer oral.
इसमें से ऑडियो भी है क्या ओनली पीपीटी है? ओनली पीपीटी है ना? पीपीटी है ना? पहले उधर डाउन एट द टाइम ऑफ सही दिस इज वन कनेक्ट स्क्रीन करना है ना?
Recorder.
Sir, this is laser pointer.
Okay. Thank you. Good morning, everyone, and I would like to extend my greetings to the MGM Medical College and the entire organizing team, and especially Prashant for giving this opportunity to talk about a few points regarding imaging that we do every day regarding the oral cavity tumors. So if I say there are particularly many challenges that we face in day-to-day practice, that the anatomical localization, and we will see how we can actually best do about the anatomy. Then what are the correct modalities that we have to choose depending upon the site of location that has been suggested by the our team. And then whether we have to do any specific techniques, even though we are doing any specific modality, whether we have to do some puff cheek or water holding technique or something like this, or maybe for the larynx it might be different. And then we need to decide what is the extent of the disease. We know that probably it is going to be malignancy, but we need to define the extent in those aspects, and whether it is going to be resectable, whether it's going into the high ITF, low ITF, perineural spread, and other features that might change the treatment paradigms. And then we have to prognosticate the patient, whether what is the tumor thickness, whether there is any extranodal extension and the perineural spread, and that actually can change these treatment aspects. So coming to the anatomy, we can divide the anatomy of oral cavity into the oral cavity proper and the vestibule. We are going towards the vestibule, where we can discuss about the buccal mucosa. We can discuss about the upper and the lower GBS, lips and the RMT region. So these are the areas which constitutes the vestibular cavity. And when we go into the oral cavity proper, we will talk about the upper and the lower alveolus, the hard palate and the tongue. So if we are switching, in the first that we see here, all the images are of a CT scan. So for the oral cavity vestibular part, we will do the CT scan, and for the tongue part, the central cavity proper, we will do the MRI. So this has been a paradigm shift, and it will help us in better localizing these lesions. Then there are certain areas where we might have a confusion when both these structures are involved, when the oropharynx is involved and the tongue is involved, and at that time we will take additional help, especially in the localization, because it will have a different prognosis, the different level of invasiveness, and the treatment paradigms also might be different, like HPV positive versus negative. Positive more likely to be coming from the oropharynx and then going into the tongue, and rather than the vice versa. So with the same histology, we can have different outcomes even though everything is same. So that we have to learn from these aspects. Coming to the modalities that we have discussed, the yellow outline, if we see the tumor in those areas, we have to do the CT scan as the primary choice, and it has to be a MDCT, which have puff cheek techniques, and it can have both the soft tissue bone window settings. These are essential because we want to also look for any bone involvement which is having a much worse prognosis. And then the central cavity proper, which is also with the gadolinium sequences and the diffusion weighted sequences, and sometimes we have to do the post contrast to map the perineural spread. When coming to the techniques, we have to do the puff cheek techniques. So both are of the same patients. If we see in the left side, we are difficult to localize where exactly the tumor it is. The moment we will do a puff cheek technique, we will identify that there is a buccal mucosa tumor on the right side and it is going to the RMT. So that is the advantage, that when the air is coming into the vestibular aspect, subtle early mucosal lesions can be picked up in a better way. Again, once we have localized, we can use the MRI ADC maps to differentiate between the HPV positive and negative tumors. So coming to the tumor localization and extent, we devise the term that is the depth of invasion, and this is something which is talking about the prognosis. So something which is looking like much proliferative lesion might have a less depth of invasion, and something which is just in plaque-like lesion might have a more depth of invasion. And this is actually now taken part into the 8th AGCC staging system, where even though up to the 2 centimeter size of the tumor and up to the 5 millimeter depth of invasion are both having the same staging. So this is, we have to learn that there is a significant change that we have to see these pathologies. So proliferative tumors might have a less depth of invasion like we have seen in this particular case, and lesions which are flat may have a more depth of invasion and have a much poorer prognosis. So these are typically measured on the pathological specimens, but actually we can actually try and correlate them on the radiology. And we need to learn that there could be endophytic and exophytic tumors where the depth of invasion varies significantly. Another aspect is that if the depth of invasion is going to be more than 4 millimeter, then we might have to implicate the elective lymph node dissection, because there might be a chance of involvement of the cervical node that might be there, and it will affect the local recurrence rates. Something which is more than 10 millimeter, we might have to take the adjuvant treatment, and if it is something which is more than that, then we have to obviously take the whole panel into properly staging these tumors and may require a multimodality treatment. So if we see the circumference of the tongue, then we have to see the center of the tongue, and then we will devise from where exactly the depth of invasion. So we start from the periphery, go toward the center of the tongue, and we take the maximum dimension. So here the tumor might be looking like 1 centimeter, but the moment we will go posteriorly and anteriorly, we have to take the maximum depth of invasion. Something might be 2 centimeter. So that is the different aspect, and we have to measure these tumors properly. And then coming to the versus whether what we are actually measuring, it is only tumor. So the error might arise, and that's why we will take a array of sequences in which we will take T1, T2, star, and the post contrast. Whatever actually it is matching all the sequences is going to be the tumor. Whatever it is enhancing, it is the advancing margin of the tumor, and whatever outside that, it's going to be the edematous aspect of these tumors. So actually we will try to overestimate on the T2 and the star sequences, but if we match all these sequences, we know exactly what is the tumor dimension, and actually then we can differentiate between these on the various sequences, what is the tumor and what is the edema and what is the advancing margin of the edema based on these parameters. Again, coming to the neurovascular bundle involvement, something like this, when we see a tumor, we will give where exactly how far it is from the neurovascular bundle, whether it is more than 5 millimeter, whether it is abutting these neurovascular bundles, and it is abutting and encasing in those aspects. How we identify these neurovascular bundles? This is a typical MR where the neurovascular bundles are going to be dark. Dark means they are going to be the flow voids, and they have a similar signal like that of the air in the maxillary sinuses. So something like this, we can easily identify this is going to be neurovascular bundle. Here it is abutting, here it is encased, and this bright signal is because of the tumor. So DOI is going to be a better prognostic indicator, and that's why it has been taken to the new classification. Now we are not able to differentiate between each and every muscle that is going to be involved. We just say the depth of invasion is this much. Coming to the bone involvement, if you want to see the bone involvement, CT is better, and if we have bone window that are far more better, and if they are into multiplanar reconstruction, they will give a more better detail. But apart from erosions, there could be many other findings because of these tumors. We might have periosteal reaction due to continuous abutment. We might have marrow involvement which is having a different attenuation, or sometimes if the involvement and erosion is too much, we might have a pathological fracture of the mandible as well. So if there are subtle erosions like this, it is going towards a marginal mandibulectomy, or maybe just the periosteum involvement. But something like this where there is an extensive involvement and it is reaching up to the mandibular canal, and when there is a very less mandibular height, we might have to go for segmental mandibulectomy. So these are better assessed on the curved multiplanar reconstructions, where these are the multiplanar reconstructions. We can see the images into the axial, coronal, and the sagittal. But again, these are simple, straightforward reconstructions. We have to tilt our plane according to the plane of the mandible, and that's why we will realize, yes, in this particular aspect, what we are seeing a very subtle erosion, it is having a significant destruction, and even the mandibular canal is also eroded. So these informations are better seen on multiplanar reconstruction of bone algorithms. So there could be other concern that we have discussed regarding how much is the residual mandibular height, what is left from the tumor, whether the patient is edentulous, whether the soft tissue is going into tooth socket, whether there is any periodontitis which might be also confusing with the extent of the tumor. All those has to be taken into the account, because it will upstage the disease if we falsely label that bone is involved. Other thing that is coming is the perineural spread, and perineural spread is something which predominantly continuous, but it might have a discontinuous also. In this, there is an involvement of the buccal mucosa, and through the ITF it is taking the mandibular nerve, and what we are seeing it here on the right side, we can see that there are the nerves which is surrounded by the normal fat, Here the normal fat is replaced, and it is the tumor tissue that is there into the maxillary sinus as well. It is having the similar intensity. If you see on the MRI, it will have the similar signal intensity, and it is reaching up to the nucleus of the nerve. So this is how grave the perineal spread can be. Even though the tumor was just 4 millimeter, actually it is reaching till the nucleus of the nerve. So if we want to see the perineal spread, we have to cover the entire area of the nerves to see it. We don't have to do a routine MRI brain to see a perineal spread. We have to cover the entire area of the nerve, and only then we can actually appreciate these perineal spreads. So this is a case in which the parotid tumor has been resected and it was malignant. RT has been given the local site. There was no recurrence in the local site. But what it has been thought earlier as might be an acoustic schwannoma, 4 years down the time, it has significantly restricted, and actually the perineal spread was missed along the facial nerve, which is going, taking the route from the parotid and actually going into the internodary canal. And this is what happens after 4 years. There is a significant destruction, even though there was a good surgery, there was good adjuvant treatment, but this is finally what happened to the patients. So we have to see these perineal spread very critically in the scans. Even those tumors like this, which is very small, around 1.5 centimeter size of the tumor into the hard palate, what we see here is that it is taking the perineal spread through the greater and the lesser petrosal nerve, and actually we can see that it is widening the pterygopalatine fossa. So if we see on the other side, it is very thin, here it is widened. So any asymmetry if we see on either side, then we have to suspect, especially on the tumor side, if it is widening of the foramen, replacement of the perineural fat pad and all those features are there, it is going to be a perineural spread, and that is very critical. Even though we do very good surgery at the local site, if we miss perineal spread, the patient still have an active disease and have a bad recurrence later on. So we need to know that what are the areas from where the perineal spread can take an uptake. Here we can see that if the tumor is near to the mental foramen, it can take the route from here. If the tumor that is having alveolus and reaching up to the alveolar canal, it might take a route from that particular site. It might take a route from the ITF and then subsequently into the foramen ovale, and it can go into the cavernous sinus. So we need to know that V2, V3, all those things can have a perineal spread. It can take the route if the maxillary sinus is involved from the infraorbital nerve. So we need to know the routes of the perineal spreads, what are the sites where the nerve is lying, and then actually we have to antegratedly see whether there is any thickening or asymmetrical enhancement of these nerves. Coming to the sites, knowing that these are the sites that we probably have to see depending upon the location of the tumor. So if there is a tumor that is in the hard palate, then we need to know that we have to see the greater and the lesser petrosal nerve, whether there is a pterygopalatine fossa involvement, inferior oblique fissure involvement, and forward it is going to the foramen rotundum and all those conditions. So this is the adenoid cystic CA, and what we see in from the ITF, it is taking the perineal spread, going through the foramen ovale and actually going into the cavernous sinus. Again, the other histology which is also having very avid neurotropic factors, and through these the perineal spread can occur, and again it is going through the pterygomaxillary fissure, going to the pterygopalatine fossa, and then actually taking the route both from the V2 and the V3 and actually going into the cavernous sinus. Coming to the tumor resectability, we need to identify whether it is low and high ITF, because low ITF have a better prognosis as compared to the high ITF, and though we can divide the high ITF into anterior and the posterior and then sub-segmentize it. So what we see here is that when we see the notch, and notch is identified when we see the two processes of the mandible, and if these are actually seen, it means the disease has already reached into the high ITF. It is something which is a single process of the mandible, then we know that on the axial scans it is in the low ITF. In the oblique coronal or sagittals, we can know that we can clearly see the notch, and below, if there is a disease that is into the low ITF, it is above the disease that is into the high ITF. So these are the things which we can actually further characterize whether which part of the ITF is involved. Something like this, which is an extensive disease, here the orbit is involved, it is going into the high ITF, zygomatic process is involved, the perineal spread is also there, and it is reaching up to the skull base. So this is going to be in the extensive disease with nasocutaneous fistula formation. Again, something which is, we have to see the disease extending from inferior, here the entire skin is involved, it is going superiorly, and again it is reaching up to the skull base. So the coronal and the sagittal reconstructions give a single snapshot image, what is the entire extent of the disease, which might not be as visible on the axial image because we have to see all the sections, and then we will get to know what is the superior and inferior extent of the disease. Again, this is the tongue CA. What are the things that we will look at, how far it is extending, whether it is going till the hyoid, whether the neurovascular bundles are involved, whether it is going to the floor of the mouth, whether the pre-epiglottic space, and all those things are actually involved, which might have a relative contraindications to the surgical management. Coming to the locoregional spread. So to the locoregional spread, we will see that nodes are typically like this on the left side, but something like this might have an indeterminate feature because it is oblong and it is having loss of obliquity, and now it become rounded, and we don't know, we will call this as an indeterminate. But something like this where there is a lot of necrosis, though it is contained in the node itself, but the node is enlarged, it is having necrosis. So we will say yes, it is looking like a metastasis. Something like this in which there is a lot of involvement of the surrounding structure, it is clear-cut E&E that is present, and that is very classical, that we don't require any histopathological diagnosis for this particular aspect that this is going to be the metastasis or not. So the role of imaging is that whether if it is a clinically negative node, whether we can pick up any occult metastasis, and that can have an implication on the neck dissection. Once we know that there might be a node that is present, we need to confirm whether there is an E&E that is looking like a radiological E&E, where it is maybe very subtle, not clinically fixed node, but having a perinodal fatty stranding and all those features, and then to map the nodal burden of the disease to see whether the node is resectable with respect to the neurovascular bundles, and if we see here it is the carotid that is also getting to be involved by the disease. So this is a very good paper which talk about why we are actually doing the elective versus therapeutic neck dissection, and it will be discussed later. So we talk about the sensitivities and specificities. Both CT and MR will not have that sensitivity. Ultrasound is having relatively better sensitivity, but it's lacking the specificity. But if we combine these modality, probably we will tell that maybe it is around 70 to 80%, but still we are unable to pick up the micrometastasis, and that is the reason that the prophylactic lymph node dissection need to be done. Though we can actually predict about the E&E better as compared to the clinical, because we can see the nodes when they are not even fixed might have an necrosis, heterogeneous enhancement, there may be subtle capsular irregularity, which is the early signs of a perinodal spread, and once that it is fixed to the muscle and this thing, it may be the clinically evident E&E. So there will be many signs, especially on the CT and MR, that we can actually discuss. Even though if we have not given the contrast, if there is a dirty fatty stranding of the neck, that is something which is we call as vanishing border sign, and that can be picked up on the pre-contrast imaging. If we have given contrast, then we know that there is a saggy enhancement that is coming up, and this is a good predictor that there might be regional recurrence. We have to watch for regional recurrences and distal metastasis in future. So if we see this node, it is going to be an again indeterminate node, something like this, which is having a lot of necrosis, perinodal extension, and involvement of the sternocleidomastoid is going to be an extensive E&E. There could be other site like this. For the hard palate, again we need to know that we have to do an MR, and here it is something like this. Even though it is a pre-contrast imaging without contrast, but actually we can define it. There is a beautiful tumor delineation on the pre-contrast sequences. So now the pre-contrast sequences are taking a good lead as compared to the contrast sequences in delineating these tumor boundary. We are giving contrast to see the necrosis and the perinodal spread, but not for the localization of the disease as per se, because now the parameters are going to be much more sensitive, sequences are going to be better, and the localization of these diseases is going to be much better as compared to the earlier scanners. Coming to the post-treatment workup, where we can actually see about the NAAC category, something like this, which is category nodes in which there is no evidence of the recurrence, something like this, where we can actually say it is a definitive recurrence on imaging, no pathological evaluation is required. Something like this, where the category in 2 and 3, where there is a low and high index of suspicion, we might need to do an ultrasound and do an FNAC, or may ask for a follow-up or do a PET scan in these scenarios depending upon the suspicion. Apart from the recurrence, we need to know that there are many other factors that can actually come and actually disrupt us. This is the osteoradial necrosis, in which there was a lot of avidity. There was looking like that there could be a lot of soft tissue in this particular aspect, but at the moment we do a CT, and especially the bone window, we know that there is a dead bone that is there. It is all surrounded by the air and it is hanging in that cavity, and it is the osteoradionecrosis that is there. So these are actually can be better picked up on the CT itself. So for ORN, it is the bone window setting. If we see that there is a dry disease that is there, it might have some kind of inflammation that is surrounding in this particular aspect, but this is how we can actually easily differentiate ORN from the recurrence. Yes, there are some areas where we need to don't know what is exactly happening, and these are the cases we will bring to our MDT clinics that is happening almost twice or thrice every week. And if there are subtle areas, then we have to discuss with our pathologist, our referral surgical oncologist or radiation oncologist, how we are planning to treat these particular patients. So there are suggestions to these challenges that we have to avoid misinterpreting odontogenic disease that might be there into the when there is a mandibular involvement, and for that we need to have multiplanar themed reconstructions, so we can actually differentiate between these associated periodontitis with the disease itself. And then we need to know that what exact modality we have to choose for which particular site. Like for the tongue and the hard palate, we have to choose MRI. For the buccal and RMT, we have to choose an CT scan. And whether we at what time we have to do a PET CT scan after the treatment. It is usually 8 to 12 weeks. If we do early, then we will pick up more false positive details, and we need to know that we have to differentiate between the tumor versus edema, and for that we have to see all the sequences and match it. Something which is matching is going to be tumor, something which is not matching is going to be the inflammation plus edematous tissue. So coming to the newer techniques that is happening in this particular aspect, we will see that now we are employing some softwares by which we are doing high and low K trans, and through that we trying to predict whether even though there is an increase focal, sometimes there is pseudo progression that is happening in these patients, and subsequently if there is a high K trans, it means that eventually on the follow-up this probably will decrease on the follow-up, and something which is having a low K trans, probably this will having a recurrence early. That can be predicted probably with the new softwares. Now we have installed the new spectral CT in our institute, and the main advantage of this is that the amount of contrast requirement is extremely low. Earlier we used to do scans of around 100 ml of iodine. In this we can do around 10 to 15 ml of iodinated contrast, and it will give a very good results. And probably for the early mucosal disease, this might be a game changer, where actually if we see this is the routine CT that is there, and if we do the spectral CT, the amount of mucosal enhancement of the disease is far more better picked up, and it will give an iodinated maps. Through that the disease itself can be highlighted in a better way. This angio has been done with the 25 ml of the contrast, the carotid angio, and we will see the amount of clarity that is coming with these new scanners. So the advantage is that as compared to the single mono energy CT scan, it is having a multitude of photons, and every photon is actually making the image, and that's why the image enhancement is much more, differentiation between the tumor is much more. And in the dual energy it is only 2 energetic beams. In spectral it is multiple more than maybe around 80 to 120 kVp. All the entire energy spectrum is taken into that. So just to conclude that there is a role of imaging to describe the tumor, the DOI, another, and we need to choose the right modality, the right technique, and we need to know that where exactly we have to pick up the perineural spread and all those things, how we can actually measure about the depth of invasion, the ENE that is going to be there. And the 8th AJCC staging system involves the multidisciplinary care. It will introduce the concept that is introduced by pathologists, that there is a need to take care account of the depth of invasion to minimize these challenges. So thank you so much for the opportunity.
you so much, Dr. Amit Janu. It was wonderful presentation. Any questions, please? Sir, I would like to add something.
Yeah, please.
That being a pathologist and what we report normally, the perineural invasion and the extranodal extension, your scans were amazing, brilliant. But how do we come to know that from where the sections to be taken? Because we do not found all the time nerves. So how the scan can help us?
That I think Prashant can answer better actually, whether what section he is giving to the pathologist, whether he is giving the proper sections or not.
Actually, it's very important for the surgeon to orient your specimen well. Okay, I usually have a practice of getting a video of the specimen as well and send it across to the pathologist. And if there's any particular area which, as a surgeon, I am concerned, I'll also ink that separately and send it to the pathologist. Because I have been to the pathology when you go after 3 days with a fixed frozen, fixed in formalin. Even I am confused at times which is my specimen. Orientation becomes very difficult. So it's very important for you to, we also have a habit of putting orientation stitches. So we'll have, short superior, long anterior, that kind of. Because
yeah, you may put a stitches. Orientation is very important because otherwise you will not know which is superior, which is inferior margin, and then if there is a doubt of perineal spread, you can put that particular side as a inked. So that will be good actually in that sense.
So if you are really concerned based upon preoperative imaging about perineal invasion, we would usually typically take a small segment of the nerve and send it across a frozen as well. So that we are very sure on table that our margins are good. Because grossly all soft tissue margins we are really sure on frozen, but nerve sometimes they will miss. That's why it's a duty of the surgeon. If clinically based on MRI it was suspicious, then we need to send it separate. We cannot blame our pathologist not to be able to tell us.
Thank you.
Thank you, Dr. Amit, for the excellent presentation. Now we would like to invite our next speaker, Dr. Swapnil Rane. I'm pleased to introduce Dr. Swapnil Rane. He is Professor of Pathology at Accredited. He's done his MD, DMD, PDCC Fellowship in Oncology, and he has also done MRCS and Translational Cancer Medicine. Sir has immense knowledge in the field of pathology. His experience and expertise has added valuable contribution to the field. We call upon Sir to highlight the pathology features in oral cancer and pre-cancer.
Audio कुछ नहीं कर इसमें वीडियो साउंड है ऑडियो नहीं डायरेक्ट बताना
All right. Hi, I'm Swapnil. I'm a pathologist by core training. And I've done a lot of things. I've done renal path, I've done oncopath, I did this, I did that. I also have a computational angle to my work, and I run a computational pathology lab at Accredited, and now we are in the process of setting up a dedicated computational oncology department, which I am leading in that direction. So our talk today is largely about pre-cancer and cancer, but then I'm going to end up showing a glimpse of where things are heading in that, focusing more on oral cancer, but obviously it's a general thing happening in all areas of medicine and pathology and radiology in general. So let's start with the oral pre-cancer things, and this is a dental college. Obviously you see a lot more pre-cancer than what we do as a cancer specialist hospital, and we get a lot of pre-cancer more from the preventive side rather than from the core hospital side. And the people who go out in the community tend to send more samples of leukoplekic and erythroplakic lesions rather than the pure hospital itself. The list of precancerous lesions is quite large. This is just an indicative list. All of them have some or the other enhanced risk as compared to normal to convert to malignancy. Some of them are they are very high risk, especially things like proliferative varicose leukoplekia. The risk is very high of converting into malignancy in a very short period of time. Some of these terms are confusing. They are clinical terms more than pathology terms. For example, leukoplekia, erythroplakia, erythroleukoplakia, clinical terms describing the lesion as visible with the naked eye. While there are terms like PV, submucous fibrosis, oral lichen planus, etc., which are diagnosed more on the pathology side. There are obviously overlaps in clinical lesions, or clinically or pathologically also. For example, the lichenoid lesions or lichenoid reactions and lichen planus are very similar histologically, but they are to be differentiated more clinically by the fact of whether there is an inciting factor or whether local or systemic, which is causing the reaction, and whether that disease disappears after the inciting factor is removed. So these things often come, diagnosis not established at one point of time. You need a lot of follow-up information to really establish many of these diagnoses. So the oral lichen planus are essentially an idiopathic or more commonly an autoimmune disorder, while the lichenoid reactions or lichenoid lesions are secondary to some inciting factor, whether it be local to the mouth or systemic diseases, etc. We are going to start off with some of the normal histology. This is largely a clinical audience. There must be oral pathologists also, I suppose. So we hardly get any normal biopsies. Practically nobody would biopsy a normal tissue unless there is some lesion. So a pure normal biopsy is practically impossible. There are some features as close to normal that are possible. For example, this epithelium is as close to as normal for the oral mucosa. It has around 10 to 15 cell layers, and there is a basal cell layer. There is a certain maturation pattern. The cells have less cytoplasm at the base and they have more cytoplasm at the top, and there is a maturation pattern as it goes up. So this is how normal mucosa looks. And what the commonest thing that happens in leukoplekias is the increase in the thickness of the layers. So the presence of hyperplasias is a common word that you will find in pathology reports. There is a hyperplastic mucosal, hyperplastic squamous epithelium, and what it means is that the number of cell layers have now increased from the 10 to 15. It can go up to 50, 100 or more. It can be a uniform proliferation, or it can be a more stratified or different kind of proliferation. You can have these kind of indippings into the subepithelium, which we often call acanthosis from the pathologic point of view. And then there can be more bulbous kind of proliferations, which are more the word uses verrucous architecture. So the morphological description that you see in pathology report reflects what we are seeing on the slide. There are some implications on what we are trying to hint towards, where we are going with that diagnosis. Inflammation is a very common thing. You will not only find inflammation in the subepithelium on the lamina propria, but also in going into the epithelium, the small cells that are going into the epithelium. The cell types also is important. Depending on the cell types that we see, we can give specific diagnosis at times. You have eosinophils, you have a different diagnosis, but commonly there are more lymphocytes. And if you see neutrophilic microabscesses, then there are different diagnoses. Sometimes not only downward proliferation, but you can have upward proliferations or finger-like projections coming up. The word that we often use is papillomatosis or papillary lesions or papillary proliferation. This papillomatosis actually corresponds more to the clinical lesion of a verrucous growth and not the verrucous that pathologists use as where it is more of a downward growth that we are talking of. So the clinical verrucous lesion corresponds more to this upward proliferation or a papillary proliferation on the glass slide. The proliferative verrucous leukoplakia is more of a clinico-pathological entity and not a pure pathologic diagnosis. The lesion is more proliferative. Clinically, it is usually more diffuse, bilateral, tends to be bilateral and irregular. It also tends to somehow favor the GBS and the alveolar locations much more frequently. The importance of this lesion is that it has a very high conversion rate to malignancy. So it's conventional leukoplakias or erythroplakias, the malignancy conversion rate is proportional to the amount of dysplasia. So if there's a high grade dysplasia, the risk is around 10% or 15%, while low grade is around 4%. But in PVL, irrespective of the amount of dysplasia, the risk of conversion is very high. So within 1 or 2 years, the patient is very 50% chance that he or she will develop cancer at that particular location. Oral submucous fibrosis, slightly different lesion. Clinically, in the late situations, you can have the inability to open the mouth, and therefore evaluating those lesions can become difficult. There is obviously a very strong association with supari or areca nut, but also seen with tobacco chewing and other conditions. Pathologically, we see this. In the early stages, we might see some proliferation and inflammation happening, but in the late stages, essentially the subepithelium becomes very fibrotic and myxoid, and the epithelium start becoming flat. So these are the signs. This is also a conversion, there's a precancerous lesion, there's a conversion factor about 5%, higher than the conventional leukoplakias. The leukoplakias typically have a 1 to 1.5% conversion rate per year. Coming to the most important part, irrespective of what the lesion is, you should always expect a comment on the dysplasia on the pathology slides. The dysplasia as a word only means disordered proliferation, and this word has different connotations once the cancer is established versus when a cancer is not yet formed, or we are talking of precancerous lesions. In the precancerous settings, the definition of dysplasia is quite wide. It can range from architectural dysplasia to cytological dysplasia, how the cells are arranged to respect to each other, how the cells are maturing. Keratin is normally not present in the epithelium, but even if it is present in reactive conditions, it is present only on the surface and not deeper down in the layers. Mitosis is always present in the basal cell layers, never in the higher layers. But if you see all of these patterns, abnormal localization of normal findings also comes under dysplasia. So disordered proliferation is a very wide thing, and depending on the extent of the presence of one or more of these features, we often will group them into mild, moderate or severe dysplasias. Because of the differences in the implementation of these criteria, all the criteria might be objective, while implementing there is a inter-observer variation that comes in. So somebody who calls something mild, somebody else might call moderate, and so those variations are quite possible. Broadly, this is the visual description that there is some epithelial abnormalities in how the cells are organized. You have keratin starting coming up in the deeper layers of the epithelium, and the amount of basal cell layers start increasing. The cell organization also starts changing. So normal anatomy is very organized, while the cell in dysplastic, the cells start losing their orientation with respect to each other. And once it is severe, the rate of conversion to malignancy becomes almost 15-fold for severe dysplasia. Something less common in the Indian setup is the HPV-associated epithelial dysplasia. This is typically restricted to the oropharynx, but nowadays we do see a lot of this in the oral cavity as well. But nevertheless, it is much less in the Indian setup as compared to the Western populations. Characterized by the classical cells which are very multinucleate and very bizarre as compared to the conventional dysplastic cells. We typically diagnose this, ideally confirmatory diagnosis by a genetic test to do HPV RNA, but a screening test using P16IHC is often done. This P16 IHC has come from the western sites. In the western countries, the prevalence of HPV is very high. As a result, the positive predictive value is almost 80 to 85% in the western population. But since our prevalence is much lower, the positive predictive value of P16 is actually less than 50% in our population. So P16 alone is not to be used as a marker of HPV, and once you have a P16 positive, you need to push to genomic test to get a confirmatory HPV RNA or PCR based confirmation. The role of the person doing the biopsy is extremely important. You often send punch biopsies. The punch biopsies are very small, 1 to 2 millimeter, 3 millimeter in size. And if they become a ball during transport and during the processing, it's like we are looking in pathology in a looking at a three-dimensional structure in a two-dimensional pattern. So you 3 millimeter diameter or thickness tissue, we actually look at only a 6 micron cut. So we are looking at less than 1% of the tissue that is sent in the single cut. The rest of the tissue is remaining in the paraffin block. We can see more cuts if required. But if the orientation is wrong, a normal epithelium can also look hyperplastic and acanthotic and dysplastic, because everything starts becoming abnormal. The surface to basal orientation starts changing. With experience, we often realize when this orientation is abnormal. We try to correct it, but often the biopsies are very small and these orientations cannot be changed. Theoretically, whatever I told you, all of that is possible to assess pathologically, but it is quite extensive assessment. This kind of extensive assessment is largely restricted in the research settings. We do this for many of our research work. In the practical, in the actual clinical usage, we have a more condensed version of this assessment where we don't actually put out the different dysplastic features one by one, but we group them and give all of this information in a condensed manner. So this is largely about the precancerous conditions. Going to cancer, the commonest cancer in the oral cavity is obviously squamous carcinoma. Theoretically, any cancer, any type of cancer, whether it be hematological, stromal, and mesenchymal, germ cell tumors, a lot of these things can happen in the oral cavity. The commonest thing is about squamous carcinoma, so I'm going to largely restrict to squamous carcinoma. It happens to be the most common thing that we see in our practice. 90% of the biopsies in any tray are squamous carcinoma. But there are a lot of variation that is there. The majority of the tumors are the conventional squamous carcinoma, where you have this keratin pearl formation and you have cells which are basaloid with the loss of, and the cells are infiltrating into the stromal cells, stromal areas. You have more differentiated cells at times, but there are some morphological variants. Within this conventional squamous cell carcinoma also there are many variations. But there are certain specific variations which have clinical significance. So one of the significant ones is what we call the basaloid squamous cell carcinoma. This tends to have very high prevalence of P53 mutations, and therefore they are resistant to therapy. Then there are spindle cell sarcomatoid carcinomas commonly seen in the recurrent setting, but upfront sarcomatoid carcinomas are also very common. Sarcomatoid carcinomas are also notorious that they are very small and polypoidal, and they have a very typical clinical appearance, and the patient may not take it very seriously because of the size of the lesion. There are other variants like adenosquamous and acantholytic which do not have too much of a clinical significance in terms of the outcome and the patient therapy is concerned. There are certain, on the higher side there are some variants, so basaloid squamous cells, sarcomatoid squamous cells. On the lower side of aggressiveness there are some variants. So it is very important that these variants are also identified because they have a very good prognosis. So carcinoma cuniculatum is a word given to a very well differentiated squamous cell carcinoma where the surfaces, what you see is this traversing tunnels of keratin filled spaces, and the spaces are lined actually by epithelium which by themselves look very normal. So if somebody gives a very small part of the tissue, it will be very difficult for the pathologist to say that this is a carcinoma, because the carcinoma diagnosis is established largely after resection. Once we see where the epithelium is going, where it is going in areas where it was not supposed to be there. It is a very locally invasive tumor. If it recurs, it tends to recur locally, but a very good surgery often is more than enough for this kind of a tumor. They don't tend to metastasize. The other tumor that has a very good prognosis is a verrucous carcinoma. Now, this is often a very misdiagnosed entity, basically because you can have squamous carcinoma which can have that verrucous pattern. So, typical squamous carcinoma can also have a verrucous pattern. The important point to be noted is the nothing more than mild dysplasia is acceptable for a verrucous carcinoma. So if you have moderate or high grade dysplasia being coming up in this tumor, the diagnosis of verrucous carcinoma has to be put out of the picture. Again, it tends to be missed at biopsies because it is a very broad bulbous tumor. You don't get the deeper part of the tissues, and therefore the diagnosis is often established only on a knife biopsy or a resection. Again, extremely good prognosis. So there's two ends of the spectrum, they are there, and in the middle there is a lot of variation, most of which is not possible to differentiate based on the conventional clinico-pathological ways. Apart from that, there are some other variants which do not have much significance, like the papillary SCC. It doesn't really have too much of additional significance. There is a lymphoepithelial carcinoma, which is much more common in the nasopharynx, but it can also occur in the oropharyngeal settings. So, in the pathology report, you need to include, pathologists need to include the prognostic factors, both related to the primary tumor as well as the lymph nodes. In the primary tumor, apart from the tumor size, tumor stage, there are now since the 8th staging and even slightly before that, there has been a lot of talk about tumor budding, perineal invasion, the patterns of invasion and things like that. So each of them have been identified to be independent prognostic factors, and therefore it is important that all of them are included in the report. Hence, the minimum data set reporting becomes important. Now, there are many guidelines available from the standard professional bodies. There is the Royal College of Pathologists, there is the CAP guidelines, there is now the ICCR or the International Consortium for Cancer Reporting guidelines, which they are trying to merge all the different guidelines into a consistent pattern. Largely, they are more or less similar. There are minor variations between the different guidelines. The most important, all of them actually say that the core elements are the most important because they have been clearly shown with a level 2A or a higher level of evidence that they are prognostically relevant. The minor elements, like there are some elements, for example, you might have the perineal invasion, whether it is present or absent is the most important, but then the size of the nerve involved becomes a less important non-core element in the reporting parameters. This is the difference largely between what we call a synoptic report versus a free text report. Synoptic report essentially comes in the form of some sort of a variable and the value kind of a report, and while a free text report is much more descriptive and it tends to be difficult to navigate for the treating physicians. We at our center actually have both these reports being printed automatically, so we will talk shortly about that. So there are levels of synoptic reporting that you can adopt. If you have initially been typing just free text reports starting from level 1, you can actually take the jump to level 3 where you are still typing it out, but now you are actually typing out variable and values kind of a report. But the level 6 is the final kind of thing where there is a lot of automation and computational technology being deployed with integration with the standard nomenclatures, TNM staging, and all of this being automated to a great extent. So all of these things are possible. With the free text report, there are other problems. There are typographic errors. You can tend to miss things, and therefore the number of calls you get from the clinic that okay, you have not mentioned about this or that starts increasing. With the automated systems, this level of incompleteness starts reducing, and the possibility that you are giving an incomplete report and the number of time you spent in actually retrieving the slides to look at it again starts reducing. So in the long run, these are much more better, but obviously it takes certain amount of technological help as well as the desire to go in that direction. There are other advantages like for research as well, where the data actually starts becoming more structured. So we at TMC also have this kind of very objective data entry where we have separated the report generation from the data entry. And the pathologist essentially only click on buttons and have a minimal free text entry to generate the different components, starting from the frozen to the margins and things, and everywhere we are not typing a lot of all of these things, and the report is automatically generated. We also have deployed this vendor neutral image management system for gross images as well as for whole slide images, where we can, anywhere in the world we can look at those pathology slides that exist on the platform. So all of these things are possible. The most important thing that it actually led to is the reduction in the turnaround times. So our average turnaround time started dropping, and it went within a year from around 12 days to 8 days. But most importantly, you can see the difference in the turnaround times, where the structured reporting actually shifted. There was a dramatic shift in the reporting time required for the pathology stand, and more than 50 number of reports that went out within the first week went from 10% to 50%. So there was a dramatic jump in the completeness as well as the time at which time that it took to actually do all of this reporting. Coming to digital pathology, most of the pathologists, even now, almost everywhere in the world, still look at the glass slides under a microscope. As we know that the tissue actually goes through a lot of processing through a number of machines supervised by technicians, trained technicians. Once the blocks are prepared, we actually cut a 6-micron cut and then stain it and put it on the glass slide, and we look at it under the microscope. What has happened now is that in addition to conventional photography, there are now automated machines which can take height, speed, throughput, and very accurate photographs and stitch all of those photographs together into a single image. So we can have the entire slide being digitized instead of small parts of the slide being digitized and then recorded, and the amount of clarity and the information that comes from this is significant, is almost as equal to what we see under the glass slide under the microscope. It has a certain additional advantages that we can, the experience is also practically very similar for the pathologist. We can actually zoom in, zoom out of the glass slides on a computer screen without having to be physically close to the glass slide. There are other advantages that I will quickly talk about. We can actually look at multiple slides simultaneously, which is not possible on the optical microscope. And essentially what now has happened is that we have replaced the microscope with a computer screen to a large extent. The microscope still is there, but there is still a lot of transition happening in different areas. Unlike radiology, the film that went out when radiology went digital, the glass slide is not gone, so a bad glass slide will lead to a bad whole slide image, and therefore the diagnosis will still be bad. So a good glass, so digital is not a replacement for conventional pathology, is an add-on, unlike the digital radiology technique that happened. So there are a lot of advantages. I can look at it from anywhere, the educational, the research advantages and all of those things. But most important disadvantage or the problem that we need to deal with is the file sizes. So a compressed file size of a whole slide is roughly around 2 GB, and as to give the volume of data, if we digitize everything at TMC, we would need about 1.5 petabyte of annual storage just to digitize and keep everything. So we are still not there. We are digitizing barely less than 5% of our entire workload, despite digitizing more than 500 or 600 slides on a daily basis. The reason why digital pathology is the future is not that we can look at it on the screen. it is often faster to look at it under the microscope if the pathologist is sitting on the microscope and the slide is physically there. But the reason why digital is the future is the AI applications and the computational pathology that has come in the fore. So the counting and accuracy of different tools, there is always an inter-observer variation. You can actually count much better on the computational. So even if there are no advanced softwares, even simply counting on the computer is much more accurate than counting on the microscope, because in microscope you are eyeballing, while on the computer you can actually pinpoint the different cells and do that much better. What has been clearly shown is that people who use computational tools actually perform much better than people who don't use computational tools. So the level of accuracy of a young pathologist becomes almost as good as that of an expert pathologist, and that is the real advantage, where pathologists who are working at remote centers or where they're working alone, they often will get much better help using these computational tools. Diagnosis is not a very difficult, it's a low-lying fruit, especially for common entities. So this particular chart is for the gastric biopsies, not for oral cancer. The accuracy of the model, the blue line, is actually, as you see, is much better than most pathologists, and it is much, obviously, the trainee pathologists or students lie somewhere around here, while expert pathologists lie somewhere around here. There are obviously a lot of labor-intensive tasks. For example, in our surgical resection, we look at lymph nodes. So out of 2 trays of surgical resection of around 40 slides, around 30 slides are lymph nodes often. So there's a labor-intensive method where we're looking for tumor metastasis. This entire work started with breast cancer, but now it's also being done in head neck cancer, and there are now AI models which can actually detect much more accurately and fast all of these metastases. So we have been in the process of developing some kind of a pan-cancer lymph node screening pipeline, where currently a model can detect both adeno as well as squamous cell carcinoma metastasis, and even quantify the size of the metastasis and the extent of the ENE to a large extent. We are in the process of actually doing this, taking this further. But more than the quantitative tools, it is the ability to look at the image or look at tumors in much more detail, which human minds cannot. So for example, in a glass slide there are millions of cells. A human mind cannot really process and measure every cell on the slide. But computational methods and AI models can actually measure and count and every cell on the slide in a very fast manner, and come up with predictive models which will identify patients who are much more aggressive as compared to others. And therefore, we can then escalate treatment for those patients and de-escalate treatment for patients who have a less aggressive disease. So this is some work happening with the Emory University, and we are a part of it. Another tool that we know, another feature as pathologists we often know is that if we have these bizarre cells in the slide, it indicates a worse prognosis. So this is a common knowledge that if you have a lot of anaplasia on the last slide and the tumor, then it is a worse tumor. But we are not able to convert it to a predictive model or a predictive score. On the other hand, computational tools can actually do that. They can quantify all of these abnormalities and give us predictive models, and they have clearly shown that the cases with these pleomorphic cells, we can actually identify them and show that they have worse survival when being treated with the same kind of treatment. The important thing about models to be highlighted is that in this particular study, the authors actually did the study in 7 different centers. If you look at the hazard ratios of those cases across the centers, they are not identical or even similar. The hazard ratios actually range from 1.4 to 2.2. And this variation is possible, and is something that we need to keep in mind, that AI models do not perform equally well in different patient groups, especially across geographies. Even in India, a model that performs well in, let's say, in TMC in Mumbai will not perform equally well in TMC in Guwahati. So there are a lot of variations that AI models get affected with. Another example is where we can actually look at images and give genomic mutation results. So this is one of the work that we have been doing, and we are in the process of actually publishing and taking it ahead, where we can predict HPV RNA presence on the image directly. To do that, we actually took cases where we had the genomic information from the tissues, and we trained the model to predict HPV mutation. And what the model actually does is actually goes and puts a heat map on the image and it identifies for us which areas it thinks are associated with HPV positivity versus negativity. And if you compare the positive predictive values of the versus the P1610, this image-based test actually performs much better than the P16 as a IHC. So these are all the things that are now happening in different areas. Another thing that we have been working on is to look at the uninvolved lymph nodes. The uninvolved lymph nodes, typically we have never looked at the uninvolved node. We have always looked at the involved node as we always quantify how many tumor nodes are positive, what is the size of mets and things like that. What we have actually managed to show that the uninvolved node, the immune response in it, actually is predictive of outcomes in an independent manner, independent of TNM and known prognostic factors. So we are in the process of actually pushing this through a multi-institutional validation where we have taken an automated image processing pipeline and quantified these germinal centers as to the size, their shape, their area that they occupy and things like that, and come up with a prognostic score. Again, this as an example, this is not possible to do with the human eye. There are ways of quantifying each and every cell, and AI models actually get affected by variations in the data. So the artifacts in the image, in the glass slide, as pathologists, as humans, we often try to adapt to it. We are able to overcome many of those artifacts, but AI models do not do that by default. We have to make them robust to these artifacts. Even as an example, the same slide scanned on 2 different scanners can look different. So all of these factors do play a role. So we also have been building a lot of these automated tools to automate the quality control and identify slides which are of good quality versus bad quality, and there's something called cautious AI. We'll not go there. As the last few set of slides, the AI models are not only there in pathology or radiology, they're also there on the clinical side. So identifying clinical lesions which are have a high risk of progression or needs to be seen by a specialist oncologist or a specialist doctor who can take a biopsy is very important in the field. So if you have the healthcare workers going into the community and they're looking at these lesions, how do they identify which one they should send to or refer to a doctor versus or they can be followed up with simply telling the patient, okay, that you give up tobacco and things like that. So these are some tools being developed. This is work from Amit Sethi's team that is in IIT Bombay, but there are other teams also working in this area where they have taken photographs initially using DSLR cameras, then try to modify the models of the phone cameras. And what it does is essentially they have trained the model on a lot of data from Nair Hospital and some other hospitals. What it does is that if you can identify the lesion, and then the model can actually give a different probability of this being which kind of clinical lesion and which needs to be sent for the screening. So the accuracy levels are quite high, but then these are in controlled settings. To actually be clinically relevant, they have to be done in much more large scale studies in the public, on the field. A lot of things that are happening. You need large volume data to do all of this AI work. On an average, you need around 700, 800 patient information to really make a model which is even close to good accuracy, and you need a lot of images. There are public data sets available which anybody can access and start their work and do all of this. But then most of these public data sets are from the Western Hemisphere. There are a lot of issues that affect the model, as I've mentioned before. There are variations in the processing, in the glass slide preparation, in the digitization, as well as there are actual variation in the populations that get affected. For example, if we look at the lung tissues in our setup, in Indian setup, they are filled with carbon pigment for whatever lung cancer specimens we get. But if you look at the lung cancer specimens from the Western Hemisphere, they are very clean. They don't have any carbon pigment, they just have the tumor there. So the model gets affected by all of these things. So model gets confused when it sees things that it has not seen before. So we have been doing this kind of work. We have been actually collating longitudinal images, pathology, radiology images for head, neck and lung cancer, and now we have started doing it for other cancers as well. We have a few thousand patient data that we are started using for building the AI models and training. This is from a multi-institute setup. 90% of the data is still from TMC, but we do have some data coming in from AIMS, PGI, Chandigarh and Rajiv Gandhi cancer centers. There are a lot of problems with AI models. There's no time to go into the details of it. A lot of those problems are related to the data and the variation in the data that happens across different centers. But these are problems that are being solved with time and effort, and gradually this is where things are going. Most of the screening work and most of the diagnostic work is slowly going to be offloaded to the AI models, and then the pathologists and other people can focus more on actually using that information than actually decoding the information in the first place. Thank you.
Wonderful talk, Dr. Swapnil. It was amazing you took us from simple squamous cell carcinoma to AI models and understanding it very well. So looking forward to have such more sessions in MGM, and I think our pathology department can also get trained in AIs. It's really wonderful. It's an eye-opener for the pathologists. Thank you so very much.
Thank you very much for calling.
Good morning once again. Before we further proceed into the insightful lecture series planned ahead for us today, let us take a moment to invoke the blessings of Lord Ganesha and have a ceremonial lamp lighting before proceeding with the lectures. I would like to invite for the ceremonial lamp lighting respected Dr. Shivali ma'am, Dr. Usha ma'am, Dr. Galindya ma'am, Dr. Gauri Pantwaidya ma'am, Dr. Amit sir, Dr. Prashant Pawar sir, Dr. Swapnil Rane sir. Kindly place us with the occasion and please.
ओंकार गणपति गणपति अधिपति सुखपति चंदपति गंधपति लीन निरंतर हो लीन निरंतर हो सूर्य निरागस हो सूर्य निरागस हो गणपति सूर्य निरागस हो मोरया मोरया गणपति बाप्पा मोरया 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 गणपति बाप्पा मोरया गजवदना तू सुख करता गजवदना तू दुख हरता गजवदना मोरया 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 गणपति बाप्पा मोरया गजवदना तू सुख करता गजवदना तू दुख हरता गजवदना मोरया मोरया सूर्य निरागस हो सूर्य निरागस हो
With the blessings of Lord Ganesha and with the lamp lighting, may we ignite the wisdom and the success of today's further lectures and the conclave. I would like to welcome Dr. Gauri Pandvedya on stage. She needs no introduction, the HOD of Department of Head and Neck Oncology at Tata Memorial Hospital. Ma'am is a pioneer in the field of head and neck oncology, and she has to her name multiple international and national publications. It is a great privilege, ma'am, to have you here with us today, sharing this extensive knowledge that she has in the topic of neck dissection in oral cancer, current status and for future perspective. Please.
Good morning, everyone, and thank you very much for. Good morning, everyone, and thank you very much for inviting me here today. Wonderful planning, excellent program, and I like the fact that it is revolving a lot on surgical techniques in oral cancers. I want to extend my thanks to Dr. Srivali, Dean, respected seniors from MGM Medical College, and of course, if I thank Prashant, he may get angry, but Prashant, thank you very much for inviting me here. I'm not new to Navi, Mumbai. I'm an alumnus of D.Y. Patil, and then I started coming to Accredited, which is further, and I'm sure this is a sign of career progression that I'm coming even further now to MGM. I always wanted to come here, so thank you for inviting me. So my topic today is to speak on neck dissections in oral cancers, the current perspective and future directions. I'm not going to talk just on neck dissections, but overall on the management of neck nodes. I've been given 40 minutes. I'm not going to speak that long and bore you all. But the reason why actually this topic requires this kind of discussion is because it is very well known that a neck node metastasis is the single most important prognostic factor in head and neck cancers, oral cancers, all other cancers. Now, if you get a positive node in a patient, this trait decreases the survival of this patient by 50%. Recurrence and survival is also dependent on node metastasis. So therefore, it is very important for us to accurately stage and treat neck nodes. As surgeons who are looking at oral cancers, we spend a lot of time evaluating the primary lesion. We look at it clinically, we do CT scans, then we try to see whether the bone is involved, the infratemporal fossa, where is the nerve, and then we say, neck dissection we have to do. But that's not the way to do it. In today's age of personalized medicine, we have to look at which neck dissection you want to do. Do you want to do you not want to do a neck dissection? What is the extent of neck dissections? What are the levels of lymph nodes? So it's now more or less a more personalized way with which we do neck dissections. Now it's not just neck node metastasis which make a difference. Within neck node metastasis, you also have certain poor prognostic factors. Now, as you find these poor prognostic factors, that is the size starts increasing, you have more lymph nodes, you have the presence of extranodal extension, these cause a further decrease in the survival of these patients. So it's not just patient has a neck node or doesn't have, you have to quantify and qualify this neck node metastasis to be able to prognosticate well. Now, if you look at research on neck dissections for oral squamous cancers, in the last few decades, what has been seen is that there has been an exponential increase in the research that has been done on neck node metastasis. Now, the commonest areas, there are 4 common areas on which neck node metastasis research and literature has gone up. The first one is on the management of the N0 neck. The second one is in the role of adjuvant chemoradiation when you have a node positive patient. The third one is on sentinel node biopsies. And the fourth one is on the pattern on lymph node metastasis from oral squamous cancers. These 4 topics within neck node management have got a lot of research, lot of new avenues, lot of new things that have happened within this, and we're going to look at some of it. Before we start, always to look at history. History is what teaches us and can take us forward. If you look at the evolution of neck dissections evolved from very radical procedures to now a sentinel node biopsy. And what basically happened was, from high morbidity and disfigurement, we tried to reduce, personalize these neck dissections to help our patients receive a low morbidity of their neck dissections. A radical neck dissection was an extremely morbid procedure. Now we are trying to reduce, we are trying to find and personalize when we can do lesser and lesser without compromising oncological outcomes. Now the whole premise of neck dissection actually depends on this, which is called patterns of lymphatic spread. Each tumor, each subsite within the oral cavity has a different pattern of lymphatic spread. The 5 levels are the commonest levels where lymph nodes will spread from oral cavity cancers, as you can see over here. This is level 1, level 2, 3, 4 and level 5 are the commonest cases. In oral cancers, the commonest part within these 5 are level 1A, 1B, level 2. You also have metastasis to level 3 and 4, less common. Level 5 also has metastasis, but least common. Most commonly, you will have oral cavity cancers metastasizing to level 1 to level 3. Now, this is a bit of history. Now, when we talk about evolution of neck dissection, we talk about selective neck dissections, and we take it for granted, but it was not always very easy to actually reduce the type of neck dissections from a radical neck dissection to a selective neck dissection. This is a seminal publication in 1984 by Boca, where he first tried to put forth to people the advantages and the oncological soundness of doing functional neck dissection is more or less similar to a selective neck dissection. You can see what he wrote here in the first 4 lines of his paper. After 20 years, so this was published in 1984, it took 20 years to go from doing radical surgery to less radical surgery, something that we take for granted. After 20 years of fierce controversy between supporters and opponents of functional neck dissection, troubled waters have finally subsided and more surgeons are now prone to accept its basic concepts. You can imagine how difficult it was to convince someone to do something lesser, and that's probably because nobody wanted to do harm to a patient. He then has given all the thoughts and concepts on how a functional neck dissection has evolved, and today it's on this basis of the research and the work that they did that we can further do selective and super selective neck dissections. Then came the famous paper by Dr. Jatin Shah. This was published in 1990, where he looked at patterns of cervical lymph node dissections in 1,081 patients, of which 501 patients, this was a retrospective study, and found that in oral cavity cancers, the most common sites were in level 1 to 3. We then did a prospective study to further classify. We just knew 1 to 3. We wanted to know further what is the patterns of lymphatic spread, and we wanted to do it in a prospective manner. So what we did was we prospective looked at 583 patients. We took out nodal levels from 1 to 5, 1A, 1B, 2A, 2B. Stitches were taken, specimens were cut and sent. And what we found was similar to what Dr. Jatin Shah found, but with few more nuances. Lymph node metastasis, as we discussed, concentrated at levels 1 to 3. Level 2B, which was one of the areas which wasn't described before, had very low levels of metastasis. Similarly, level 4 and level 5 also had lesser incidence of lymph node metastasis. Overall, we found that in oral cavity cancers, 96% of metastasis will be restricted from levels 1 to 4. Now, there's this whole question of skip metastasis. For the students in the back, when you mean skip metastasis, what we mean is if you have metastasis to a level without there being any preceding metastasis, this is called skip metastasis. So generally you look at skip metastasis at level 3, 4 and 5. What that means is if you have a metastasis at level 3, you don't have metastasis at level 1 and level 2. Now, it has been known that there was a lot of skip metastasis in tongue cancers at level 4, Bob Byers' very famous paper. We did find a 7.3% skip metastasis at level 3, especially in tongue cancers, but we found no skip metastasis. This is a prospectively done study. We found no skip metastasis at level 4 and 5, which meant if you had metastasis to level 4 and 5, they will always be associated with metastasis elsewhere. Now, with this background of lymphatic spread and the evolution of neck dissection, we'll go into the actual management of the neck in oral squamous cancers, and I'm going to talk in two ways. One is on the N0 neck and one is on the node positive neck. Now, let's look at the N0 neck. The issues here are multifold. First is about the imaging modality. What is the imaging modality? And I think Amit may have covered this, but what is the imaging modality that's the best for calling something N0? You clinically palpate a patient, you want to know if this patient is really N0. Ultrasound, CT scan, MRI, all of them are available. Once we know whether we should treat the neck or not treat the neck, and if we have decided to treat, how much to treat the neck. With regard to imaging, we have two studies from TMH. Ultrasound was very popular and it is still very popular for staging of the neck, but we found that in both our studies, we didn't find a great the benefit of using ultrasound. The sensitivity specificity was not very good, and probably ultrasound can be used as a problem solving tool rather than the main tool. The other issue with ultrasound is, now if you look at these patients, all these patients are clinically node negative. But each of these patients has a different type of tumor, and in all of them, you would require some imaging of the primary. So are you going to do another ultrasound for these patients, or can you use a CT scan or an MRI? So if you look at radiology, ultrasound is operator dependent, requires expertise. A CT scan, which is the workhorse for the primary tumor, is a good tool even for finding out whether there is an N0 neck. And MRI also, and it has multiple new images, new sequences that are also available. So this thought that MRI is not good for neck nodes is incorrect. It also has a good accuracy. So you don't need to do any added ultrasound in these patients. Whatever imaging you're using for the primary is good enough to classify. Now, in spite of doing good clinical examination, doing good radiology, what you find is that there is a group of patients whom we think is N0 but is actually not node negative. 20 to 30% of these patients harbor what we call as occult node metastasis. That is, they are not clinically or radiologically evident, but if you do a neck dissection, you will have node metastasis. And that is why this question on whether you want to treat the neck or don't treat the neck comes. In 30% of patients, you're going to be good if you do the neck dissection, but in 70% of patients, you're going to overdo a neck dissection when the patient does not have metastasis. Which is why we come to this question on, do we treat an N0 neck or we don't treat an N0 neck? Because you feel you're going to do 70% unnecessary neck dissections. However, this is not true. We have more or less left this we have solved this controversy. The problem is you can't make out who is in the 70 and who is in the 30. So if you don't do a neck dissection for those 30% people, it is going to lead to a whole lot of problems. This is our very famous randomized trial that was published in the New England Journal of Medicine, where we found if you do an elective neck dissection versus the wait and watch, there is a significant difference in the survival. You will be having more deaths if you don't do an elective neck dissection. We found this across all subgroups of patients. The only place where we found that there may have been an issue is if you have very fine, thin tumors, then maybe in them elective neck dissection did not seem to have any improvement in survival. Now the minute we published this, so this paper said we must do elective neck dissection in all patients, even if they are N0 clinico-radiologically, because it saves lives. The question came, what do you do when you have such thin tumors? Now you can barely see this tumor. This is a very superficial, thin tumor. You know, you feel like taking this patient into your minor operation theatre, just removing this primary tumor. Why do we have to subject this patient to an entire neck dissection? So the question was asked, in very superficial thin tumors, can we avoid elective neck dissection? I must say that this remains an unanswered question, and this is because there is differing definitions of what you call thin. We definitely know as the depth of invasion increases, lymph node metastases increase, but nobody can say if it's 3 millimeters, some say 2 millimeters, some say 4 millimeters, so we don't have a correct definition of what is a thin tumor. Secondly, there were very few less than 3 millimeter tumors on any of the clinical trials, so we cannot take help from literature on this. Depth of invasion may vary among pathologists between 2 millimeters and 3. One pathologist may say 2 millimeters, one will say 3. Now, do you do a neck dissection or do you not do a neck dissection? And if you stage this, you do the primary, you may have to put the patient through 2 surgeries. So as of today, because there are so many unanswered questions with regard to these thin tumors, except for particular cases, in most patients, we should go ahead and do an elective neck dissection, even if you find a small tumor, which is depth of invasion is less. And this was proven by another very large randomized trial, which is known as the SEND study, which said that even if you had T1 tumors and tumors less than 3 millimeters, elective neck dissection was better than wait and watch policy. So, more or less, for all tumors of the oral cavity, even if you are node negative clinico-radiologically, except in very exceptional circumstances, you must go ahead and do a neck dissection. It saves lives. We then come to the next question, okay, you want to do a neck dissection, what is the extent of neck dissection in these patients? The premise in these patients is not to cure anything, it is basically to cover the levels which are at risk for occult metastasis. And we have to do this in an attempt to decrease shoulder morbidity. And the surgery of choice is a selective neck dissection. We now do selective neck dissections from a single skin crease incision. We put it on the skin crease that 2 centimeters, 1 centimeter is something that's of the past. We put it on a single skin crease. You can increase the skin crease anteriorly, posteriorly, depending upon, you know, if you're unsure if you're going to reach the level 1A, and do a selective neck dissection. You generally do, there are 2 types of selective neck dissections, a level 1 to 3 or a level 1 to 4. Skip metastasis to level 4 in tongue cancers is not proven. It does not exist. You don't need to add level 4. Also, when you try to do level 4 clearance, it increases the incidence of chyle injury. So as of today, if it is a node negative neck, irrespective of what the primary is, you may have a T4 and 0 also, you don't need to do more than a selective neck dissection 1 to 3 or maximum a level 1 to 4. Now, in spite of doing this selective neck dissections, if you look at the shoulder morbidity, even patients with selective neck dissection have significant shoulder morbidity, and this is because of the handling of the spinal accessory nerve. And keeping this in mind came the concept of sentinel node biopsy for node negative patients. Now, sentinel node biopsy, it was commonly done for breast cancer and melanoma. It's a minimally invasive procedure done for early tumors, T1, T2, N0 oral cavity cancers, where you use a technetium nanocolloid radiotracer, and it allows the surgeon to identify and excise targeted upper echelon nodes. If the sentinel node is positive, you go ahead and complete the neck. If it is negative, you avoid a neck dissection. And it is somewhere like bridges the gap between both diagnosis and treatment of N0 necks. Now this is what is the algorithm for sentinel node biopsy. Oh sorry, this was where it was initially done. And this is one of the earliest articles from Sandro Stockley's group, which was used to use isosulfone blue, and this was reported in 1998. So it's not like sentinel node biopsy is something new, it has been researched over many years. You need a lot of infrastructure, surgeon, nuclear medicine, pathology, radiology, lot of money, enthusiasm. You have to have SOPs, quality assurance, and analysis of your results before you can start using it in practice. What do you do in a sentinel node biopsy? What you do is first you do a primary resection and you do a sentinel node biopsy. You pick up these nodes, and I think there's a video later on so you can see the exact procedure. If it is positive on frozen section, then you do a completion selective negative. If it is negative on frozen section, then you close the patient, shift the patient out. These nodes are then subjected to serial step sectioning, immunohistochemistry. If they are negative, you do nothing. You have just picked out 3 nodes in this patient or 4 nodes in this patient. You do nothing else. You observe this patient and the patient is kept on a follow-up. If, however, this IHC is positive in the pathology, the patient has to be taken back into surgery, and 2 to 3 weeks later, you do a completion neck dissection. So this is the actual algorithm of sentinel node biopsy, and this is therefore called sentinel node biopsy directed elective neck dissection. It's never just a sentinel node biopsy. Some advantages and disadvantages. It's really a minimally invasive technique. If you compare a sentinel node biopsy versus a complete selective neck dissection, it is really a minimally invasive technique. You don't damage many structures. There is very little lymphedema. It's a small scar, and maybe these patients have better shoulder function. The disadvantages are the biggest problem is the infrastructure, the cost, the learning curve, and need for extensive pathological evaluation. This, according to me, is the one step that really puts people off from doing sentinel node biopsy. It's a difficult pathological evaluation that you need to know. And in around 8 to 12% of patients, if it comes positive on pathology, you need to take the patient back onto surgery for a second surgery. So you have a second surgical procedure. Now, 3 trials, the SEND study, which was a multicentric prospective EORTC group study, the Senti-Meroral study, which was a phase 3 multicenter randomized trial from French collaborative group, and the Japanese study. These were 3 studies which said that both sentinel node biopsy guided neck dissection versus doing elective neck dissection in patients is equal as far as oncological outcomes are concerned, which means that you will be safe if you have perfected your technique of sentinel node biopsy. You will be safe doing sentinel node biopsy plus neck dissection as compared to doing neck dissection alone. Here is a little bit of a snapshot of the tumors that you have to select if you want to do a sentinel node biopsy. Most of them are T1 tumors. Most of these patients should not be requiring reconstruction. It's very difficult to do reconstruction and then go back in and do an elective neck dissection. And none of these patients should have received previous treatment. So you have to select your patient very well for a sentinel node biopsy. There has been some flaws in the evidence for sentinel node biopsy, issues with underpowering of studies, cost effectiveness, use of reconstruction was not well defined, good evaluation of shoulder morbidity was not available, and we have an ongoing randomized trial that will tell us the reason we are doing a sentinel node biopsy is basically for only one reason. We want to prevent shoulder morbidity, which I showed you is present with selective neck dissection. But that has not been well proven. We hope that this randomized trial will help us with that. So I'm going to summarize management of the node negative neck. As of today, with the available literature, and the amount of lives that you can save for all patients, T1 to T4, small, thin, big, buccal mucosa, tongue, every subsite, it is safer to do an elective neck dissection in these patients. A selective neck dissection is adequate no matter what the T size is. You can do a 1 to 3 or a 1 to 4 if you have the expertise. A sentinel node biopsy may be a good option for early cancers, but requires good patient selection, infrastructure, and really good multidisciplinary expertise. Let's go to management of the node positive neck. We would think it's not that complicated. If you have a node, you have to remove it, but we are good at making everything complicated. So if you have a node positive, of course you need to do a neck dissection. What are the principles? Generally, the gold standard is to do a modified neck dissection, which involves levels 1 to 5. You have to spare as many non-lymphatic structures like the spinal accessory, the internal jugular vein, and the sternocleidomastoid. Excision of these structures have to be done only if they are involved. The radical neck dissections, we rarely do any radical neck dissections anymore, and they are only for very large N3 nodes. This is typically how a modified neck dissection looks. And as of today, we take a single horizontal skin crease incision even for level 1 to 5 neck dissection. This can be extended up to the midline if you don't have a primary resection to be done. And you can do even level 5 with this single incision. Now, in a modified neck dissection, because you are doing 1 to 5, even more issues with shoulder syndrome. You can have pain, limited abduction, limited external rotation, disfigurement, drooping. It is a genuine problem. And there are certain strategies that have been seen to try and decrease this morbidity. Now, understand we are dealing with node positive patients where we are supposed to do levels 1 to 5. Now, there are two strategies that have been tried to decrease this. One is, instead of doing a modified neck dissection, can we do a selective neck dissection even in node positive patients? And two is, can we avoid dissection of level 2B and level 5 because the spinal accessory nerve traverses to level 2B and level 5. So two strategies have been attempted to try to decrease shoulder morbidity even in a node positive patients. So let's look at selective neck dissections. Now the question is, can a selective neck dissection be performed in node positive patients? We used it for node negative patients, and is it oncologically safe? Does it decrease the rate of shoulder dysfunction? And should you do an SND 1 to 3 or an SND 1 to 4? Now generally, if you have a node positive patient, most will prefer to do a selective neck dissection 1 to 4 so that 96% of your metastases are going to come out if you do a 1 to 4 rather than a 1 to 3 which we employed for a node negative neck. If you look at the literature on selective neck dissection with regard to its oncological safety, there is no level 1 evidence. Most studies are retrospective, they are small numbers. And shoulder dysfunction rates, unfortunately, the reason for which we want to decrease doing level 5, level 2B are rarely actually documented. Now here is a meta-analysis, 5 retrospective studies, 443 patients, oral squamous cancers, all were node positive. 210 underwent a selective neck dissection, 233 underwent a modified neck dissection in this. What they found was overall mortality. There was good outcomes when you did selective neck dissection along with adjuvant radiotherapy. There was no difference in neck recurrence, overall mortality or disease specific mortality. These are all node positive patients, and you should tailor the extent of neck dissection depending upon the levels involved. So in N plus patients, there seems to be in retrospective data comparable recurrence rates between SND and MND. It can be used in low volume nodal positive disease, that is N1 or N2. If anything is above N2, you should not use a selective neck dissection. If you have lymph nodes that are level 2 and down, don't use a selective neck dissection. You must do a gold standard modified neck dissections. If you have extracapsular spread, you may have issues. So if you have a small node at level 1B but extracapsular spread, you may want to do a proper modified neck dissection. And if you're doing a selective neck dissection, in most cases, because it's node positive, you would give radiotherapy, but it is mandatory that you give radiotherapy if you're doing a selective neck dissection, because the best results have been found in selective neck dissection when they have been associated with radiotherapy. Now the second strategy. The first strategy, yes, you may do selective neck dissection to decrease morbidity. The other one is, can we avoid dissection at level 2B and level 5? And this was again comes from our study which we did, where we found 96% of metastasis from oral cancers were at level 1 to 4. Level 2B was in a smaller group of patients. We tried to look at what predicts when you have metastasis at these two levels where the spinal accessory nerve has to be dissected. And we found that if you have level 2A metastasis, this significantly predicted presence of level 2B metastasis. So what this means is, that if you do a level 2A analysis, that is you send it for frozen section and it's negative, and you have other features which don't suggest that this patient has any other metastasis, you may consider not operating on level 2B and level 5 because this is a strong predictor. This has similarly been seen in another study from our country by Dr. Deepak Sarin's group, where they found that the level 2B metastasis was very low. It was only in 2 patients, and in both these cases, these were associated with 2A metastasis. This has been proven many times that level 2A, it's almost impossible to have a level 2B metastasis without a level 2A metastasis. So if you can analyze a good level 2A metastasis, then you may try to avoid doing resection at level 2B and level 5. To summarize management of the N plus neck, SND 1 to 4, that is doing less than a modified neck dissection, may be adequate for most oral cancers which have low nodal burden. It is important, you can't, if you have larger nodes, I'm saying this again and again because the gold standard is to do a complete modified neck dissection. The results are poor in the presence of extracapsular spread, and adjuvant radiotherapy should be part of the treatment algorithm. However, there is no level 1 evidence on the oncological safety of doing selective neck dissections or whether it decreases shoulder dysfunction. Level 2B can be avoided if there are no 2A metastasis. Again, there is no level 1 evidence available for the oncological safety of this strategy, and if you don't have frozen section, you're unsure, it's just better to clear the level 2B and level 5. Modified neck dissection remains the gold standard for multiple nodes, lower nodal levels, and presence of extracapsular spread. I'm going to end my talk by talking a little bit about the future perspectives. Now, first I will talk about extent of neck dissection. Now, there is lots that we need to do. One is we have to try to improve our indications for contralateral neck dissections. There's not a lot of research done in this. We have this coming to midline. We are not sure when to do a contralateral neck dissection, and that's one area of research where we have to look at it. We have to expand the use of selective neck dissection 1 to 4 because a lot of retrospective data says it is safe, and unnecessarily we end up doing level 5 because we are unsure, we don't have good quality of evidence. Can 2B and level 5 sparing neck dissection replace a sentinel node biopsy? Now this is something that is close to our heart. Doing a 2A analysis and doing level 2B, level 5 was first described by us from our institution. We are also doing sentinel node biopsy. We find it very difficult for other institutions, even within our institutions, to implement sentinel node biopsy. So can we really avoid doing this expensive procedure of sentinel node biopsy? Here is an ongoing non-inferiority phase 3 randomized controlled trial. Dr. Richa Vaish is the PI of this trial, where what we are doing is we are looking at patients with early oral cancers, and they are going to be randomized to sentinel node biopsy guided versus what I described to you, which is the 2A analysis guided neck dissections, and we are going to look at the oncological outcomes. And we are also going to look at our shoulder dysfunction rates. So if we find that just sparing the level 2B and level 5 is going to give you good decreased shoulder dysfunction rates, then we don't need to spend a lot of money on our sentinel node biopsies. This may be a better option to go, and this is something the randomization is ongoing. Now with regard to sentinel node biopsy, lots that is going to come in sentinel node biopsy. There are going to be newer, easier tracers. We have to look at doing research to try to show that sentinel node biopsy actually decreases shoulder morbidity. Detections of contralateral nodes in sentinel node biopsy is said to be one of the greatest advantages of sentinel node biopsy. You know, we never know when there is a lymphatic spread on the other side. Swapnil spoke a little bit about this on preventing immune depletion. That is, tumors in patients in whom you leave back more lymph nodes. There is more and more data coming to say if you leave back these lymph nodes, patients have better survivals. And this is called prevention of immune depletion. If you do a sentinel node biopsy, you're only removing 3 lymph nodes as compared to an elective neck dissection. This will prevent immune depletion and may improve the outcomes. There is a lot of research that needs to be done. We are not going to translate this today and say, oh, do only half a neck dissection because you want to leave back nodes. We have no data for this. This is something only for the future. The other thing that we are looking at Tata Hospital is looking at mapping of lymphatic pathways using sentinel node biopsy in recurrent cancers. This is the ongoing first in the country pilot study. The PI is Dr. Vidisha Tuljapurkar. In these patients, what we are trying to look at is when you have a recurrence on one side, we generally tend to do contralateral lymph node dissection. Is it really necessary? Is it not necessary? And we are trying to map how recurrent tumors have their lymphatic pathways by using the sentinel lymph node dissection. So these are 2 or 3 of the avenues, lot of future perspectives in lymph node management in oral squamous cell cancers. The future is bright for all of us. I'm going to end by inviting all of you all for our conference. This is a conference we hold every year. It's a very, very well planned program. This year we are going to talk about a lot of very important issues on how do you manage patients after you operate them for locally advanced tumors. We have a lot of complications, suturing of flaps, we have a cadaveric dissection course. So I invite all of you all for our conference. I hope to see all of you all there. And once again, thank you very much for inviting me for this talk. Thank you.
I would now like to welcome our beloved Dean, Dr. Srivalli Natarajan Madam, also the HOD of Department of Oral and Maxillofacial Surgery, ma'am, to share a few thoughts on the program and the conclave that we have aligned today. Welcome, ma'am.
A very good morning to the esteemed speakers for today, my colleagues, the postgraduate students, the other delegates, undergraduate students. I know Madam is looking at me, the clock is ticking. But I'll be failing in my duty, Madam, if I don't thank you and the entire TMH team. I think it's been an amazing start. So when we thought of planning this workshop, we were just thinking, we certainly knew that we wanted to do something in oral cancer. Then we thought, let's make this conclave end to end, from beginning to start. Beginning to end, and involving all the disciplines. And I think the first 3 lectures, thank you, Prashant sir. He was the lead in actually putting this thing together. He was the guiding light, I would say. And I think the first 3 lectures from Dr. Amit, Dr. Swapnil, and of course, Madam, I think it was absolutely perfect. They did the job from basics, right from definition to anatomy, put their vast experience in a nutshell to all of you. I think for the postgraduates, their lectures answered paper 1, paper 2, and paper 3. It went from anatomy to surgery to, you also had the recent advances. I think a big round of applause from, there are a lot more lectures to come, but I think it was an amazing start, Madam, and thank you to the whole team, and thank you, Prashant sir, and the chairpersons, Dr. Ujjwala, for really being here. So I welcome you all to this conclave. Oral cancer for the undergraduates sitting behind. I think India can be proud of hosting 1/3 the global burden. The 2022 statistics show that we have about 77,000 new cases being added every year with 52,000 deaths annually. So it is a kind of an epidemic in our country. Every day we are losing fathers, mothers, brothers, and sisters to this disease, which is very much preventable, detectable, and treatable only if we act on time. I think all the research was talking about it, about the depth of invasion and how many nodes are getting involved. So it all is a direct correlation with the time. So India has the highest burden of oral cancer, but despite having the highest burden, we see our patients very late. That's the irony. So getting this disease under control in this country has its own set of problems, limited resources, late diagnosis, financial constraints, and a pressing need for awareness. So in every challenge, of course, there lies an opportunity to educate, to innovate, and to build a future where early detection and the best of treatment are not just privileges but rights accessible to all. So Tata Memorial Hospital, we are very proud and we bow down to the exemplary service. You see that all their lectures touched just not the core science but also the research, also future, and also about public health. So they are literally a model institution. So it is very much feasible despite the volumes and numbers. You can see the meticulous way in which they are handling this disease, and that's the need of the hour. We need to learn from it. They are making cutting-edge cancer treatment accessible to thousands of patients, no doubt, wonderful. But I think we all also have to help them. So MGM Dental College and Hospital, backed by an extremely proactive management, along with our dedicated oral and maxillofacial surgery department, has also played a very spirited and crucial role so far in battling this disease. So over the years, we have also successfully completed a fairly good number of patients, performed some very good surgeries with good outcomes, and ensured post-operative rehabilitation to improve the quality of life. So today I am proud to announce that we are taking this commitment further. There has been a signing of a memorandum of understanding between the MGM Dental College and Accredited for establishing a center of excellence at this institution dedicated to oral oncology. So this initiative will not only strengthen our capacity to treat this disease, but also pave the way for advanced research, interdisciplinary collaboration, and skill development for all the healthcare professionals. So we're going to grow as a team under the guidance of TMH and Accredited. So as we gather here today, let us reaffirm our commitment. I think every single dentist here, last week we had Dr. Pankaj Chaturvedi here. He said, if you're going to look for specialists to come into your team and run this center, it's going to be a big no, it's not possible. He said, you have to run it with. So from today, our interns are also getting posted at Accredited in this regard. So the MOU is already in action. Our PGs are already there. We are already trying to put together things and to battle this disease with renewed vigor and dedication. So it is only through collaboration, innovation, and persistent efforts that we can make a tangible difference, let me tell you, in the lives of all these patients. So I once again extend my heartful gratitude and thanks to this amazing galaxy of speakers for today, the experts from Tata Memorial and Accredited, and the delegates who have joined us today. So let us all work together to advance oral cancer care, ensure better patient outcomes, and shape a healthier tomorrow and a healthier India. Thank you very much.
Thank you very much, Dean Ma'am, for the comprehensive insight about and the information about the conclave today. I would take this opportunity to invite our chairpersons, Dr. Prashant Pawar sir and Dr. Ujjwala Maheshwari ma'am, to felicitate our speakers of the first session. And I would request Dr. Srivalli ma'am to please join us on stage with them.
Gauri madam just wants to say something.
I think I really echo what you said, and I'm so happy you said what you did. And I must tell you that we have complete cooperation with you with regard to TMH and Accredited to help you in whatever. Please do just pick up the phone and call us up if there is something that is worrying you, something that you want to do. You have our full support. So it was wonderful for you to the way you put it across. Thank you.
I request our chairpersons to kindly felicitate our first speaker of the day, Dr. Amit Janu sir. Sir, please join us on stage.
Thank you very much. I look forward to more detailed sessions from you.
Thank you, sir. I invite Dr. Usha ma'am on stage as well to felicitate our next speaker, Dr. Swapnil Rane, sir.
Absolutely amazing. So lots to learn. We would like to have some regular interactions.
I now request Dr. Gauri Pantvedya ma'am to kindly accept a token of appreciation and thank you for the lecture, ma'am. I now invite Dr. Galinde ma'am and Dr. Usha ma'am to felicitate our chairpersons of this session, Dr. Prashant Pawar sir and Dr. Ujjwala Maheshwari ma'am. I request Dr. Galinde ma'am to felicitate Dr. Prashant Pawar sir. Okay. Dr. Ujjwala Maheshwari ma'am. For a valuable time and moderation of our session. Thank you, ma'am. Today's conclave, the video presentation sessions, and for the first session, that is on the topic of neck dissection techniques, including conventional approach, posterior approach, sentinel node biopsy, endoscopic neck dissection, and complications, a wide array of topics. To moderate this session, I would like to invite on stage Dr. Yogesh Kini sir and Dr. Kalpana Kumar ma'am. It is my pleasure to introduce Dr. Yogesh Kini sir. Yes, sir. He's a esteemed chairperson for the first session as the professor of the Department of Oral and Maxillofacial Surgery with a wealth of knowledge and experience in oral and maxillofacial surgery, advancing scientific research and fostering innovation, making a significant impact in the field. We are honored to have him today as a moderator. I also would like to extend a warm welcome to our second chairperson for the day, Dr. Kalpana Rajiv Kumar ma'am, a renowned otorhinolaryngologist with over 25 years of experience, professor in the Department of ENT with MGM Medical College and Hospital. Her extensive expertise in otorhinolaryngology and her dedication in advancing both clinical practice and medical research makes her a wealth of knowledge for this conference. We are honored to have your guidance here today, ma'am. Thank you. For the first video presentation on conventional neck dissection, I would like to extend a warm welcome to Dr. Vidisha Tuljapurkar, Associate Professor, Department of Head and Neck Surgery at Tata Memorial Hospital. Welcome, ma'am.
We'll check the video. Call a mic. I have a voiceover on the video. Okay, good morning everyone.
This is a video of left neck dissection.
I don't need a mic.
For a carcinoma left.
Just a minute. I don't need a collar mic.
Okay.
रिकॉर्डर है,
Just a recorder. वो YouTube live.
ये ऊपर है, अंदर से लगाइए.
Okay. इस पे लगा सकते हैं. This is okay. Okay. Good morning everyone. At the outset, I'd like to thank Chairpersons Dr. Shivalli and all the organizers for this kind invitation. This is a wonderfully arranged program. So as with the before lecture, the previous lecture by Dr. Gauri, we have understood that the neck management is a very important part of managing all head and neck cancers. And as you will come to know, there are various ways of doing a neck dissection in subsequent videos. But doing a conventional neck dissection in a proper manner is the most important thing a head and neck surgeon can learn. And being well versed with the anatomy and being proficient in doing a conventional comprehensive neck dissection is one of the most key aspects that you have to learn as budding head and neck surgeons. So this video has a voiceover, I'll let it play. If anybody has any questions, they can come back to me with this.
This is a video of left neck dissection for a carcinoma left vocal mucosa T2N1M0 in a 32-year-old male patient. In this case, we have performed neck dissection level 1 through 5, preserving uninvolved non-lymphatic structures such as IJV, spinal accessory nerve, and the sternocleidomastoid muscle. Various incisions such as McAfee, lateral utility, and Schrödinger have been described for neck dissection. In this case, we have performed neck dissection through a single horizontal synchronous incision. The incision is deepened through the skin and the platysma is incised at the same level. The subplatysmal flaps are raised superiorly till the lower border of mandible, inferiorly till the clavicle, and posteriorly till the anterior border of trapezius muscle. Neck dissection starts at level 1A, where all fibrofatty tissue and lymph nodes in the submental triangle are removed. The submental triangle is formed by two anterior bellies of the digastric muscle and the body of the hyoid. Apex of the triangle lies at the mandible and the base is formed by the mylohyoid muscle. Next, level 1B or the submandibular triangle is bounded by the anterior and the posterior bellies of the digastric and the lower border of the mandible. It contains the submandibular gland and 1B lymph nodes. To begin the dissection, common facial vein overlying the digastric muscle is identified and ligated. The anterior and the posterior bellies of the digastric muscle are delineated and the submandibular gland is reflected superiorly. The facial artery is identified entering the submandibular gland just behind the conjoined tendon where it is ligated. The marginal mandibular nerve is identified along the lower border of mandible by incising the fascia over the submandibular gland. Its course is traced with careful dissection as it crosses over the facial vessels. The nerve is reflected superiorly by ligating the vessels, taking care to avoid thermal or traction injury during the ligation. Perifacial nodes may be present around the facial vessels, which must be carefully dissected and removed. Clearance of level 1B begins at the apex between the digastric and the lower border of the mandible. We may encounter the submental branch of the facial artery here, which needs to be cauterized. The fibrofatty tissue and the lymphatics in the submandibular triangle are cleared. The mylohyoid muscle is then retracted to visualize the lingual nerve, the submandibular ganglion and the submandibular duct. Submandibular gland is released by sharply incising the ganglion after ligating the duct. The hypoglossal nerve that lies next to the submandibular duct must be preserved carefully during this step. Next, we begin dissection of level 2 and 3 group of lymph nodes. Here we delineate the superior border of the omohyoid muscle, inferiorly till its crossing over on the IJV, and superiorly till the hyoid. The sternocleidomastoid muscle is opened along its medial border, exposing the carotid sheath and jugular group of lymph nodes.
These are the small branches of sternocleidomastoid that we need to take care of, either clip or bipolarize them carefully.
The level 2 is bounded superiorly by the C2 vertebra, posteriorly by the sternocleidomastoid muscle, and inferiorly by a horizontal plane passing through the hyoid. The spinal accessory nerve is identified at the junction of upper 1/3 and lower 2/3 of the sternocleidomastoid muscle. It is traced till its crossing over the internal jugular vein, where it passes under the posterior belly of the digastric muscle.
So identifying the digastric is also one of the most important steps that you have to do in the start of the neck dissection. It will give key to a lot of landmarks in your neck dissection. If you are beginning from anterior to posterior in this video, there are multiple ways of doing it.
Fibrofatty tissue and lymph nodes in level 2 and 3 are removed by staying dorsal to the carotid sheath, thus preserving the great vessels. Identification of ansa cervicalis can serve as a useful landmark in this step. Lower limit of level 3 is defined by crossing of the inferior belly of omohyoid over the internal jugular vein. While removing the lymph nodes at level 2, it is important to define lateral border of IJV completely. The angle between the IJV and the spinal accessory should be cleared meticulously to remove all tissue in this corner.
There are a lot of lymph nodes in this area which we should not leave behind with the fear of damaging nerve or the IJV.
One should watch out for the knuckle of internal carotid artery that may pass lateral to the border of IJV and is prone to injury while dissecting level 2 lymph nodes. The fibrofatty tissue is removed a block, preserving the prevertebral fascia underlying cervical nerve rootlets and ansa cervicalis. Level 2B or submuscular recess is bounded anteriorly by the spinal accessory nerve, superiorly by the posterior belly of the digastric, and posteriorly by the sternocleidomastoid muscle.
So this is.
The spinal accessory nerve may be accompanied by a vein which needs to be clipped or bipolarized in this step. One must be careful to avoid retraction or close cauterization to avoid injury to the nerve.
So here please avoid putting vein loops and giving traction to the nerve to preserve the function of the nerve as much as possible. Don't use monopolar cautery close to the nerve.
The level 4 contains several critical structures such as the phrenic nerve, thoracic duct and transverse cervical artery. For the level 4 dissection, inferior belly of the omohyoid is freed from the carotid sheath and is retracted inferiorly. The fascia and tissue anterior to the IJV needs to be cleared as it may contain lymph nodes. A large thoracic duct may be seen in few cases and all lymphatic ductules must be secured meticulously to avoid the complication of chyle leak.
So one tip for doing level 4 is that when you are doing level 4, please come from lateral to medial. As we showed in the previous step, you are freeing everything from the sternocleidomastoid. From we are coming lateral to medial, you will encounter the artery first, transverse cervical artery first. And if you stay above the transverse cervical artery and don't go into the confluence of IJV and the transverse cervical, you are less likely to injure the chyle duct. So that's one of the pointers that you should remember. The common mistake that we often do is we first go close to the IJV, try digging it in the corner of where you will find the chyle duct, and in that dissection you are likely to damage the chyle and get a chyle leak. So if you come from lateral to medial, you will have the fibrofatty tissue in your hand, you will find the transverse cervical artery as we will see here, and then you can go into the angle, clip everything individually and then get all the fibrofatty tissue. That will reduce your rate of chyle leak.
Carefully to remove the specimen.
So here we are seeing the transverse as it will come here.
Here we can see the transverse cervical artery, the thoracic duct and the phrenic nerve at the end of the dissection. The posterior triangle is formed by the posterior border of the SCM, anterior border of the trapezius and inferiorly till the clavicle. It contains level 5 lymph nodes, cervical roots and the spinal accessory nerve. Here we can see the external jugular vein and the greater auricular nerve in the posterior triangle. The spinal accessory nerve can be identified at the Erb's point, which is about 1 cm superior to the exit of greater auricular nerve. The entire course of the nerve is traced till its entry into the anterior border of the trapezius muscle. Careful dissection is performed using bipolar cautery and sharp dissection in this step, and the lifting of nerve from its bed is avoided to prevent devascularization.
So another tip here is you will find many nerves in this area, and you might think that something is a spinal accessory nerve, but please don't believe it till you have traced the entire course, because there are a lot of other nerves such as transverse cervical nerves, branches of the supraclavicular nerves, which you might mistake as a spinal accessory nerve, and in the end you will end up damaging the true spinal accessory. So whatever you deem as a spinal accessory nerve, please trace the entire course till its entry into the trapezius, and then only cut out the other rootlets if you are going to cut the transverse cervical branches.
Fibrofatty tissue is removed inferiorly till the transverse cervical artery to complete level 5 dissection.
Here again the same principles. Don't skeletonize the nerve 360 degree, don't lift it up from the bed, do not put nerve hooks on the spinal accessory nerve to clear the fibrofatty tissue.
Nerve, the transverse cervical artery and the supraclavicular nerves in the posterior triangle.
So here we have to clear the fibrofatty tissue which is above the transverse cervical artery. Anything that is below, it is a part of the supraclavicular fossa which continues with the axilla. So the lower limit of your level 4 is going to be the transverse cervical artery. And in cases where there are extensive nodes, you may end up resecting these supraclavicular nerves as well. So that is why when you are resecting these supraclavicular nerves, please identify your spinal accessory in the entire course. Once you have identified the spinal accessory nerve and the transverse cervical artery, everything else above is a part of your neck dissection specimen.
Anteriorly, we can see the internal jugular vein, internal and external carotid artery, hypoglossal and spinal accessory nerves.
So at
This
the
is
end
a
of
video clip showing chyle leak during left level 4 neck dissection.
this is from a different case.
Clear fluid can be seen oozing from the area of thoracic duct while giving positive pressure ventilation. Area of leak is identified using fine forceps. It is cross-clamped and ligated. Absence of chyle leak is again confirmed by giving positive pressure ventilation.
So you may use
At the
various
end of
methods.
surgery, adequate hemostasis is ensured and the incision is closed in layers over suction drains.
So for controlling chyle leak, you may use different methods. You may do bulk ligation, you may use clips, or some people may oversew the area. So the pointer will be to identify the site of leak. Just doing a bulk blind cauterization or blind clamping may endanger smaller vessels and increase your chyle leak rather than reducing it. And if you have controlled it adequately in the neck during surgery, that is the best way to prevent a postoperative chyle leak. Relying on the fat-free diet and everything, these are supportive measures, but identifying a chyle leak during surgery and controlling it adequately is the most important thing, is we need to remember. I thank you for your attention. If there are any questions, please, I'd like to take those.
Right side.
Thank you very much, ma'am, for such a clear and descriptive video presentation along with your valuable tips as it went along at each level of dissection. Moving further to the next video presentation, we have on posterior approach in neck dissection by Dr. Arzu Salia, consultant head and neck oncology surgery.
Good morning, everyone. I'm Dr. Arzu Salia, an alumni from MGM Medical College, Kamote. I feel very proud to stand in front of you to address this video presentation today. Thank you, team, for inviting me. We'll be looking at posterior approach neck dissection. This is just a different way of doing it and not a different procedure altogether. We'll be approaching the neck dissection from the posterior triangle first, and then we'll be going to the anterior levels. So the video that we'll be looking at is of a type 3 modified neck dissection from the posterior approach. The incision we have used is the horizontal skin crease incision. This is the skin crease that we have used for this surgery. We'll first start with raising the subplatysmal flaps, that is the platysma. We have to stay close to the platysma while using the cautery. Identify our external jugular vein, sternocleidomastoid muscle, and the greater auricular nerve. We raise the posterior skin flap. What we have to remember here is there is no guidance of the platysma, so we have to make sure the skin flap is not very thin. After that, we go ahead and identify our spinal accessory nerve first. Like ma'am already has mentioned, we have to trace the nerve entirely till the entry point at the trapezius. That is at the Erb's point where we identify our spinal accessory nerve. These are the landmarks. Now we start with dissecting our posterior triangle. Here we'll be starting by taking all the lymph nodes and fibrofatty tissue, staying close to the sternocleidomastoid muscle. We identify our internal jugular vein. We identify our omohyoid, and then we ask the assistant to retract the omohyoid and then continue with our dissection. First, we completely bare the posterior border of the IGV. Since this is on the left side, we have to be mindful about the thoracic duct and at the entry point. We stay above the prevertebral fascia and preserve all the cervical roots. Here we are going to ligate the external jugular vein at the lowermost point. We identify our transverse cervical artery and our external jugular vein. These are the landmarks: external jugular vein, internal jugular vein. Then we ligate it. We have to make sure that we are staying above our transverse cervical artery. From this approach, we have now cleared level 3, 4 and level 5B from the posterior part of the sternocleidomastoid going anteriorly. We are looking at the clavicular end, which has the omohyoid, the sternocleidomastoid muscle, the internal jugular vein, and our spinal accessory nerve is very well seen. We are well above the prevertebral fascia. We can also visualize our phrenic nerve which runs below it. That is the area of the thoracic duct. Continuing with our routine procedure, we finish our level 5A. Making sure that the spinal accessory nerve is preserved well. All further steps are mostly similar to our conventional neck dissection. We delineate the middle border of the sternocleidomastoid muscle and proceed with our level 2 dissection. We identify our spinal accessory nerve. That is our spinal accessory nerve, internal jugular vein. We delineate the posterior border of the internal jugular vein and make sure all the lymph nodes and the fibrofatty tissue is cleared. Continuing with our dissection, we go to the level 2B. Here as well, we start with delineating our posterior border of internal jugular vein. Stressing on the same point that Dr. Vidisha has already mentioned, we make sure that there are no traction injuries to the spinal accessory nerve and clear our level 2A and 2B. That is our level 2A and 2B. We then complete our level 1A dissection. Which is similar to our conventional neck dissection. That is our level 1A. This is the level 1B dissection. We start by identifying our marginal mandibular nerve. We identify our facial vein, facial artery, ligated at the lower border of the mandible. At this point, we ask our assistant to put a smaller right angle or a retractor at the mylohyoid so that the deeper part of the submandibular gland is exposed. That is the lingual ganglion, lingual nerve and the ganglion. We identify our facial artery and ligate it or preserve if we are doing a free flap for anastomosis. This is the final overview where we're showing all the levels. That is the 1B, level 1B. That is the level 2A, 2B and the level 3. We have to make sure that the hemostasis is achieved before handing over the patient or closing the neck. And positive pressure ventilation to be given to check for any chyle leak. That is our posterior triangle. The video credits to Dr. Prashant Pawar sir, Dr. Sagar Vaishampayan and team. What we have to remember is this is just a different way of doing it and not a completely new procedure. This conference is definitely going to give you a bird's eye view of all the different approaches. Thank you.
Thank you, Dr. Arzu Saria ma'am, for the wonderful video presentation and your insightful words. Before we proceed to the next video presentation, I would like to take a moment to ask ma'am to address any doubts that we have in the previous two presentations. Any doubts among the delegates or students present here?
Hello. When should we go in for a posterior approach neck dissection?
So it's just a matter of habit that we do it, okay? So whenever we have to do a comprehensive neck dissection or a modified neck dissection type 3, and you have to address level 5A as well as 5B, it has been our experience is that if you go posterior, so you have a good control on the IJV, as well as at times you have these anomalies where you have the external jugular vein going to the IJV. That is where control on these anomalies is much easier, and of course 3, 4 and 5 you do it together, so it's time saving as well. So there is no greater advantage from what you do conventionally, but it's just my experience that this is the way we do it. And other thing is that when we do level 3 and 4 in a conventional manner, your assistant is retracting, you are also bending, so a lot of backache to you as well as your assistant. So what I have found is that this is a more direct approach, good control on the vital structures and easier. So, but only for comprehensive where you are doing 5. If you are not doing 5, then there is no point in going behind unnecessarily.
Thank you, sir.
Any other questions? Yes.
Sir, are there any other variations for this incision? Like you have followed the skin crease incision which was there. So is there any other incision which you prefer for this, or it is the skin crease incision which we follow?
So this neck dissection was the same horizontal skin crease incision. There is no different incision as such.
There is no modification.
No,
on
just the horizontal skin crease incision.
That
It's just the way whether you go anterior to the sternomastoid from the very beginning or you go from posterior from the very beginning. That's the only difference in this.
Okay, thank you.
Moving forward to the third video presentation of the first session, which is a video presentation on sentinel node biopsy by Dr. Richa Vaish, Associate Professor in the Department of Head and Neck Oncology. And I request Dr. Prashant Pawar sir to kindly conduct this video.
So unfortunately Richa could not be present here in person, but she has been kind enough to share the video with us, and she has a voiceover as well.
Good afternoon everyone. I will be presenting a video on sentinel node biopsy. Patient is a 37-year-old male with a non-healing ulcer over the right buccal mucosa measuring 2 into 2 centimeters with no lymphadenopathy. The landmark trial from our institute showed that elective neck dissection confers a survival benefit in node-negative early oral cancer. What we also know is that the neck dissection is not needed in true node-negative patient, which is about 55 to 70%, and it is associated with morbidity, which is predominantly of nerve dysfunction seen in 40% of the patients, which can be crippling in about 5% of the patients. We have level 1 evidence for sentinel node biopsy, which does not cause any morbidity and confers a survival benefit. Today, sentinel node biopsy is an alternative option in the standard NCCN guidelines. Freshly prepared nanocolloid is injected in 4 quadrants around the tumor. The dynamic lymphoscintigraphy is performed to identify the sentinel node, as we can see it appearing here. This is followed by a SPECT, which helps in localization of the sentinel node with regards to the surrounding landmark structures. This is followed by injection of methylene blue around the tumor in the same 4 quadrants using a tuberculin or insulin syringe. The procedure can be done immediately after the induction before scrubbing. That gives adequate time for the dye to traverse. The primary is excised first so as to avoid any interference with the radioactivity of the sentinel node. It's anteriorly located lesion, so amenable to peroral excision. Wide excision is performed perorally with adequate margins. Adequate third dimension is secured, taking out the underlying muscle. This is an ideal case for peroral excision since the lesion is anteriorly located and patient has a good mouth opening. It's a superficial lesion which can be excised easily. Once the tumor is excised, the location of the sentinel node is confirmed with a handheld gamma probe. The probe is moved systematically along the neck levels, and if there is any increase in the signal intensity, that is picked up and that marks the position of the sentinel node. As we can see here, it's level 1B in this case. We mark it with the ink. The probe is again put back to identify any other sentinel node. Skin crease incision is marked in such a way that if a completion neck dissection is needed, it can be performed from the same incision. The incision is about 3 to 4 centimeter. The skin is excised. Platysma is cut and limited planes are opened to gain access to the sentinel node. Extra dissection is avoided so as to avoid any inflammation in case the completion neck dissection is needed in the second setting. We can see the sentinel node with a bluish hue of the methyl blue dye. This is confirmed with a handheld gamma probe. The node is excised meticulously, preserving the capsule. It is excised in entirety. Dissection can be performed using the bipolar forceps or the mosquito, staying close to the node so as to avoid any injury to the underlying structures. Any small vessels are secured with the Liga clips or can be cauterized with a bipolar. The node is dissected all around, preserving the capsule of the node. Care should be taken not to excise the non-sentinel node in the vicinity. Once the node is excised, we can see that these are two nodes here and the activity should be confirmed in both the nodes. We can see the bluish hue in both the nodes and the increased activity, which should be 10 times the background activity. So these nodes are bottle blue. Any vessels in the bed are secured meticulously. One should always go back and confirm the activity in the basin, which should be less than the 10% of the hottest node. Usually it is merging with the background activity. The nodes are then subjected to the frozen section, which is performed at 2 mm blocks. This is done to identify the small focus of metastasis and to do the completion neck dissection in the same sitting. The nodes are meticulously mounted on the chuck and sections are obtained which are stained with toluidine blue and hematoxin and eosin staining.
I think that was an excellent video. I think our thanks to Dr. Richa, who could not come, but thanks. Any questions from the audience? We'll move on to the next video presentation. You have a question? Yeah. Disha, can I?
So what are the chances of this biopsy being a false negative?
So every institution has to validate its false negative. So the literature, what has been come, the 3 trials that Dr. Gauri showed, the 3 randomized control trials that have been shown, the false negative rate in those trials has been under 10 to 14%. So that is the accepted current levels as per the trials. But when you start your sentinel node biopsy in any institution, first there has to be a validation to see what is coming as your false negative rate, and that false negative rate has to be acceptable, that it cannot be more than, like, let's say 14%, which is the cutoff of the literature. Then only you can do that standardization. So the false negative rate is a valid question, but that usually has to be validated for each institute, and it has to be as per literature currently between 10 to 14%. Thank you.
Thank you, Dr. Vidisha. Moving on to the next video presentation for our day on the topic of endoscopic neck dissection, we have with us Dr. Arjun Singh, Associate Professor in the Department of Head and Neck Oncology, Tata Memorial Hospital. Welcome, sir.
Thank you everyone. Thank you Prashant sir and the other organizers and seniors from our department. Actually, it gives me great pleasure to be here today. 21 years ago, I was also a student in MGM, and seeing my teachers in Tata as well as our past teachers for MGM gives me a great privilege to even come here and share the little work that we're doing. So just to go through this. So this is an approach we're trying to do, is a transaxillary breast approach for neck dissection. And I don't know if you guys caught it, but Dr. Gauri Pantvaidya said a very important thing in her lecture. We often try to make the simple things much harder, and this is one of them. So the contemporary neck dissection, which you guys have been very familiar with, someone asked about incisions. So there are a number of incisions. These are all cervical approaches. So if you have problems in the neck, you go through the neck. That's what would be the most common sense answer. But more often than not, patients as well as different disease processes require you to somehow or sometimes go through an extra cervical approach. And an extra cervical approach can be in various forms. I've just listed a few of them over here. Some are combined. You can go through the mouth, you can go through the axilla, the breast, you can do it hybrid, you can go from up and down, as well as a lot of techniques have been described. But most of the techniques have been bilateral, very few have been unilateral. Most of the cancers that patients would want is from a unilateral scar as well. So I'll just show you one of the approaches. Sorry. Yeah. So this is a 22-year-old male, had a cancer in the oral cavity, needed to do the neck dissection. So I'll just explain to you. So this is not a routine extracervical approach that you see. It's done through 3 port placements, and we use carbon dioxide for insufflation of this entire air cavity that you create. You go through the chest. There are ports being placed over here, 12mm ports as well as 5mm ports. And as you raise this entire flap to reach the cervical, to raise the flap, which is your regular subplatysmal flap, till the landmarks which I'll be describing, you keep insufflating carbon dioxide and gas so that the flap stays elevated. And then various instruments are introduced through these ports. Now mind you, this is done only from a remote area with a very small 1 or 2 centimeter incisions. So you're seeing this patient from down up now, and you raise your typical subplatysmal flap. You see level 5 first. Here you can see the platysma suddenly starts disappearing as you reach the midline. This you can see we're just palpating the gonial angle and the mandible over here. As you progress anteriorly, you're going to see the lower border of mandible, which you should palpate, and then you go towards the level 1A area. Now, before you do any of this, you should be very familiar with what you're seeing, and in an open approach or in an open technique. Here you can see the anterior belly ipsilateral as well as the contralateral, and in between these two is your level 1A. You start by dissecting this level 1A fat off the mylohyoid muscle. And here, because of magnification, you can see these structures quite clearly. The only thing is if you hit a vessel or you hit something, it gets a little difficult. But over time, as you do these procedures, it gets a little more comfortable. The next step is this is your level 1A, just to get you oriented. The next step is you try to identify the omohyoid muscle, which leads to the digastric, anterior belly of digastric. That defines your level 2, 3 and level 1B area. Here you can see the submandibular gland being elevated and the fat along with it. This is your common facial vein. So going back to the landmarks, it's very important to identify the posterior belly of digastric. That gives you more confidence and control in case you hit something. Here you can see we've ligated the common facial vein and the gland is pulled superiorly. Here you can see the facial artery deep to the digastric as well as the submandibular gland being elevated. You clip and you ligate these, the facial artery and the vena comitans. And this is the posterior belly of digastric. And here you can see the other structures which the previous speakers have also shown, the hypoglossal nerve very clearly seen. Now next is your marginal mandibular nerve. You can see it over here. And you want to define the superior border and release the submandibular gland and the fibrofatty tissue from the mylohyoid muscle over here as well as the lower border of mandible. Now here you will see the submental artery also sometimes creeps in. I think you can see it there. And the next step is you identify the superior part of the gland and the facial artery that's on the superior part. You also ligate that. So the idea is to dissect and release this gland from all its sides, all its attachments. Here you see the vein and the artery as well as the nerve being preserved. And once you pull the gland little laterally, you will see the lingual nerve, the neurovascular bundle as well as the duct which is there. And that's how the entire gland is removed. You pack the gland in the 1A area, that's what we do. We don't bag it just yet. Now for 2, 3 and 4 levels, so sternocleidomastoid has 2 heads, the sternal and the clavicular head. You start raising this, now typically you would retract the sternocleidomastoid laterally. Now here you're coming from the chest, so you don't have much of an option. You split the 2 heads which have a very well defined anatomic plane, as well as most of the perforators from the IJV to the muscle, they go through this plane. So they also get cauterized very well. Now it's important to delineate this residence triangle or residence area, what they say, which is a friendly area. No structures come between the posterior belly of digastric and the sternocleidomastoid. As you dissect this, you'll see the spinal accessory nerve over here. So it's very important to preserve this, remove the fibrofatty tissue along it. Next, to keep the sternal head of the sternocleidomastoid, we pass a grasper and then just keep it, clamp it to the digastric anteriorly and keep it elevated. So you see this entire space of level 2, 3 and 4 open up. Then it's your conventional fibrofatty tissue from the anterior area. I don't know if many of you all know, but one of the earlier AJCC classifications had a distinction between 3A and 3B. And this was where the distinction was. 3A was anterior to the vein and 3B was posterior. So it's kind of revisiting your old classifications back again. So how you remove it doesn't matter whether you go from top to bottom or bottom to top. The idea is to remove the entire fibrofatty tissue along with the lymph nodes. Here you see the carotid triangle. In this case, you can see the hypoglossal nerve here, which has a very distinct anatomy between the vein and the carotid artery. And you can see a node which is present. It's very often, because you have no tactile sensation over here, you need to make sure, you need to dissect and then only remove anything. Now for what I mentioned as 3B, we don't classify it as 3B anymore, but just so to tell you that the part posterior to the vein is now being dissected. Now the clavicular head of the sternocleidomastoid also needs to be retracted laterally. We pass a needle introducer. I don't know if you're familiar with these instruments, but this is a tie, vessel tape, and that's a needle passer. So subsequently, because of the pull, that entire space opens up. And you have your omohyoid muscle over here and level 4, 3 and 2 as you go superiorly. So level 4, the conventional, where we retract our omohyoid inferiorly and go by that technique. You don't need to do that in these cases because the patient is positioned in such a manner where level 4 does get elevated in the cervical part. Here you can see the fascia that was glistening white, which you typically see the cervical rootlets being preserved. And as you go subsequently superior, you see a carotid knuckle. I think one of the speakers before highlighted, that you should dissect very meticulously over here, not only to save the spinal accessory, but also to safeguard you from inadvertent injury to the carotid knuckle. You keep dissecting, you can sort of cauterize and release the fibrofatty tissue in this triangle. This is often left behind. Now this is a maneuver we've just tried, and now we really enjoy doing this part actually. You just lift the nerve superiorly, there's minimal handling, and then you take that triangle out. This is 2, 3, 4, that's 2A, 3, 4, and now you approach level 2B. Of course, you don't have the typical retractors over here, but the instrument we are using does not have any conductive effect or heat thermal effect on its lateral border. So these are insulated instruments. So even if you touch the lateral border on the nerve or the vein or any vessel, it won't cauterize it or burn it. Next, these specimens are bagged. It's very important to put this in a bag and remove it through the chest. And this is just the clearance. In fact, you can see a lot of the mistakes I've made and the fact that I've left behind because of this magnification that you achieve with this technique. So just to move on, you'll see at 3 months post-surgery and the long-term follow-up, there are no scars. There is nothing at the back of the neck nor on the front of the neck. So it's completely extra cervical. The incisions are small. There are a number of other techniques as well, and I'm sure other speakers will also talk about it. In our experiences, all techniques have some complication. If you don't have complications, you've definitely not done enough surgery. So some have keloid formation, some have, you'll see tips becoming black. Some have large incisions. They are mostly extra cervical or cervical, but remote access. So this is a technique which combines both remote access as well as minimally invasive. They're small incisions. So we've moved a long way from where we used to treat. We also give incisions in the natural creases. They're closed very well. And now subsequently, when patients' demands increase, you want to also not give an incision at all in the cervical region because that is more visibly seen. But mind you, all of these are incisions. There's nothing as a scarless surgery or incisionless surgery because you have to, go in somehow. So where we are headed, we use, in certain areas, especially 1A region, it's a little difficult to raise the flaps and access that area. There are flexible arms. You don't necessarily need a robot in these situations. Mind you, none of this has been done with a robot. This has been done with our regular laparoscopic long extension instruments. They're standard, they are available in Indian manufacturers as well. It does take time. Initially, I used to take about 4 hours, 5 hours. Now we are down to about an hour and a half. You also have a lot of, someone would say, the gas is a lot. So it's 500 rupees for 4,200 liter cylinder. And you can't run through that even in a day. So you can do about 2 or 3 surgeries in that 4,000 liters. It's routinely available in, I think, most hospitals now, not for our purpose, but for laparoscopic surgeries. So it's the instruments, the armamentarium is very available. You can also use dyes, which now are being tested for various other indications, especially thyroid cancer. You want to differentiate between parathyroid tissue and lymph nodes, but you can also use it in our situation because these kind of dyes, they stay in lymph nodes, they don't stay in parathyroid tissues. And of course, training is, I don't need to emphasize this more because this is the most important point. You need to not only train yourselves, but train others. Because if you want any of these procedures to go ahead, if you want to see your work, moving forward, it's best seen when someone else does it rather better than you, in fact. So thank you, and happy to take any questions.
Thank you, Arjun. I think it was an excellent video, beautiful pictures. And I think you rightly pointed out that learning curve is very important in these. And where did you get trained? Like, can you tell for the benefit of the students?
I think I'll avoid that because we started doing it on our own.
Okay.
And initially, look, it's very disorienting because you don't have your regular access. If you hit something or you do something, you can't just suddenly go and catch it. And the arteries, rather, if you hit something in an arterial vessel, it's going to spurt back on your camera. And these are small areas. The camera has a light where if it sees red, the brightness reduces. So your visibility goes, everything goes, it's very difficult. Veins get collapsed with this gas. So you need to use Valsalva maneuver again and again to check whether these veins, whether there's a vein or whether it's a node. Over time, you get comfortable, doing these procedures. We have had many instances where you need to suddenly open the neck because you can't, complete the procedure through this access. It is difficult, but the more you do it, the better you get at it, as in most things. But to Prashant sir's point, I think you should be comfortable doing it in an open approach, and then you try, these approaches. Whether it's, any extra cervical or cervical, get comfortable with the anatomy, and then, you can make your own procedures and do your own thing. I don't necessarily think that you need a formal training for this, but if your basic is strong, I think you should be able to do most procedures.
Thank you. Thank you
sir.
very much. There is a course in Yonsei. Annually they have a robotic symposium, and along with that they also have an endoscopic dissection course, in which they teach transoral as well as retroauricular as well as this Baba kind of a thing.
Yeah, so this is not Baba. So what we've done is we've done it unilaterally.
But it's a good beginning.
Definitely.
Get hang of the instruments. They have cadaver dissection as well, so it's beautiful.
Thank you, sir.
Thank you very much.
Dr. Arjun Singh for the enlightening session. And the next topic we have is on retroauricular neck dissection. And this video presentation would be taken by Dr. Prashant Pawar sir, the consultant head and neck oncologist at Tata Memorial Hospital. HCG Cancer Center.
Pointer is that?
I think in the interest of time, I'll quickly begin with my presentation. So, this was the premise with which we started, and we've all seen the movie Dark Knight. And, scars have a very deep psychological impact on a human psychology. And this was a nice study. We know thyroid surgeries are the simplest surgeries that we do. And this is a prime example of, most of the times you get good scars. As you see in the first picture, a nice linear scars after a few months, you barely see anything. But you are never sure. 90% of times you'll get a good scar. But look at a picture B, it's a bulging scar. Picture C, which is a hypertrophic scar. And picture D, which is a retracted scar. So we never know when we are going to land up with what kind of a scar. So this study showed that, the psychological impact was as bad as that caused by chronic skin conditions like psoriasis, vitiligo, and severe atopic dermatitis. And that is where we know that scars are really important. Another very simple study. On the left hand side is the patients who undergo a transoral thyroidectomy. On the right side is the transcervical thyroidectomy. And there were observers who were given, laser adapted to their spectacles. And you saw that, where are people looking? You see, when you've done a transoral surgery, people are focusing only on the face, whereas in the transcervical. So that really causes psychological impact, because whenever the patient is in society, people tend to look at it and discussion kind of goes there. So that is how it is, and there are ample of publications to show that it really causes body image disturbances, and that is why scars are important. During our training, we have seen various incisions, but we know that a classic Kral's incision gives a very bad scar. But we also know that most of the times, like we have seen in today morning presentation as well, that most of the times today we are doing a horizontal skin crease incision. So if you see the picture on the left and the right, so left is just the horizontal limb of the Kral's. But if you look at the right, it's a horizontal crease, which is much better. So if you restrict to the crease, it's always better. But just like the thyroid analogy, you never know which is going to be a good or which is going to be, in those rare instances, a bulging, retracted or a hypertrophied scar. So this picture, you can see a nice scar. On the picture on the lady on the right, sometimes I'm also confused which was the one which I use, superior or inferior. But that's the problem, is that you never know when you're going to land up with a retracted hypertrophied scar. And that's where what is best is in the picture on the extreme right, where you cannot see a scar. So this is the kind of innovation that we did, because I got my first training in robotic surgery in Yonsei Center in Korea way back in 2014. But when I came back, there were very few centers which had robot. I mean, even today, there are very few centers which have head and neck specific instruments and robot. So we had to do some jugaad, and this is a jugaad that we did, and it ended up working out very well. So this is a small video I'll show of a retroauricular neck dissection. This is a retroauricular or modified phase shift incision that we use, again for early oral cancers. This was a setup I used to use initially. I used to use an endoscope holder, a Thompson's retractor with self-fitting retractor blades, patient in supine position, head turned towards the opposite side, what you would do for a conventional neck, and the monitor on the other side. This is the marking of the incision. And we shave a centimeter of the hairline and take incision within the hairline. So when the hair grows back, the incision is invisible. So this is the marking again. We start in the preauricular sulcus, go behind the pinna, and come down along the hairline. Infiltration, then incision. Initial flap raising is absolutely similar to what you do for a parotoidectomy. You leave a little bit of fat on the skin. First structure that you identify is the greater auricular nerve, followed by the external jugular vein. Once you found the external jugular vein, the platysma is usually within a centimeter there. And once you found the platysma, the subplatysmal flap raising is absolutely similar to what you would do for a conventional neck dissection. Only thing is that the difference is that you kind of raise flaps a little bit more than what you would do for a conventional neck. So you would go across the midline, along the midline, you go above the clavicle, and you go below the clavicle, and you go above the mandible. So this is a very gory picture, but it shows you how much of access you can get. So this I'm going to just run through quickly of how you do. Again, I'm trying to emphasize the point that, see, the sternum is being retracted by simple Babcock. I'm using a simple cautery, not even a long tip cautery. I'm using a simple vascular forceps. And majority of times nowadays, I'm just looking in the field and the camera is just recording. Just to highlight the point that this is very close to a conventional neck dissection, and there are no fancy gadgets or instruments required. You can do it in any setup. I have done this kind of neck dissection even in a municipal hospital. So level 3 and 4 complete. Level 2 is even more easier because it's the closest to our field. Spinal axis nerve identified, level 2A, 2B. The most difficult ones are actually the level 1A and the 1B. And another simple thing about this is that because the incision is quite like an open incision, so even if there's a bleeding or something, you can control it easily. I never have to take a consent that I may have to change the incision in any of these neck dissections. So now I'm concentrating on 1A. So we identify the ipsilateral belly of digastric. This is more like an inferior to superior approach and a medial to lateral to medial approach. So I'm starting dissection along the myloid muscle from the hyoid, moving superiorly. You should always anticipate vessels like Arjun was telling. These are the submental branches which will kind of make you feel very bloody. In any minimally invasive, you need a clean field to be able to do a good neck dissection. So that is very important. Go slow, be methodical, and that's your 1A. 1A, usually there is no important structure that comes here, so relatively easy, only the axis is difficult. So that's after the completion, ipsilateral contralateral digastric, that's the completion of 1A, and now coming to 1B. So this was a C8 tongue. So first thing that we did was identify the marginal mandibular nerve. And again, the difference, not very different from a conventional neck dissection, it's just that it's posterior to anterior and inferior to superior kind of approach. So after you identify the marginal mandibular nerve, then you start your dissection. I mean, just incising the fascia there and making sure that I stay away from the nerve. Now, the key is just lifting structures at all times. Just like you saw in the endoscopic neck dissection, you have to use your one arm to lift the structures up, identify the planes, and do a methodical dissection. This, now we are trying to identify the inferior belly, so the posterior belly of digastric. Now we are going posterior to anterior. Now you can see the facial artery very well. In this particular patient, the anatomy was quite favorable in that the facial artery was coursing posterior to the gland. So we could just ligate the branches going to the submandibular gland, and we could leave the facial artery in continuity. Now we are just running along the lower part of mandible. Now we'll ligate the branches first and then proceed anteriorly. I'm using Liga clips. It is easier to handle in a narrow field. So we apply clips, a couple of clips on either side, and then divide. And you can see that's the third, I'll say, intelligent arm. So one of my assistants is using the instruments and the scissors. And you see that right angle retractor above, that's also another assistant. So you have another arm which is assisting you doing the surgery, and the field is maintained by your self-retaining retractors. Now here again, we are working over the myloid muscle, taking all the fibrofatty tissue from over the mylohyoid. And now here, we will be able to identify our lingual nerve. Yeah, see, I'm just lifting the structures up because I want to stay away from the hypoglossal nerve. You can see the digastric tendon very well. So now, yeah, that is where we identify our lingual nerve. Okay, see, I'm just pulling down, be able to identify the lingual nerve, ganglionic attachment. We'll just divide the ganglionic attachment and the nerve will then retract. Then I will take all the fibrofatty tissue from over the mylohyoid. The duct will be the last structure I divide because I want to be sure that I'm lifting the gland up and making sure that the hypoglossal nerve is away. In a tongue cancer, it may not matter so much, but if you are doing a buccal mucosa cancer, then of course your hypoglossal nerve is very important. Okay, so we have taken all the fibrofatty tissue. We are running over the antivilli of digastric now. Now finally, we'll see the duct and divide. Yeah. Again, you may use a Liga clip, you can divide, you can just cauterize and leave it, that's also fine. So that's the level 1B. Again, ensuring our marginal mandible nerve is well preserved. That's the completion. It was a seared tongue, wide excision was performed, closure. In an elderly gentleman, you may not notice the cosmetic outcome, but look at a young patient. Okay, you actually have to make an effort to retract the hair and see the incision. So that's the most important benefit, is the cosmetic outcome. That's the whole agenda. So we moved on from a horizontal limb of Kreis to a horizontal crease incision and now to a retroauricular. This patient we also did a marginal mandibulectomy along with a neck dissection. Now this is what we were discussing, can we do it without endoscopes? So I'm going to show you open camera pictures. Look at this lady, this is operated in MGM Medical College. Okay. This is open camera picture. You can look right up to the 1A region with the open camera. Just to tell you that access is good enough in most patients for you to be able to do as an open approach as well. So nowadays I'm saying it's just another incision, not to call anything fancy, but you just need some instruments which can help you do that kind of approach. Can we do free flaps? Nowadays free flaps is becoming more and more as a standard of reconstruction. So if you have to do any kind of free flap, especially FRAP is very easy because you've got a long pedicle. Okay, and most of the patients, whether it's FRAP or ALT, we have been able to do. We have not done fibula as yet, but we have been able to do soft tissue reconstruction. What about pedicle flaps? Now this is one gentleman who had a young patient. We did a hemigloss, we did a free flap reconstruction. Unfortunately, what happens in 5% cases is sometimes the flap fails. In this patient also, you can see the flap had failed and we had to do a salvage rescue with a PMMF. And we just have to take a separate incision for the PMMF and didn't have to change. I'm just trying to show you the versatility of the incision. We didn't have to change the incision. Only thing that we noticed was the minimal of skin necrosis at the tip, but the outcome was cosmetically superior. Some patients for ethnic reasons, for other reasons, they don't want to shave. Fair enough, my incision is far too posterior. We don't necessarily have to shave. And this is the only complication we have noted, is that if you go high, just like in a parotidectomy, if you go high onto the maxillary, you will end up with a little bit of skin necrosis. And in about 12 to 15% of patients, we have noticed that there's keloid tendency in that region. So we have also published this. And another thing we noted was lymphedema is much less because your incision is vertical and posterior. This is another lady I did in KM hospital. Learning to show you that it's very versatile. We can do it in a cost-constrained setting as well. This has been a part of systematic reviews and meta-analysis showing the same point. Consensus now today is that, what is the indication for this? Is that a treatment name, early stage oral cancers, which is per orally resectable. and clinically N0 neck. Contraindication is past history of chemoradiotherapy or any neck surgery or a recurrent case or clinically N+. So these are today the contraindications. I'll just show you again just to emphasize the cosmetic outcome. Sometimes I am also kept guessing of which side I have operated. And especially in young patients, it really makes an impact. Okay. Young male. Mukulo akaro. Okay. Okay, so this was CA right side tongue. We have done a wide excision. And in this particular patient, you see, he had a keloid tendency. And he had a large keloid in the retroauricular scar region. Same patient, if I had operated with a conventional incision, he would land up with an ugly scar in the neck. So this is much better that you could do a retroauricular and give him a good cosmetic outcome. You see that? Yeah, it's a bad keloid. But because it's in the retroauricular area, it's quite handy. See, the preauricular incision also goes in behind the tragus. So that area is also hidden. So final summary is that, we are now moving towards smaller incisions. We try to avoid incisions of the face. We are moving towards horizontal skin crease incisions. And a step above is if you are able to do a retroauricular. Another thing about retroauricular is that today we are talking about oral cancers, but with the same approach and same incision, we are doing parotidectomy, we are doing thyroidectomy, we are doing benign submandibular gland excisions as well. So one incision and one approach, if you learn, you are able to offer a lot of other surgeries as well, which makes it very vital to our profession. Thank you very much, and I'll be happy to take any questions. Please. No, we can do it for the, like I'll show you the other patient which we did FRAF, was a buccal mucosa cancer. So the only indication is that it should be early stage and per orally resectable. Okay, if you're going to take an incision for access of the primary, then there's no point in taking a cosmetic incision in the neck because you have a scar on the face already. So your primary should be per orally resectable, then you think about cosmetic incision for the neck as well. So I think nowadays we are doing, but we don't really have that kind of data. So more data should emerge. But every surgeon in his own way is trying to give cosmetically superior outcomes. So many times, if the skin is not involved, we are today doing segmental mandibulectomies also with a cervical approach. We are doing marginal mandibulectomy per orally as well. If it's anterior, it's quite easily possible. So yes, but I would not make it as a generalized statement. But yes, per orally resectable tongue and buccal mucosa cancer, I think it is easily feasible. For bone resections, I think it will be a little bit far-fetched to say that today, but maybe in future, of course. Yes. Yeah, so tunneling was the same as you would do. That's what I'm trying to say. If you do the whole neck dissection from that, you have already, and in this, anyways, we are going beyond the clavicle to raise the flap. So that part of plate is partially already raised. So that's what I'm trying to show, that even if you had to do a PMMC or a PMMF, you don't have to change the cervical incision. Okay, so that is the versatility. You didn't have to change the incision in any way. So we have had instances where patients had bleeding as well, big hematoma as well, but we didn't have to change the incision. We could manage the bleeding and everything with the same incision because quite frankly, it's quite an adequate access. It's more than adequate access to control anything in the neck. So it doesn't jeopardize you in any way to do anything in the neck. Thank you very much.
Thank you very much, sir, for the very comprehensive view on that note. For the next video presentation, we have the topic on management of chyle leak, taken by Dr. Ratan Shetty, sir, Associate Professor in Department of Head and Neck Oncology at Accredited.
This is the one which has been changed. Okay. Yeah. This one. Wait.
At the outset, I'd like to thank the organizing team for having me here. I also like to thank Prashant Pawar sir for giving me the video of Kyle Leak. So let me begin. Before knowing managing Kyle Leak, one should know the anatomy of the Kyle duct. So the Kyle duct starts at the abdomen at the level of L2 and it reaches the thorax, and at the level of T12 it crosses onto the left side and forms the thoracic duct, and it joins the IJV at the level of C7 vertebrae. It can be as high as up to the level of the thyroid cartilage, and usually it is between 2 to 5 centimeters, about 2 centimeters above the clavicle. And what does the thoracic duct drain? The left half of the body except for the right limb and the right side of the neck, which is drained by the right lymphatic duct, not the Kyle duct, the thoracic duct. Now coming to Kyle duct injury, one should remember that the complications which are reported in literature is much lower than what actually happens. So that is the trend in across all institutes. So we try to be as honest as possible, but the Kyle leak rate in our institute is about 1 to 2%. So it's not very low also. So if it is less than 1%, then it should be considered very good. So injury is rare, but it's a serious complication. You tend to injure, but you should know how to manage it. The incidence is between 0.5 to 1.4% even in thyroidectomies, because sometimes you can injure the Kyle duct behind the carotid, and it's about 2 to 8% in neck dissections. And what are the most importantly, one should be able to recognize the injury to manage it. And 98% of the time the thoracic duct drains onto the left side, but sometimes in 2 to 3% it's on the right side, and can be as high as up to 25% in certain series. But most of the time 2 to 3% only it's on the right side. There are more than 20 different classifications. I want to go into the details of the classification of thoracic duct anatomy. So where does it terminate? 70% of the time it terminates into the junction between the subclavian and the IJV, about a centimeter above the junction. And in about 30% it goes into the confluence of the IJV and the subclavian, and sometimes in 18% it drains into the subclavian. Again, this can be a single duct or multiple ducts. Vast majority of the times, about 70 to 80%, it's a single duct, but sometimes it could be bifid or trifid or many ducts. So this is a review article which showing whether it is a single terminal duct or a common trunk or a multiple trunk, and vast majority of the times, most of the studies are cadaveric. There is an ultrasound based study by Serger et al. In 2009, where vast majority of the times it's a common single duct, but there can be multiple trunks draining into the IJV or the junction between the IJV and the subclavian. So why is it important? What does Kyle drain? Kyle drains the lymph from the intestines. The long chain triglycerides and the short chain triglycerides are absorbed into the intestine by esterification, and it is drained by the lymphatic duct into the venous system. It can be about 1.3 to 1.5 ml per kg per hour. So the bigger the person, the bigger is the Kyle flow. And also depends on the hydrostatic pressure, like how is he coughing or doing the strenuous exercises. The lymph flow can be quite high. So it's about 1.3 to 1.5 ml per kg per hour. So if you could do the math, it will be liters sometimes. So when you cause injury to the Kyle duct, there is loss of protein, loss of fat soluble vitamins, loss of fat, loss of vitamin trace elements, and even contains white blood cells. So the patient can become immunocompromised, can lead to hypovolemia, electrolyte imbalance, and if you let it be, then the patient can have malnutrition and immunosuppression with the consequent wound related problems like wound healing problems, infection. Rare complication is a chylothorax. I happen to have the unfortunate that I have seen 2 chylothorax in my career over 10 years. But this do tend to happen. If you have a Kyle leak and if the Kyle leak stops, the next day don't be very happy. Get a chest X-ray. There may be a chylothorax. So how to prevent chylothorax? That is careful dissection of level 4. Vidisha madam displayed how you will have to access the level 4.
always start from lateral to medial rather than medial to lateral, because sometimes the thoracic duct can be very high and you can tend to injure it at the level 3 region also. And Osvaldo Suarez has described a technique where you can do a blunt dissection with the gauze, which is not an elegant technique, but it prevents injury due to sharp dissection. So that is something which was described in 1960s. Osvaldo Suarez, the guy who introduced functional neck dissection, for those who are not aware. So if inevitable, identify and divide and ligate. Ligation can be with the clip or with the, you can clip it, or you can ligate with non-absorbable sutures, ideally a silk suture. So the silk causes intense inflammatory reaction and fibrosis sets in and it prevents chyle leak. Intraoperative, you can identify by carefully examining the neck after the neck dissection. Look at the level 4 region. If you see a creamy liquid or a milky fluid, that means it is chyle, nothing else. You can use loupes to identify the chyle duct, because the chyle duct is fairly translucent, not very easy to identify sometimes. So you will have to have a high index of suspicion. And a surgeon who knows how to dissect or way to dissect would recognize a chyle duct injury, and whenever you recognize a chyle duct injury, I suggest immediately repair it rather than wait for some time, because when the lymph flows out, the lymphatic, the thoracic duct collapses and one would not be able to identify the thoracic duct very well. You can do a Valsalva maneuver, or better still do a Trendelenburg position and ask the anesthetist for a Valsalva maneuver. You can increase the hydrostatic pressure of the abdomen by pressing on the abdomen, and the chyle can flow out. Sometimes because the fasting and all would be there, the patient not be producing chyle, so the may go unrecognized. And always identify and ligate immediately. This is a video of a right lymphatic duct, very rare. This video was taken from Prashant sir. You can see the lymphatic duct here. You can see the lymphatic duct with a translucent structure here containing the lymph. And it's quite high up in the neck. See how high is it reaching from the clavicle? And this is also on the opposite side. Right side. There's a similar structure on the left side, which is the most common one. Usually not as big as this. And you can see the chyle leaking from the lymphatic duct. So you can see the lymphatic duct, a translucent fluid coming out. Can be milky also. If the patient has not had anything the previous day, you will get a clear fluid. If the patient has had a meal, if it is a fatty meal, he'll have a milky. It can be as white as milk. We have had residents telling that, sir, there is milk in the drinks. So always manage intraoperatively. How often do you hit the chyle duct? It should not be more than 10%. So this tends to get injured sometimes when you do an extensive neck dissection. Always recognize on table and repair it with surgical clips or non-absorbable sutures, ideally silk. You can use flaps to cover it, but ideally what we do is the technique that I use is take the prevertebral fascia and suture it onto the carotid sheath. That is something which will compress the chyle duct. And you can use the omoid muscle. If you have the omoid muscle intact, you can use the omoid muscle to plug it. Additional topical agents, I don't have personal experience having this topical agents. You can use sclerosing agents, but that is not recommended. Usually it is amenable for closure. The problem which happens is when you have multiple ducts, that is when you have problems. Identify the proximal and the distal end, and then you can oversee with silk or use a muscle flap like SEM or a PMMC. Sometimes, very rarely, never used. Only once did we use this. That was the remnant PMMC which was there for reconstruction. That could be used to plug the defect. But usually it can be controlled intraoperatively without all these muscle flaps. The problem with suturing is very close to the phrenic. So you'll identify the phrenic, stay medial to the phrenic and suture. Post-operative, this is a problem. So next post-operative day, when the patient starts having Ryle's tube feeding, there is sudden increase in pain, especially after having a meal. and there will be the swelling in the lower neck. Patient can have erythema, lymphedema, and you can see the chyle in the drain. Is the clinical diagnosis. However, if it is equivocal, you have a translucent fluid, sudden increase in drain, you can send for triglycerides. Usually triglyceride level is more than 100 milligram. The clinching diagnosis is presence of chylomicrons. If chylomicrons are present in the neck drain, then there cannot be any other diagnosis other than chyle leak. Depends on the drain output. There is no consensus on what is high output, low output. Certain series it's mentioned as more than a liter, certain series is more than 500 ml, 500 ml over 3 consecutive days, a liter over 3 consecutive days. So for all practical purposes, we will consider that more than 500 ml over 3 days is considered high output leak. But if you have a leak more than a liter in a single day, then I think we should consider surgical management rather than wait for conservative management, because the complications of persistent chyle leak is much more than dealing with the chyle leak. Patient can have severe complications and lose nutritionally, and one needs to monitor the serum electrolytes level every day, if not alternate days, and albumin every weekly. And the patient comorbidity is also determined whether we can do. Suppose you have done a free flap reconstruction, then doing a surgical exposure would be a problem. And what's the surgeon's preference? So if it is a low output leak, we can manage conservatively, usually by making the patient putting the patient on a fat-free diet. You should always supplement with medium-chain fatty acids. The most common one is coconut oil, which contains medium-chain triglycerides. Remember, you cannot completely make a patient fat-free, because every food item will have some amount of fat in that. So predominantly fat-free diet, and most of the time you can decrease the chyle output. And in high output fistulas, you would have to consider surgical resection, surgical intervention. So when you put a fat-free diet, always supplement the vitamins and all that. And sometimes you will have to make the patient NBM if it is significant output. So NBM is when nothing goes into the intestines, nothing gets absorbed into the lymphatic system. So, and supplement with the total parenteral nutrition, usually peripheral total parenteral nutrition or the so TP and peri can be given through peripheral venous access. Always do wound care, restrict bed activity, because when the patient walks and moves around, the hydrostatic pressure increases and the chyle secretion also increases. And stool softeners can be given because the patient strains, again the chyle output increases. Octreotide is something which has been used off late, and the dosage is about 100 to 200 micrograms subcutaneously, secondarily, or every 2 times a day or 3 times a day. These do not work in high output leaks. There are series, about 20 odd series, where they have used octreotide. And many a times when octreotide acts, it will act within 5 days. But if you have a persistent chyle leak beyond 5 days, then one need to do surgical intervention. So if it stops with octreotide, what one can do is wait for 2 more days after administering octreotide, and after the chyle leak stops. Only then you stop the octreotide and then remove the drain. Though once the chyle leak stops, don't stop the octreotide. Continue for 2 more days and then only remove the drain, and then you can stop the octreotide. No experience using sclerosing agents. I do not recommend using sclerosing agents because it causes contiguous tissue damage also. Again, the treatment effectiveness can often be gauged by how much the drain output changes in response to a particular intervention. If it is not responding, then the alternative is surgical exploration only. The criteria, again, there is no consensus whether 500 ml over 3 to 5 days or 1 liter per day. So this number has been taken from a review article by Delaney et al. 2017. So if 5 to 7 days of conservative treatment fails, one can go for a surgical intervention. And it's not very easy because the chyle leak will cause maceration of the tissues, and when you open up the sutures, you will not be able to identify the structures very well, and even the chyle duct will not be very well visualized, and the tissue will be macerated, and taking sutures around the chyle duct also becomes very difficult because of that. So one would use muscle flaps to cover the chyle duct area and oversew it, and so that it compresses the chyle duct area. Sometimes this also fails, then one would have to go for VATS ligation. The VATS ligation is the one which we used in our case, which was in 2 cases we did a VATS ligation. Now coming to selective distal embolization, which if you have a good IR setup, you can use this, percutaneous transabdominal cannulation. Very easy to describe all this, but it's not very easy to identify the cistana chyli intraabdominally, and the success rate is only 70%. Whereas VATS, you identify the chyle duct between the azygous vein and the aorta ligated, is fairly easy. So VATS is some more invasive procedure, but yes, the success rates are much higher. And selective distal embolization is something which can be explored. I personally don't have experience with this. This is a flow chart taken from Delaney's article, where how to manage a chyle leak. If it's a persistent leak, you do a surgical intervention, otherwise manage with conservative procedures. And if chyle leak persists, you do a transabdominal embolization using your IR team or thoracoscope VATS ligation of the chyle duct in the thorax. And the VATS ligation is done from the right side, not the left side, at the lower end of the, or the just above the diaphragm. Thank you. If you have any doubts, you can ask. The best way to prevent chyle leak is intraoperative examination, and never wait for the chyle leak to develop. Thank you.
Thank you. Excellent presentation, Dr. Ratan. Thank you very much.
Thank you, Dr. Ratan Shetty, sir. Our last video presentation for this session is on complications of neck dissection and its prevention by Dr. Parikshit Bagchi, Assistant Professor, Department of Oral Maxillofacial Surgery, MGM Dental College and Hospital.
Good morning everyone. At the outset I'd like to thank Dr. Srivalli and Dr. Prashant for giving me the opportunity to present this today at this gathering. So my topic is complications in neck dissection and its prevention. So complications are a part and parcel of any surgical procedure, and whatever literature we see, complications are underreported, that is a fact. Why are complications common during neck dissection? It is because the neck has a lot of vital anatomical structures, and the procedures we do have certain inherent risks which can't be avoided. However, we should know how to avoid these complications. And important thing is to train yourself, equip yourself, and know the anatomy of the part you are operating. So how do we start with this? How do you analyze your complications is, you start with a detailed patient assessment. Take a detailed history, whether it's a pristine neck or it's a redo case. Judge what is your aptitude, decide what you want to operate, and have a plan prior. Once you have everything planned out, only then proceed. Okay, so if we plan something, we know what steps we are going to take, and only then can we plan ahead for management of these problems. Now, one more important thing which is neglected generally in the private setting is use of surgical checklists. So WHO has come up with a surgical safety checklist which consists of 3 parts, which is generally pre-op, and in the OT you have to read these checklists out. So a study was conducted, it's a multicentric study in which it was a large patient database, and it was noted that there is a reduction in the rate of complication and the rate of death just by using a surgical safety checklist. So you know which patient you are operating, what is the site, what is the planned procedure. Before you make an incision, you must be aware of everything that is going to happen. Also, there was a study at the Tata Memorial Center which used this checklist, and however it was seen that there was a lack of coordination between the team members who are present in the OT, between the surgeons, nurses and the anesthesia team, and that is why there is certain difficulties in implementation of checklists. However, it is not impossible. In the Western world, it is seen that use of surgical checklists have reduced the rates of complication for all planned procedures. And generally, what neck dissection we do is a planned procedure. It is never an emergency except for a T4 lesion or a large fungating mass. So to go ahead, just to classify, we deal with these complications in the intra-op or the post-op setting. In the intra-op setting, the structures at risk are generally the nerves and the vasculature in the region. So although all nerves are at risk, few complications are dealt with in a maximum setting. So marginal mandibular nerve, spinal accessory nerve are the nerves which are handled a lot during these procedures and are at a greater risk of injury. Vascular injury, again we only deal with the IJV and the carotid artery, so those area you have to be careful while dissection. And few post-op complications are mentioned, I will deal with them later. So now first is the marginal mandibular nerve, and as maxillofacial surgeons we are aware of this because generally for mandible fractures or an angle fracture we use the residence incision, and this is the first nerve we deal with while taking. So everyone is aware of the Hayes-Martin procedure. However, why this nerve is injured in the maximum? Because it has a variable anatomy. Okay, so we can see that the nerve can arise at the apex of the gland. It can also arise from the parenchyma of the gland higher to the apex. Also, it has a variable branching pattern. However, it is important to know that a consistent landmark should be identified, which is the facial vein. And if you take an incision 2 centimeters below the mandible and you are able to identify the facial artery and facial vein, the nerve is generally protected. And when you are doing the surgery, always be careful about the amount of retraction we are doing. Avoid use of monopolar cautery in the region. Use diathermy or cold steel instruments while dissecting in this area. This nerve injury doesn't cause debilitating side effects. However, it causes great inconvenience to the patient, and generally it is seen when we are doing a peroral dissection. So these patients are generally more affected by a injury to the marginal mandibular nerve. Second nerve which we deal with is the spinal accessory nerve, and this is dealt with when you are managing the level 2 or level 5 dissection. This nerve again has a variable anatomy. Nerve is usually located lateral to the IJV. However, it might be located medial or might pass through the IJV. And also there is a variable branching pattern which is generally seen in level 5, in which there might be a separate branch which is going to the trapezius muscle, which might get transected when you are dealing with the cervical roots and doing a level 5 neck dissection. This is a small video of variation in the spinal accessory nerve.
As you can see, this is the IJV, okay, this is the facial vein, and this is the spinal accessory nerve, okay. It's posing, okay, it is posing anterior, yeah, it's posing anterior to the IJV, okay. And if you can appreciate this, see, this is spinal accessory nerve. So if you can see, it feels like it's going to the sternemastoid. But before going to sternemastoid, no, it's, if you can appreciate this is the nerve, okay. Now this is joining the cervical roots, and from the cervical roots this branch is going and continuing below as the spinal accessory nerve, okay. So this is where many times what happens in the neck dissection, no, we have seen the nerve going to the sternemastoid, and then we feel okay, we have preserved the spinal accessory nerve, and sometimes accidentally a cervical root is cut, and the cervical root if you cut, and then you realize when you go into level 5 that the spinal accessory nerve has already been divided, okay. So you need to be aware of this variation, okay, that the small division sometimes a separate branch for trapezius first enters into the cervical roots, and from the cervical roots goes into the trapezius, okay. And if you can see, this branch is a proprioceptive branch, okay, going here, proprioceptive branch going posterior, okay. And many times what you do is that if you see the proprioceptive branch, you dissect along the proprioceptive branch and it will lead you to the spinal accessory nerve. Okay, go closer. Okay, yeah, very well seen. Fine. And if you want to see here, boss please to me, yeah. Okay, let me just show you the structures here. So this is the IJV, it is the carotid, okay. And if you can appreciate here, okay, this is the phrenic nerve. Okay, go closer, closer. So this is the prevertebral fascia that is preserved. Light away kartera, okay. And this is the phrenic nerve, and this is the brachial plexus, okay. Scanus anticus and medius के बीच में brachial plexus, okay. And this is the carotid, and if you want to see, if you go behind and see, you will find the vagus. Okay, that's the vagus. As you can see, this is the IJ.
We have one more video showing one more
This is
video.
show you the navigation in the spinal accessory nerve. So this is your IJV. Okay, this is the spinal accessory nerve. Okay, and here what's happening is that this is the cervical root. So after giving the branch to the sternomastoid, the nerve is going and attaching to the cervical root, and then coming off as the spinal accessory. I will go posteriorly and show you. So actually we did the level 5 neck dissection first. Just check, but and then if you see, we went behind and see this is the greatoauricular nerve. Sorry, this is the greatoauricular nerve, and that's the nerve. Okay, but if you trace the nerve above, it's not actually see it's deep to the sternomastoid. Okay, one thing is that, so when you're doing level 5 neck dissection and you find that the spinal accessory nerve is very deep, okay, and it's going deep towards sternomastoid, usually what we say is that we will bifurcate the muscle and come through the muscle, but this is deep. So when we found that this was deep, we anticipated that this nerve is going to be deep to the IJB as well. So then we went ahead anteriorly. Okay. So when we started dissecting that nerve from below, we realized, okay, that see this nerve. So this was the nerve, okay, and it's going here, like that, okay. And then we realized that a nerve to the sternomastoid is separate. So the spinal axis that we dissected was going like that over here, and this is the nerve to the sternomastoid, and yet there is a communication between the two. So there is a communication between this nerve and this nerve. So these fibers are coming and going through the cervical root and then continuing as the nerve in level 5.
The other nerves in the region which we see generally in 1B, the hypoglossal nerve is handled, and when we are removing the 1B lymph node, we should lift it carefully and see so that we avoid accidentally harming or causing an injury to the nerve. The vagus and phrenic are generally located vagus is located inside the carotid sheath and phrenic is located below the prevertebral fascia. Unless you are very aggressive with your cautery, you don't generally damage these nerves as such. Moving on to vascular injuries, again the IJV has a variable anatomy. We can see that it is bifurcated at times, and generally when there are large nodal masses in level 3, 4, we tend, and stuck nodes of the IJV, we might cause a rent in the vessel. Also, injury can happen in the salvage setting if the neck is radiated priorly. There is also an interesting variation, which is the transverse jugular vein, in which the EJV drains into the IJV. However, if we use the posterior approach which has been shown, we are able to avoid that because we are aware of where the nerve is entering and we prevent an injury to the. And generally all these vascular injuries happen because if you are digging in a small area, so have proper exposure of the region and have a good assistant with good retraction, traction and counter traction in the region. The second is injury to the carotid, which is again a extremely rare complication, only which if you are very aggressive with your cautery. The only anatomical feature is the carotid bulb, which is located at level 2, and if you are not careful during your level 2 neck dissection, you might nick the carotid bulb. So we have a video showing a large carotid bulb.
So you can see the IJV there. Okay, you can see a small bulb there that looks like a node, but it is in the node. If you see carefully, you can find the pulsation there, and then the carotid bulging in there. Okay, and the carotid body. Okay, if you dissect further, you find the carotid. Good. So you can see the zinc clearity. That's what it is. So
you have a large carotid bulb knuckle here.
Facial vein, IJV. You see the carotid bulging like that. Behind the IJV. Okay. So occasionally somebody might feel there is a.
So whenever you have a vascular injury, first thing is to keep a level head and not panic. Apply pressure, it will stop the bleeding. Avoid aggressive use and blind application of clips, use of cautery in that region. Just get a good field, expose the area, and for IJV, you can easily repair it with a Prolene suture or anything. However, for an injury to the carotid, you need a vascular surgeon cover. Okay. Important thing to note is there might be chances of air embolism which are generally neglected if you are damaging the IJV. If you are injuring the IJV at the lower end, then you should immediately give a Trendelenburg position, flood the area with saline, and then calmly try to ligate the vessel as possible. Injury to thoracic duct has been covered in the previous talks. I will not go into it. Now, generally coming to the post-op part. So this is things we generally see in the ward, and it can be avoided if you have been meticulous and you have followed your checklist, seen intra-op whether you are clean in the field. So generally how to identify an hematoma in the immediate post-op setting is the drain will be filled with blood, flaps might be floating and not stuck, and if it is an arterial bleed, there will be a rapidly progressive swelling. Okay, so these are cases in which you should take the patient back into the OR and explore the wound and try to find the bleeder. Generally, more often than not, what we see are smaller hematomas in which you use your clinical judgment to see if the patient is not tachycardic, if the blood loss is not high, if your drain is not filling, then generally post-op application of pressure and conservative management can heal these cases. Okay, so one more interesting thing is we generally tend to see the neck and we forget that a flap is also placed. So your hemostasis should be clean in both parts. Generally it is seen in the end of procedure, everyone including the surgeon is tired and we might miss a few artery or vein which are left open, and then we see. So in this patient, the lower end of the IJV was not clipped, and surprisingly the neck somehow was not filled with blood, but the entire hematoma got collected in the chest. So we had to open the chest and evacuate the hematoma. So hematoma is something either seen post-op, you might land into a big complication later on. Now surgical site infections are one more thing which are very common and can be avoided. Most of the head neck cancer patients or oral cancer patients have poor nutrition and they have additional comorbidities as well. So always plan your cases priorly, be aware of where you are taking the incision, avoid the watershed area of the neck. So generally this is a flap necrosis in a diabetic patient, so this is what the post-op presentation is, and it is difficult to manage this patient in the ward and they require frequent dressing changes so that you end up with a granulating wound which can be managed with a skin graft or no other surgical procedure is required. However, the important problem here is we to do helps avoid these complications, and when they do occur we should be aware of how we are going to manage. Now one other complication which is not a major as such does occur is collection of seroma or a small salivary sialocele, generally when you have dissected level to the parotid tail aggressively. So what happens is you forget to suture the tail parotid and you end up with a collection over there. So generally it is managed conservatively, you apply pressure, evacuate the seroma and it stops most of the time. However, if not, you can give IV glycopyrrolates, medical management, and generally most of these patients tend to do well after an adjuvant radiotherapy. So one important thing is to audit yourself after each procedure. So this is the Clavin-Dindo scale for surgical complications. So whenever they do occur, instead of hiding it, we should audit all of these complications and then sit and think about what we could have changed and implement them in our practice. The important thing again is to plan, and when they do occur, audit yourself as to what is going wrong. The take-home message is, neck surgery, though a very common procedure, complications can and will occur. Auditing is poor and incidence is variable depending on yourself. You have to be honest to yourself and the patient at the end of the day. Even when non-life-threatening, these complications do end up delaying adjuvant therapy for the patients and affect the overall survival. Recognition and intra-op correction is vital for these complications because they do affect the post-op status of the patient, and always good training and knowledge of the anatomy is important. Thank you.
Thank you, Dr. Parikshit, for the important concluding session on neck dissection video presentation session 1. Now I would like to conclude the session 1 with felicitating our speakers for the day. I invite our chairpersons, Dr. Yogesh Kini sir and Dr. Kalpana Kumar ma'am, to kindly felicitate our speakers for this session. For the first speaker, we would like to invite on stage Dr. Vidisha Tuljapurkar. Ma'am, please. Next, I would like to invite on stage Dr. Arzu Salia. Next, I invite on stage Dr. Prashant Pawar sir. Next, I invite Dr. Arjun Singh sir on stage. I invite Dr. Ratan Shetty sir on stage to kindly accept our felicitation. Next, I invite Dr. Parikshit Bagchi.
You can understand from the applause. Dr. Parikshit has been the heart and soul of this Early Oncology Conclave.
I now invite on stage Dr. Galinde ma'am and Dr. Usha ma'am to kindly felicitate our chairpersons for this session, Dr. Yogesh Kini sir and Dr. Kalpana Kumar ma'am. as we conclude this first session, I would like to thank all the respected speakers for this detailed session which provided so much clarity on dissection, strategies and pointers alongside with the video presentation. Before we move on to the second session, we would like to take a break for lunch. I request all the faculties from Tata Memorial Hospital, all our respected speakers and dignitaries The next session on management of buccal mucosa cancer will commence shortly. Take about 5 minutes, please step it down. Welcome back all after a hearty lunch, back to our enthralling sessions of video presentations. Before we commence our next session on management of buccal mucosa buccal mucosa cancer, I'd like to invite our respected chairpersons for this session today, Dr. Sunil Sidana sir and Dr. Ratan Shetty sir. It is my privilege to invite Dr. Ratan Shetty sir, who is the Associate Professor in Head and Neck Surgery at Accredited, and his invaluable experience in clinical practice and also understanding and treatment of head and neck conditions, it brings him to today's best guide for the discussion that we will be having in this session. We will look forward to his guidance and insightful leadership through this moderation. Thank you, sir. For the session number 2, the first video presentation is on the topic of marginal mandibulectomy by Dr. Anuja Deshmukh, Professor in the Department of Head and Neck Surgery, Tata Memorial Hospital.
Unfortunately, Madam is not able to come, so Dr. Pranav, he has been kind enough to send over a video with a voiceover. I think Dr. Pranav can
We invite Dr. Pranav to moderate this session for us.
Good afternoon, everyone. I'll be talking.
Oh, you're gonna switch.
So thank you to the organizing committee and Prashant sir for giving me the opportunity to present on behalf of Anuja madam. So we'll be going through the video demonstration as described by ma'am.
Good afternoon, everyone. I'll be talking on marginal mandibulectomy, and I would like to thank the organizer for giving me the opportunity. Always do the pre-op clinical assessment and a radiological assessment before you decide for the oral cavity surgery. You may do a CT scan or an MRI to assess the mandibular invasion. Marginal mandibulectomy is usually performed when the tumor is abutting the mandible or close to the mandible, and where we require a bone for an adequate margin. Whenever we choose the patient for the marginal, there is no bone erosion or superficial erosion is present, and a minimum periosteal involvement is there. The contraindications are the gross mandibular erosion, prior radiation, edentulous mandible, paramandibular tumor, and whenever the remnant mandible height is less than 1 centimeter, or a gross periosteal involvement or extensive soft tissue involvement. The type of the marginal mandibulectomy depends on the lateral, anterior, posterior, or a reverse marginal depending on the location. The medullary cavity is absent in the middle 1/3, so ramus part is usually excised in a sagittal mandibulectomy only. So for the buccal mucosa, you may perform a sagittal mandibulectomy with the buccal plate, or a lingual aspect for the lingual tumor. In the lingual aspect, the sagittal mandibulectomy done. Sometimes for the floor of mouth tumor, we may do a oblique marginal mandibulectomy with a combination. The precaution should be taken that the bony cuts are not at right angle, but they are smooth and a boat shape so as to avoid the fractures in a post-operative period. In RMT area, the marginal mandibulectomy is avoided in view of a soft tissue clearance may not be adequate. The precaution should be taken to leave behind the 1 centimeter inferior strong bone of mandible so as to avoid post-operative fractures. In edentulous mandible, the marginal mandibulectomy is avoided. Coming to the case, this is the young patient who had an early cancer of the buccal mucosa. Instrument is showing the ulcer and the erythroleukoplakia surrounding the main tumor. This warrants the anterior cut close to the angle of mouth, and this diagram shows the planned marginal mandibulectomy till the sigmoid notch along with the upper alveolectomy. Open approach is chosen for this case, and the midline split is avoided because that may compromise the vascularity of the left lower limb. The island of the skin has been planned to excise in view of the third dimension laterally. The left neck dissection done, and the facial artery ligated. The skin island isolated, and the anterior cheek flap raised inferiorly, keeping the platysmal muscle on the specimen and the lower border of the mandible. This is the posterior flap which has been raised till the angle of the mandible. This forms the lateral margin over the tumor. Excision has been planned 2 teeth away from the unhealthy mucosa, and superiorly we plan to do a upper alveolectomy since there is unhealthy lesions going in the upper GP sulcus. The intraoral cuts are communicated. The facial vessel identified superiorly and ligated. The soft tissue cuts are taken superiorly. The paramandibular soft tissue assessed and marginal mandibulectomy planned. The cuts are taken at the mental foramina. The nerve identified and cut. The nerve denotes the level of the mandibular canal. Sometimes the soft tissue extends towards the nerve. You may send it for frozen if there is a suspicion of invasion. The facial artery ligated,
and the soft tissue over the remnant mandible has been kept, and the periosteum also kept intact on the lower border of the mandible. The superiorly, the soft tissue cuts are taken, and the parotid duct ligated. The part of the masseter is also cut, since to get the third dimensional soft tissue over the tumor. The posterior cut is planned at the sigmoid notch after identifying the coronoid process. Tissue has been cut over the mandible to plan the bony cuts later. The 1 centimeter inferior strut has been planned, and the lower and the upper teeth are extracted. The reciprocating saw has been used to do the bony cuts. In this case, this is the open approach where the cheek flaps are raised, and it is very easy to use this instrument. You can use a burr also along with this, but burr gives you a ragged appearance for the curvature and it takes more longer time. However, reciprocating saw gives you a smooth and faster approach for the bone cuts. The care should be taken not to have a right angle bony cuts, but it should be a smooth and the boat shape so that the forces of mastication are equally distributed and less chances of fracture in a post-operative period. This is the posterior cut which has been taken at the sigmoid notch. The temporalis muscle cut and the medially soft tissue cuts are taken. The temporalis muscle attached at the coronoid process cut, and the posterolateral wall of the maxilla, the soft tissue cuts are taken. The upper alveolectomy is planned without opening the maxilla, and only the soft tissue reaching till the upper GB sulcus has warranted the upper alveolectomy for this patient. The reciprocating saw used to do the upper alveolectomy along with the marginal mandibulectomy. The medial pterygoid muscles are cut at the pterygoid area. The mylohyoid muscle is cut inferiorly and the specimen is freed from all the muscle attachment and delivered. The adequacy checked, remnant mandible assessed, and the angle of the mouth was preserved.
The second case, which is also similar case, but where we have used the intraoral approach for this patient.
The soft tissue cuts are taken over the mandible and the marginal mandibulectomy planned above the mental foramen. The lower teeth are excised. We used a curved blade for doing the intraoral mandibulectomy. If you use a reciprocating saw, it is very difficult to use it in this kind of a resection. There is an advantage which you get because of the angle instrument and the short length of the blade and various different blades available for the mandibulectomy. This avoids the cheek flap raising and the angle split for this patient. There is an inbuilt irrigation system along with this. Initially, we used the smaller blade and then converted to a little longer blade, and you can operate from the opposite side of the lesion so as to get a better grip and the cutting efforts. The same can be done with the reciprocating saw also, but however, intraoral excision is difficult with the long blade and without any angle. The medial soft tissue component is cut and the mylohyoid muscle is cut at the mylohyoid line and the specimen delivered. This is the third case. This patient had a right lateral border tongue missing. Lingual plate of the mandible. We did an intraoral marginal mandibulectomy along with the hemiglossectomy, and this was the defect.
Local flap, distant flap or a free flaps are done as a reconstruction. Thank you so much.
Madam is not here in person. So Pranav, when do you choose on, when do you do marginal mandibulectomy?
So when there is no gross paramandibular disease, when the lesion is averting and there is no gross bone involvement, and when the lesion is averting the bone but not involving or when there is no...
This is for the benefit of all the students here. So marginal is only for margins. Remember, marginal is not an oncological resection. If bone erosion is there, then you should do a segmental mandibulectomy. Margin is only for margins. If there is gross paramandibular disease, then you can do segmental. It's safe for doing segmental. I would like to know the experience of the other faculty here. How many of us have done sagittal sectioning of the mandible? I don't think I have done ever. I have done one. So the numbers are very, very less. So which is a safer option, especially when you have a bony reconstruction available. So better off doing a segmental. Will have a thicker bone and you will be able to make the person dentate by giving implants also with a fairly good bone stock. Thank you, Dr. Pranav.
So ACTRAC, I think this year only by January, another article was published from ACTRAC, which is actually classified marginal mandibulectomy into 4 types. Type 1, Type 2, just as James Brown's classification has classified defective mandible into 4 types. It's classified into 4 types, where Type 1 is where we do horizontal mandibulectomy without coronoid process. 1C is with coronoid, 2 is sag, 3 is reverse, and 4 is otherwise. So you can go to the, I think, Springer classification. It's a defect where you can refer to the, even while writing your notes, you can say what type of marginal mandibulectomy you are going for.
Thank you, Pranav. Excellent presentation.
Thank you. Thank you.
In this video, I think Pranav is again given the responsibility to present the next video. Again, this is by Dr. Shivkumar Tyagarajan, who is associate professor, head in oncology at DMH. Unfortunately, he is not able to come in person today, but he's been kind enough to share the video, and Dr. Pranav will.
Yeah, we'll see the video of a segmental mandibulectomy now that we have seen a marginal.
We shall see the surgical steps for a segmental mandibulectomy. This is a 65-year-old male patient with hypertension and diabetes, a reformed tobaccocure, with ulcer-infiltrative growth in the buccal mucosa ventromolar tribal region, biopsy of which was polydifferentiated squamous cell carcinoma. You can see in the insect picture the lesion. The CECT axial sections of the same patient shows the cortical bone erosion of the mandible on the left side. The surgery performed was a segmental mandibulectomy with an ipsilateral modified leg dissection and tracheostomy. The reconstruction was done with a pre-fibular osteocutaneous flap with the use of CAD/CAM to design the cuts for the mandible as well as the fibula. Here the skin appears closed, which is being removed with the specimen, and the flap is being raised around it. The cheek flap is raised, leaving behind the platysma on the mandible, that is on the specimen side. We can see here in this section, the platysma is cut at the level of the lower wall of the mandible, which is with the neck flap, and the platysma on the mandible is taken with the specimen. The angle of the mandible is delineated and the flap is raised over the masseter muscle, taking care that there is adequate soft tissue cover on the mandible. As we raise this flap here, we would come across the parietal duct. It is important to identify the parietal duct to avoid the post-operative complication of parietal fistula. Here, this is the facial artery that is identified before that. and ligated. And as we are raising the flap over the angle of the mouth, we are trying not to split the angle of the mouth and sort of bucket handle it, so that to maintain the anatomic integrity as much as possible. This probably could offer some potential advantage to the patient. So whenever oncologically safe, we attempt to do this. We're just trying to bucket handle it. We use a gauze please, and then the mucosal margins are given under direct supervision on the intraoral aspect, whereas the soft tissue is being raised from outside and making sure that the entry into the oral cavity is not blind, as we have already given the mucosal margins. The flap is being raised anteriorly, both on the lower border of the mandible as well as along the mucosal cut that has been given. Making sure that the soft tissue margins on the mandible is adequate enough. And at this point, we have to connect the mucosal margin and the margin at which the bone needs to be cut. Here we are cutting through the soft tissue on the mandible only at the point where the bone cuts are to be provided. So once the anterior bony cut has been delineated, now we are raising the flap posteriorly, simultaneously by giving the mucosal incision as was done anteriorly as well, and posteriorly raising the cheek flap over the masseter. Now here, as we are doing that, we would see the parotid duct. Now here, this that we are ligating is the angular vein, the facial vein that is, not the angular vein, sorry. Here we are raising the flap over the masseter and going closer to the zygoma. This is the buccal fat pad that is coming into the view. And we are raising the flap till the level that you want to give your bone cut. Now in this case, since there is erosion coming onto the mandible, we want to give a higher bone cut. Now this is the parotid duct that is being identified and ligated. Now once that is done, we can give the cut on the masseter, going deeper down onto the bone. Now that's the masseter cut being given to delineate the mandible. The coronoid process will be taken along with the specimen. The condyle is being preserved in order to fix the fibula to the dominant condyle. Now the posterior border of the mandible is delineated here, which is well seen, and communicated superiorly to the masseter cut. The entire masseter is cut, exposing the condyle. And we need to expose the bone only to the extent of the bone that is to be saved, and not to expose the bone which is closer to the disease. That we are at the level of the sigmoid notch. You can see the sigmoid notch just appearing here, and as we go anteriorly, we would face the temporalis muscle, which needs to be cut again. Now that's the coronoid attaching to the temporalis, which is being released all around to facilitate the delivery of the specimen once the bone cuts are given. The suction can be used here effectively to push up the temporalis muscle and cut it easily, and also avoid damaging the structures beneath, which gives rise to bleeding. Now here, the notch is seen, and the condyle that is being preserved is being exposed, and we are keeping the guide for the osteotomies, which was planned using the CAD-CAM, that is being fixed with the screws. So this helps take predetermined bone cuts on the mandible. So the guides need to be fixed, and the bone cuts need to be taken flush with the guides, both anteriorly as it's being done here. The bone is being cut along the guide, and here towards the condyle. Again, just the condyle with some amount of bone is being saved for the fixation of the mandible. Now once this cut is given, the specimen needs to be delivered. Now the mucosal cut on the floor of the mouth is being given, taking into consideration that we need to have a soft tissue cover here as there is bone erosion that was seen in the CECT. So we need to have a good soft tissue cover on the medial aspect as well. That is the geniohyoid muscle along with the anterior belly of digastric that is being cut. And as we cut the muscles on the floor of the mouth, there will be a lot of venous supply that needs to be taken care of. This is the anterior belly of digastric again being cut inferiorly. You can place your fingers to make sure that no structures beneath are inadvertently injured. That is the geniohyoid and some amount of the mylohyoid muscle that is being cut. That's the geniohyoid that is being cut. Once that geniohyoid muscles are cut entirely, the mylohyoid comes into view. And you will also see the sublingual glands, which will be taken with the specimen. Yeah. While the mucosal cut is given one step at a time, the mucosal cut and the soft tissue cut is taken from anterior to posterior along, and it is taken together. First the mucosal, then the soft tissue, then again you go posteriorly, take mucosal and the adjacent soft tissue. This way the entire cut is completed. And in this case the lingual nerve is also sacrificed because the disease is there in the retromolar tribune area. It's very important to place the fingers here as you go medially towards the styloid process to avoid any inadvertent injury to the internal carotid artery as they stay above the styloid process. Now this is the medial pterygoid muscle that is being cut closer to the medial tuberosity, which forms the medial soft tissue margin. The tuberosity is cut as high as possible close to the pterygoid annulus by keeping your finger or some instrumentation there to avoid a blind cut as we proceed deeper. Since this patient had disease all the way, that is the mandibular nerve coming out of the canine going up superiorly, which is taken as high as possible, and that was sent for frozen, which came as negative. That is the specimen that is being seen, and we are ascertaining the margins, both mucosal and soft tissue, in all dimensions, and this was confirmed by frozen. This was a class 2 defect based on the Brown's classification. And this patient underwent reconstruction with a free fibular osteocutaneous flap. That is the guide for the osteotomies on the fibula, which was fixed to the laminate mandible. And that's the post-operative picture at the end of the surgery. And the patient underwent tracheostomy as well. Acknowledgements to all involved in the process of making this video. Thank you for your attention.
Excellent video, but I think the patient was hypertensive. Probably the bleeding was a bit more than what was
normally expected.
So, how do you? This is a question for the students. How do you decide on the bony cuts, like on your clinical radiological examination?
So based on the extent of bone erosion, a rough clinical judgment is you go 2 teeth ahead of where the bone erosion is. So which roughly translates into 1.5 centimeter, 1.5 to 2 centimeters of your bony margin. And that is how, so this goes on either side, both anteriorly and posteriorly.
If there is marrow invasion, you are suspecting perineural spread, that is on radiological examination, one can get an MRI scan to see whether there is disease growing along the inferior alveolar nerve all the way up to the foramen ovale. So if you are in doubt, don't hesitate to get an MRI. Don't have to get an MRI from the skull base to the level of the clavicle. Get a limited MRI cut so that you will be able to visualize what you want to see.
Right.
Thank you. Anything? Any other questions from the audience? Thank you, Pranav.
Thank you. Thank you, everybody.
Just a short interruption. I request our chairperson, Dr. Sunil Sidana, to kindly felicitate our MSDC observer and faculty, Dr. Pranay Pardeshi, sir. Please accept a small token of appreciation from our side.
Moving on with our next video presentation on the topic of white composite resection with ITF clearance. This topic will be presented as a video presentation by Dr. Deepa Nair, Professor in the Department of Head and Neck Surgery, Tata Memorial Hospital. Instead of ma'am, we will have this video presentation conducted by Dr. Amay Pai.
Yeah, Madam again could not come in person because of the exam going on in TMH. So I would request Dr. Amay to kindly present. She has been kind enough to share the video, and she also has a voiceover, so we'll get final input from her as well.
This is an edited
Welcome, sir.
So just to begin with, all these procedures are done for all T4B diseases. They are all advanced stage cancers. They are usually those diseases which involve the RMT, which are going superiorly up to the sigmoid notch, slightly below the sigmoid notch. So we will see in the surgery also that the entire tissue right from the skull base to level 1B, the entire part is taken out in toto so that there is a good clearance. So we'll just see how we go about with that clearance.
This is an edited surgical video of bialveolar resection with infratemporal fossa clearance in a 45-year-old gentleman with oral cancer involving the gingivobuccal sulcus. For surgeons, the infratemporal fossa is an area bounded by the ramus of mandible, posterior wall of maxilla, encompassing the pterygoid muscles, the temporalis, the mandibular nerve, and the maxillary artery. Radiologically, however, this space, along with the masseter muscle, forms a masseteric space. In this patient, the tumor was involving the buccal mucosa, the retromolar trigone, the masseter, the medial pterygoid. However, the supranotch infratemporal fossa, namely the lateral pterygoids and the insertion of temporalis, were free. Hence, a plan of bialveolar resection with infratemporal fossa clearance, neck dissection, and reconstruction was offered to the patient. Before starting the surgery, the soft tissue extent of disease should be marked and soft tissue and skin involvement circumscribed with margins. After neck dissection, the mucosa is evaluated and a wide 1 centimeter mucosal margin marked. This is done in order to achieve at least 5 millimeters margin on the final histopath. The incision is deepened and connected with the skin marking across the lip. Flaps are raised, taking care to have adequate soft tissue on the specimen side. This ensures that margins are not closed in the submucosal plane. Similarly, on the superior aspect, mucosal incisions are marked onto the upper gingivobuccal sulcus. The skin is connected across the upper lip, taking care to have adequate soft tissue margins. In this patient, the masseter was completely involved, and hence the soft tissue margins at the masseter were much higher. The entire masseter is resected in the specimen due to gross involvement of the masseter on the CT scan. Facial vessels are identified and ligated in this masseteric space. The masseter is divided along the posterior border of the maxilla onto the zygoma. The skin is circumscribed and the posterior flaps are elevated, connecting it to the neck incision. The posterior part of the mandible is freed from the parotid by dividing the investing fascia. The buccal branch of the facial nerve is identified along with the Stenson's duct. In this case, as the tumor was involving the masseter and the buccal branch was traversing the masseter at the point of maximum involvement of soft tissue, it was decided to sacrifice the buccal branch. The Stenson's duct is identified and ligated. This is done to avoid post-operative parotid fistula. While dividing the masseter of the lower border of the zygoma, it is very important to stay flush to the lower border in a subperiosteal plane in order to prevent injury to the zygomatic branch or the facial nerve. Once the posterior fibers of the masseter are completely divided, the tendon of the temporalis is next visualized, as well as the buccal pad of fat, which continues as the retromaxillary fat pad. Here, the infratemporal fossa connects with the temporal fossa. The posterior border of the mandibular condyle is identified. The maxillary artery is ligated near the neck of the mandible in order to reduce bleeding during surgery. Dissection of the condyloid process continues by dividing the remnant fibers of the masseter muscle and the capsule or the temporomandibular joint, thus exposing the glenoid fossa. The mandibular cut is next taken with a reciprocating saw, here at the level of the lateral incisor. The mandible is then retracted laterally, releasing the digastric and the mylohyoid. Mucosal incision is taken in the floor of the mouth, and the sublingual gland and the lingual nerve are reflected medially. In this case, as the lingual nerve traverses beneath the tumor, the lingual nerve is sacrificed. The mucosal cuts onto the upper alveolus are taken beyond the level of the tonsil, staying very close to the upper alveolus, trying to preserve as much as the palate as possible. Bony cuts are taken with a reciprocating saw, again very close to the upper alveolus. Similarly, on the maxillary side, exposing the posterior lateral wall of the maxilla completely, the alveolar cuts are made and connected, and small osteotomy is done to disjunct it from the pterygoid process. At this point, it's important to take care of the greater palatine vessels which may bleed The next step is to rotate the mandible outwards and downwards to elongate the medial pterygoid muscle. The posterior border of the mandible is freed by dividing the stylomandibular ligament. Here, one can identify the inferior alveolar nerve between the temporalis and the two heads of the lateral pterygoid muscle. Medial rotation of the mandible is done to release the last remaining fibers of the temporalis muscle. This releases the coronoid process, and now by rotating the mandible laterally again, the pterygoid muscles are dissected off the lateral pterygoid plate. This is the medial pterygoid being dissected off. And next, the lateral pterygoid from the lateral surface of the lateral pterygoid plate is dissected. Now, the only thing holding the specimen back is the foramen ovale and the mandibular nerve. Dissecting of the mandibular nerve flush with the foramen ovale at the greater wing of the sphenoid ensures that the whole specimen comes off en bloc. Troublesome bleeding from the foramen ovale can be controlled with some bone wax. This is the styloid process, which is now exposed. The styloid group of muscles, the posterior belly of digastric, the pterygoid plates, the maxillary sinus, the pterygomaxillary fissure, the greater wing of sphenoid, the temporal fossa, the glenoid fossa, and the foramen ovale. This connects the infratemporal fossa with the parapharyngeal space, and behind the styloid you can actually palpate the internal carotid artery. This is the specimen with adequate mucosal and soft tissue margins. This patient was reconstructed with pedicle reconstruction. Thank you for viewing this video.
So one of the hallmarks of a good ITF clearance is that the entire condyle is covered by muscles. So that is where we know that the entire ITF right from the skull base has come down. So the aim to do an ITF clearance is to get the entire group of lateral pterygoid, medial pterygoid covering the condyle along with the glenoid fossa, articulating disc and everything down. So it should all be covered by strong muscles.
I think a wonderful video and self-explanatory actually. Beautiful video. Any questions from the audience?
Ratan sir has a question.
So the technique described by madam is medial to lateral.
Right.
There are two techniques. One is lateral to medial, medial to lateral. Again, whether condyle needs to be preserved, the Neera Trivedi group, they do not remove the condyle. They
Right.
cut at the neck and just go to the skull base, cut at the insertion of the lateral pterygoid where it inserts into the neck of the mandible, and then they go to the skull base and go from lateral to medial. And their posterior cut is also behind the tonsil. So don't have to be dogmatic. Change your technique as per the case. In this case, we need not need to remove the pterygoid plates or the posterolateral wall. So one should never be dogmatic. Apply the surgery which is applicable to the patient. But remember, like Dr. Amaya said, you should remove all the masticatory muscles. That is the idea behind doing a compartmental resection for ITF disease. So by this, the imaging, it was a type 1 compartmental involvement, Majan classification 2022. Please read it. He tried to classify the involvement of the infratemporal fossa into 3 types, 1, 2 and 3A, 3B, 3C. So 3C is not many of us would operate.
Yeah, so
Neera
this
Trivedi's classification is also along similar lines, but this is type 1.
So these are all classically AJCC 7, those diseases which we usually earlier used to term as inoperable. So we have actually slightly gone beyond, we have started operating all these cases. So that is where we have started stretching our surgical boundaries. Earlier all these cases, T4Bs, if we take stage 7 or edition 7 of the AJCC, these are all termed as inoperable cases.
The type, so AJCC, now we have the AJCC 8th edition. AJCC 7th edition made it moderately advanced and very advanced. 6 was inoperable and operable. 5 never had any subclassification. So the Licitra trial was based on AJCC 5, not even 5, I think it is 4. So there was no subclassification of T4s. Yeah. It was all T4s. Yeah. Involvement of prevertebral, involvement of ITF, all were classified as T4s. They subdivided it into 4A, 4B, which was inoperable, operable. Right. 6 was advanced, very advanced. 6 was inoperable, operable. 7 was advanced, very advanced. 8 is 4A, 4B. Yeah. So 20 years ago, most of these cases were inoperable. Yeah. You were right.
Thank you very much. Thank you, Amay.
Thank you, sir, for conducting this session by Dr. Deepa Nair. The next topic for our video presentation is on reconstruction of buccal mucosa defects by Dr. Tanmay Joshi, Consultant Plastic Surgeon, Apollo Hospital, Belapur. Welcome, sir.
सर ऑडियो आहे गुड
Yeah, so good afternoon everyone. I'm going to have a brief presentation on microvascular reconstruction of buccal mucosa defects. So we have to classify all defects into subclasses or subcomponents. First is the mucosa and skin, which are the X and Y axis of the defect. The subcutaneous tissue, which will act as the Z axis, and the bone, if present, or without bone. Special considerations are to be given for tongue, lip and palate. So what is a free flap? It is a tissue which is harvested based on some artery, known artery, and the veins accompanying it. It is disconnected from its origin. It is shifted to a new site, and restoration of the blood supply by microvascular anastomosis establishes the circulation. You assess the defect in terms of the X and Y axis and Z axis as explained. After assessment of the defect, you choose the right flap so as to give the best functional outcomes as well as aesthetic outcomes. The most commonly done free flaps or workhorse flaps are the free ALT, the radial forearm and the fibula flaps. Mostly these cover most kinds of defects. Most components of defects are well covered by these. So donor assessment is done. FRAF means radial forearm. It is taken from the radial border of the forearm. You do an Allen's test to check the vascularity of the hand. Check for cephalic veins. It may be involved, you may have IV cannulation or blood which is taken out from that hand. Patient may have atherosclerosis which might be seen on X-rays. And X-rays are also done to rule out forearm fractures which may be plated and have some vascular component. The next group is a thicker soft tissue flaps which give soft tissue defects the required flap. The thickness of the flap is measured, and accordingly you can do a variety of flaps like the anterolateral thigh, medial sural, or a skip flap. You have to do a perforated Doppler, check for varicose veins and if there are anatomical variations. A fibula flap, you require varicose vein assessment. Doppler is done for perforator assessment as well as peroneal magna. Atherosclerosis is ruled out and check for fractures and polio. So these are the workhorse flaps which we commonly do. So for free radial forearm flap, as I explained, you have to check the anatomy of the arteries. Look for dominance of hand, whether right or left-handed. You also check for fractures, cephalic veins, whether patient has had any chemotherapy-related injury, and Allen's test. This is one of the radial forearm harvests. I'll just run through because I have a fibula video which I would like to show you. This is a reconstruction of one patient with mucosa and skin defect covered with a radial forearm. This is an anterolateral thigh flap, straight line incision on the thigh. Look for perforators, dissection of perforators and pedicle. You get the flap with no muscle and the entirety of soft tissue, and you have a primary closure. So advantage of a flap and advantage of a ALT over a FRAF is that you have a primary closure of the donor site as well as it is hidden even in half trousers. Usually Indian males or females will have short clothing, so a FRAF donor site is not a cosmetic donor site. One of the patients reconstructed with intraoral defect with ALT, another with a skin defect and intraoral with ALT. TDAP flap is also used. This is just to show you that if you have a bad donor site or it's not matching, you can do other kinds of flaps. Bony reconstruction, what are the advantages? First is like for like replacement, obvious cosmetic advantage by putting bone at that spot. You can also do dental rehabilitation, occlusion of the remaining teeth is maintained. Also you can put implants or dentures on the fibular donor site. It provides for tongue support and lip support as the lip would fall without the presence of a fibula. Another advantage is when it is a vascularized fibula, you have a resistance to volume loss. Fat and muscle will get absorbed, but bone will stay as it is, so there is a resistance to volume loss. And it gives anchorage to soft tissues. Fibula is a workhorse because it has an expandable bone, a good quality of cortical bone is available with a long length, and it has periosteal and endosteal blood supply, which you can use for multiple osteotomies. One patient with intraoral reconstruction of fibula giving a good contour cosmesis as well as mouth opening is preserved. Another with a skin paddle which is given for skin cover by division based on perforators. Some other central segment, lateral segment defects. I'll show you this as a complete video. You can also do flap thinning for buccal mucosa defects. If you have a smaller soft tissue component, you can thin the flap. If you have a heavy patient, you can thin the flap. Chimeric flaps can be used in which chimera means two animals together. So you have got two perforators supplying the same skin paddle. You can divide it based on that and reconstruct either inside two kinds of defects or inside and outside. You can also use supercharging principle in which if you have two perforators joining two different pedicles, you can join them separately to two microvascular anastomosis. There are some challenges to free flaps, sometimes previous surgery, radiotherapy, a resected or ligated IJV or external carotid, previous failure of pedicle or free flap, medical comorbidities and unfavorable donor sites. Sometimes there are obvious complications are not uncommon, vascular insufficiency around 3 to 4% patients, OC fistulas around 8 to 10% patients, arterial blowouts, carotid leaks, chyle leaks and implant exposure we have discussed. Osteoradionecrosis can happen post-RD. Some recent advantage is 3D model resection as well as reconstruction with fibula. We just saw one patient. Spy-cam and thermal imaging to understand the vascularity post anastomosis. Can use coupler devices for joining veins as of now, and invasive flap monitoring with implantable Dopplers. I'll say that plastic surgery in the World War II era was a constant battle between blood supply and beauty. My professor says that with microvascular reconstruction, it is a camaraderie, it's a friendship of blood supply and beauty. And our professor from Tata used to say, as resection adds years to life, reconstruction adds life to those years. Thank you. I'll just show a video. I have time for video?
याच्यामध्ये ॲपलमध्ये जावं आणि सिस्टम सेटिंग डुप्लिकेट करायला लागेल ना.
हे काढा ना. आता परत एकदा
कट करू?
नाही ठीक आहे. फोटो होता का?
नाही, व्हिडिओ.
तिकडे झाले ते, तिकडे कनेक्ट झाले. तिकडे कॅन्सल करावं लागेल. माऊस तिकडे ना ना, एक मिनटं. माऊस डिस्प्लेच नाही, खालती होतं स्क्रीन समोर.
करा परत एकदा क्लिक करा.
आता काय?
इकडे नाही ऑप्शन. मी कधी यूज नाही करत ना, सगळे प्ले करायचं.
सर याला परत हे करा, ते ॲपलवर.
यालाच क्लिक.
हां ना, याला पहिले ते बंद करायला लागेल ना. एक मिनिट.
हे रिमूव्ह करून द्या, हे प्ले करा, नंतर लावा.
तरी पण ते तसंच राहणार. कट करायला लागेल.
कट करून केलं? कट करून
हे झालेलं आहे ना.
हो, असं झालं. आता बघ,
हे काय आलं, कॅन्सल कर.
ते सोडून ते ओपन कर.
लावू का?
लावा. यायला पाहिजे.
ते डुप्लिकेट मिररिंग ऑप्शन असतं ना. माऊस कुठे गेला?
त्याच्यावरच जाते.
स्क्रीन मिररिंग. डिस्प्ले सेटिंग नाही, व्हिडिओ प्ले केलं, प्ले केलं.
पेनड्राईव्ह आहे ना, इथे लावा.
ते मग लोगो नाही लावू शकणार म्हणून.
टाईम आहे ना,
दुसऱ्या पीसीवर टाकलं आपल्या.
हां तेच ना.
पेनड्राईव्ह में घ्यायचं आहे ना.
थोडं एक सेकंड थांबा. डायरेक्ट F3 बटन दाबा डुप्लिकेट
ते नाही आपल्या ह्याच्यामध्ये होतं ते
ह्याच्यात नाही
प्रेझेंटेशनमधूनच प्ले करून बघतो थांब.
ओके हां प्रेझेंटेशनमधून होईल ओपन.
मिरर नहीं हो रहा है सर, तो वो दूसरे ट्रांसफर में सर उसमें ट्रांसफर करना.
परीक्षा के लैपटॉप में है.
हाँ घ्या सर पेन ड्राइव लागू
कनेक्ट करना ये पे.
नहीं पसंद.
सर का कहाँ पर है इसमें वीडियो?
सर का नाम
कहाँ से? देखिए तो
इसमें स्पीड बढ़ा सकते हैं क्या? स्पीड ऑफ वीडियो
दूसरे प्लेयर में डालना पड़ेगा सर.
अच्छा ठीक है.
साउंड नहीं है सर. ठीक है ना 11 मिनट से थोड़ा थोड़ा करके.
Yeah, ठीक है. Sorry for the delay. I am going to have a fibula harvest video. So there are two approaches to fibula harvest, an anterior approach and a posterior approach. This is a demonstration of a posterior approach fibula. So this is the defect that we were reconstructing. This is the position in which the leg is kept. We start with the posterior incision first. Incise the skin and subcutaneous tissue, reach the fascia. Then we enter into the plane. Posteriorly we have the gastrocnemius muscle and the soleus muscle, and anteriorly we are trying to keep the skin paddle with the fibula septum, posterolateral septum. We ligate all the branches of the peroneal artery which are supplying the soleus muscles. After ligating all the branches, we look for the posterior tibial artery. If we have a posterior tibial artery which is present, then we at least rule out the type 2 peroneal magna and we can proceed with the flap harvest. With the anterior incision, we would need to do a bone resection before understanding whether the peroneal artery is present. This is how I avoid any kind of osteotomies in the presence of peroneal magna. Though we have identified the tibial nerve and the posterior tibial vessels. We've seen 2 or 3 perforators which are originating from peroneal artery, entering the septum and reaching the skin surface. We dissect the perforators through the muscle to identify the course. Incision on the anterior border of the skin paddle. Here it is a suprafacial dissection. We safeguard the superficial peroneal nerve which will come in the lower part of the flap. Superficial dissection is continued till we cross the superficial peroneal nerves and then we can incise the fascia. Now the peroneal muscles are dissected off the fibula, they are attached onto the fibula. Once you remove them, we will reach the anterior compartment. We've got 2 surgeons operating here, 2 quarters. This is one of the videos showing teamwork. So now we incise the anterolateral septum and enter the anterior compartment. Here we will encounter the extensor muscles, the tibialis anterior and the anterior tibial arteries and veins. Once you identify them, you can also proceed in reaching the intramuscular septum. And the interosseous membrane comes into view. Once you reach this, then we plan the lower osteotomies for harvesting the fibula. This is the lower osteotomy. We are using a saw. You can use Digley saws or reciprocating saws as per availability. After doing the upper osteotomy, you reflect the fibula backwards. You incise the interosseous membrane to reach the deep posterior compartment. Your main peroneal vessels will come into view in the lower part. We remove the tibialis posterior muscle, which is attached to the deep surface onto the fibula fascia and fibula muscle, fibula bone, sorry. All the branches which go into the tibialis posterior are ligated meticulously. We safeguard the tendons by inverting. So the deep posterior septum is incised for the last part of the harvest. We'll see at this step we'll be able to see the posterior tibial vessels if we only do an anterior dissection. And they are more commonly absent than the absence of anterior tibial vessels. Like at the lower end of the peroneal vessels, cut off the distal end of the FHL muscle, dissection of the perforators. So in this part we do a in situ osteotomy by keeping the vascularity intact for a little longer. We check the septums. We fix the fibula here. After fixing the fibula, we do the inset and microanastomosis. So advantages of posterior incision: absence of posterior tibial vessels can be identified in a slightly earlier stage to avoid further dissection. Many times we have identified posterior tibial in the opposite limb, so we can do a safe harvest of the opposite side. It's not bilateral and it's all teamwork. Thank you.
I think a very beautiful video, Dr. Tanmay.
Thank you.
Thank you for the wonderful
Thank you, sir.
Any questions? Maybe Priyanka can ask you some questions. Thank you.
Okay, thank you, sir.
Yeah, one second.
So,
Yes.
very good presentation. So, I want to ask you about which is the easier technique for the beginner to learn, anterior or the posterior?
So, I did my MCH in Nair. We started off with posterior. Then I did 3 years in Tata and I switched entirely to anterior approach. And after 2 years, I have now come back to posterior. So each approach is that way easy. Posterior approach, the only drawback is the first 20 minutes. You have to bend down your back a bit. It's very easy. It's not at all difficult. It's the same thing done reverse manner.
But which one will you recommend for the beginner to learn?
Again, if you have seen 10, then definitely you can do any kind of approach.
Okay.
There is no problem in doing posterior. It's not that anterior approach is easier in any situations.
Okay. And which is the most common complication?
It's only that because if you proceed the entire thing from anterior, your back is straight, so you last longer.
And which is the most common complication you have encountered in harvesting the fibula flap?
In harvesting the femoral flap, the main only complication is peronia magna, in which posterior tibial may be absent. The disadvantage is that even if anterior tibial is present, the major supply to the entire posterior compartment is either posterior tibial or peroneal. Once you remove the peroneal and posterior tibial is absent, it will lead to necrosis of the posterior muscles. So that's a sort of relative contraindication. So that is one. Second, not really as a complication, but atherosclerosis is there in around 10% patients, which may preclude the harvest totally. We try to do the anastomosis, but at the end of 10 days, we feel that we would have been better off not doing a fibula.
And one more last question.
Yes.
In the benign tumors, normally we do reverse planning, like we find out where the teeth will come first and then the bone and everything like that.
Yes.
In malignancy, is it happening like you are doing reverse planning or?
No, we do. I have not explained here, but there are indications for doing same side harvest versus opposite. So if you are doing a same side harvest, for example, left mandible and left fibula, then you would get the correct surface above for dental rehabilitation. If we use the right fibula for the left side, we'll have the sharp surface above, which will be difficult to have a dental implants. But if you have a larger mucosal defect which runs onto the palate, or maybe having a hemiglossectomy or more defect onto the tongue side, then a same-sided harvest would lead to a very large skin paddle requirement. And in that case, because of the anatomy, the septum is attached on one surface, so it has to run all through the bone and go in intraorally. So if you use the opposite side, you will require a much smaller skin paddle. So if you are looking for dental rehabilitation, stick to same side. But if you have a large mucosal defect, or if you have to also address a large skin defect, go to the opposite side. It's safer.
Thank you.
Thank you. Thank you. Sorry for the delay.
Thank you, Dr. Tanmay Joshi, sir, for the wonderful video presentation. The next topic that we have for today is on rehabilitation in oral cancer defects by Dr. Sandeep Gurav, the professor in HOD in Department of Dental Prosthetic Surgery in Tata Memorial Hospital. Welcome, sir.
So good afternoon all. Thank you for the organizers for giving me an opportunity to present on dental rehabilitation of oral cancer patients. It is close bonding with MGM. I have worked here for at least 6 years of my life. I started my career here and then moved on to the Tata Memorial Hospital. Since last 10 years I am there. So when I started my career here, that was a great opportunity to work with close coordination with oral surgery department, and we did some cleft cases here, and that was when I was integrated with the maxillofacial rehabilitation. And then for going ahead now, my work is mainly oral cancer rehabilitation. So acquired defects, that is the cancer rehabilitation, we do rehabilitate with all the kind of maxillofacial prosthetics. So which all process we can do. Internal prosthetics, for example, obturators. Obturators, we have 3 types: surgical obturator, interim obturator, and definitive obturator. Then about the mandibulectomy, we rehabilitate the patients with bite gate prosthesis for the patients who have not undergone osseous reconstruction. Then glossectomy patients can be rehabilitated with palatal augmentation prosthesis or glossal prosthesis. Then we do fabricate some radiation stents for a betterment of the patient during radiation. And extraoral prosthesis like conventional extraoral prosthesis, ear, eye, nose, cranial prosthesis, and unconventional prosthesis like patch prosthesis and lip prosthesis. All these comes in the umbrella of dental and prosthetic rehabilitation of cancer patients. So coming to the first, the prosthetic management of maxillary defects. There is always a debate whether the patient of maxillectomy should be treated with surgical reconstruction or a prosthetic rehabilitation. And More or less, it is a consensus that if there is high-level maxillectomy involving the floor of the orbit or involving the orbit or involving the zygoma, more of a zygoma, and it's better to reconstruct this with the surgical reconstruction. The defects which are crossing midline, not having much of the palate or edentulous patients. However, prosthetic reevaluation is preferred in low-level maxillectomies, Brown's class 1, class 2, sometimes class 3. The patients who are having strong abutment teeth which will support the process is better way. Hard palate is preserved, and many patient-related factors. If the patients are not suited for microvascular surgeries, then the prosthetic rehabilitation is always an option. And there are obviously disadvantages of both the things. The donor side morbidity is always there with the surgical reconstruction, and availability of the microvascular surgeon may not be there in the interior parts. Also the cost involved in the surgical reconstruction. Whereas the prosthetic rehabilitation, we can have good tumor surveillance, we can remove the obturator, see how is the progress and the healing, everything. It gives very good aesthetic results and functional outcomes. But the only drawback is the dependency. The patient is completely dependent on your obturator. One day obturator is missing, patient cannot eat food. So coming to the phases of treatment in maxillectomy, it is generally divided into 3: surgical obturator, interim obturator, and definitive obturator. For the surgical obturator, you have to refer the patient pre-operatively. So in the pre-operative setting, we make the impressions, we discuss with the surgeon what is the line of resection, we modify our cast, and we keep a surgical plate ready or surgical obturator ready, which then inserted at the time of surgery. Now this obturator is a flat plate. It does not enter into the defect. It's just a flat plate, but covers the complete defect horizontally. It does not contain any teeth as far as possible. Anterior teeth can be placed in this surgical obturator. It provides a matrix for the surgical packing. It supports it. It reduces the oral contamination of the wound during healing, restores palatal integrity, permits some amount of deglutition, and sometimes we can remove the nasogastric tube immediately after this. Most importantly, it reduces the psychological impact of the surgery on the patient, because the patient, once they wake up after surgery and suddenly the palate is not there, and this surgical obturator gives us a lot of psychological benefit to the patient, and the patient can speak and communicate with their relatives. That is very important. If the surgical obturator is not placed on the day of surgery, we can still delay it maybe after 3 to 5 days. Once the bolus is removed, still we can place a surgical obturator with the same advantages. And coming to the interim obturator, once the healing is sufficient, we have a mucosalized surface around 12 to 15 days post-operatively. If the surgical site is matured enough, we have to make the impressions, capturing the complete defect, and then a interim type of process is done. Now this process enters into the defect. It covers the defect vertically as well as horizontally. Now with this, there won't be any regurgitation, and patient can be off the nasogastric tube. Patient can eat and speak comfortably. We do not give any teeth in this interim phase, because this will create a lot of forces on the healing wound. And once the wound is completely healed, completely mucosalized surface, epithelialized surface, then you can go ahead with the definitive obturator. The timing of definitive obturator varies. If the patient is not radiated, we can go ahead with the definitive obturator 6 to 12 months of the 6 to 12 weeks of the surgery. But if the patient is radiated, then we have to wait till the radiation effects goes down. It may be 6 months or 1 year post RT. So the definitive obturator can be made with the acrylic resin, or we can use a cast partial framework for a better function and better outcomes with this. These are some of the cases wherein we have used a cast partial denture framework and tooth colored clasp, and we can actually give a very good, beautiful processes in definitive setting for these maxillectomy cases. Now here, since this conclave is mainly related to the surgical fields, I would like to comment on these things. What are the maxillary defects which are amenable for the obturator processes, which can be easily rehabilitated? One is the patient should have strong abutment teeth. The first abutment tooth is very important. So first abutment tooth, mainly canine or central incisor, are the good abutment teeth. Multiple periodontally sound teeth, they are good for the obturator processes. Split thickness skin graft on the lateral side of the defect. This gives a lot of support from the lateral side. It will not allow the obturator to tilt from the lateral side, and will keratinize the junction between the hard palate and the defect. This can be achieved with few modifications during surgery. One is trans-socket resections. You have seen so many videos, and most of all the surgeons have removed the tooth and then take the incision on the alveolus. So this is very important. This will preserve your alveolus adjacent to the strong abutment tooth. If you take the incision adjacent to the tooth, this will happen. The adjoining tooth, which is the first abutment tooth, as I told, that's very important. It may lose the bone support and it has to be extracted afterwards. So ideal abutment teeth with long roots preferred, depending on the oncological safety. It's a premolar, canine or central incisor. If it is crossing the midline, then the contralateral central incisor, contralateral incisor, lateral incisor, and then the canine. If it is going beyond the canine, it's better to reconstruct the defect rather than depending on the obturator processes. Now this is a split thickness skin graft you can see here, and it creates a scar band over here, and this is very important for the obturator for retention. Otherwise the obturator will tilt from the lateral side. And you can see it here when the split thickness graft is placed and when it is not placed, and if the patient is using the obturator processes, what kind of delayed effects these patients might face. This is what I was talking about. You have to extract the tooth and then take the incision along the socket. If possible, take a mucosal incision and then the bone resection, and just turn this mucosal incision inside like this. This will give a good keratinized surface at the junction between the remnant palate and the defect. And this is very important for the obturator processes. If you see here, it is not, the keratinized mucosa is not yet developed, and this creates a lot of ulceration during the obturator processes wearing. So if you see this diagram, these two areas are very important. One is this lateral junction with the skin graft, and one is this junction where the obturator processes tend to tilt. One more thing is to attempt to close the defect with the deficient soft tissues. This leads to this kind of small fistulas, quite difficult to make any kind of obturator. Then closure with the muscle flaps. Now here we cannot do any dental rehabilitation. Patient has to remain without teeth forever. Nowadays we can place zygomatic implants, but still it's quite difficult to rehabilitate these cases. And some of the structures to be electively removed during the surgery after the oncology resection. One is these small bands of soft palate. If they are less than 1 centimeter, they are of no use for the function. It does not contain any innervation, and this is a hindrance for the obturator placement. The inferior turbinates. If you place the obturator on this will keep on traumatizing the patient. One more thing frequently asked, when to plan the implants in these patients. You can plan the implants if the patient is edentulous. You have to plan implants either pre-operatively or primarily during surgery. For the edentulous patients, very important to give some kind of support, because obturator placement may not be easy in these cases. We can use 2 or 3 implants for a good support. Implants can be placed in fibula to give a good prosthetic outcomes. Here now the resection has crossed the midline, it has gone to the premolar, hence the fibula reconstruction was done and the dental implant. Nowadays we can use zygomatic implants for the complete rehabilitation when the bilateral maxillectomy, total maxillectomy is done. Zygomatic implants are the good option for these patients. Coming to the mandibular defects. Now mandibular defects are mainly of 2 types. One is the continuity defect, which are generally marginal mandibulectomy, and discontinuity defect, which are segmental mandibulectomy. So marginal mandibulectomy, the prosthetic rehabilitation is quite simple, straightforward. It is just like a partially edentulous artist. We can make a denture, acrylic denture or a cast partial denture. Now this is one of the case we did here only. We have published this case. A simple cast partial denture, we can rehabilitate these cases. An important thing in marginal mandibulectomy, you have seen Anuja ma'am's video. She has extracted the teeth and then done the marginal mandibulectomy. If we do not extract the teeth, this will happen. The root pieces remain inside, and this is generally covered with the flap. The patient comes to the dental department for referred by the radiotherapist. Now we cannot extract these teeth because they are already below the flap, and these are good source of infection, may lead to the ORN afterwards. So coming to the segmental mandibulectomy. In opposite to maxillectomy, the segmental mandibulectomy should be reconstructed as far as possible, because good functional and cosmetic rehabilitation may not be possible only with the prosthesis. What are the problems of the soft tissue reconstruction? First is the deviation, because one side mandible is removed, obviously the mandible tends to deviate on the resected side, and patient cannot close it in occlusion. There is something called as a frontal plane rotation. If you see this, this is called as a frontal plane rotation, because there is a continuous pull from the others on these muscles. When the patient is closing, the bone tends to have a orthodontic effect, and there is a open bite on the other side. How we treat these cases with the bite guide prosthesis. Bite guide prosthesis is a simple prosthesis which is placed generally on the palatal side of non-resected side, which will allow the mandible to guide in the position, in the occlusion. This is more of a training prosthesis rather than a rehabilitation or functional prosthesis. So this is how the bite guide prosthesis is placed, and patient is trained how to use the bite guide prosthesis in the position. Patient has to use this prosthesis at least for 6 to 12 months. If the patient is radiated, then we have to extend further. Coming to the glossectomy rehabilitation, as you know, there are two types of main defects: partial or total glossectomy defects. Partial glossectomy defects are quite difficult because tongue is a moving organ. We cannot put any prosthesis on the tongue. Here the problem is the tongue cannot reach the palate, so the patient's speech as well as swallowing is affected. So we can place palatal augmentation prosthesis which deepens the palate a little bit, and these patients can pronounce better, and the functions can be restored back to the normalcy. These are very good prostheses, particularly the public speakers and teachers, because these are the individuals which are dependent on continuous speech. Total glossectomy, now these are quite difficult cases because tongue has multiple functions and it cannot be restored directly with the prosthesis. We do try to make some prostheses with it, but these are stagnant prostheses. They can't move. If we add in speech, it will give a lot of comfort to the patients, but it do not have any mobility, no taste bud, no sensations. So how we make these prostheses? We make the upper lower impressions, we make the wax patterns, we communicate with the speech therapist, do necessary adjustments, and then plan this processes with the help of resilient soft liner. This is a little softer material, so whenever a patient is swallowing, patient has to close the mouth and apply a little pressure, and patient can swallow it in a better way. We require a lot of training for use of these processes. We are dependent on speech therapists for evaluation of tongue processes. They use various tools to check the tongue process, how the tongue process is. Now here are two videos. This is without tongue process. If you see, there is a lot of pulling of the fluid at the floor of the mouth, and this is with the processes. You can see there is no pulling near the floor of the mouth. So even though the tongue process is not a functional or a moving process, still it helps the patients to degrade it in a proper way. So on to one more topic, that is the implants in head and neck cancer patients. Now when these implants should be placed? There are two ways. One is the primary dental implant and the secondary dental implant. Primary is the setting when we are doing the resection and reconstruction. At that time we can place the dental implants, or we have to wait for sufficient time after surgery, 6 months, 12 months, and then we can place the dental implant. That is the secondary dental implant setting. The primary is mainly preferred in benign cases or small lesions wherein a tumor is resected. The fibula here, it is harvested, and we have placed 3 implants in this patient, and young boy with a benign tumor. We have replaced the teeth after 6 months. Advantages, definitely there is a sufficient time for osseointegration. If the patient is planned for radiation, still the implants get integrated beforehand. If you are planning the secondary dental implants, obviously because of radiation, the implant failure rates are very high. Disadvantages, The implant malpositioning is the most important disadvantage because we don't know what will be the exact appearance of the patient after complete healing. And sometimes we cannot use the implants for the final processes. So there are reports like around 25 to 40% of the primary implants can never be used for the final processes. Backscattering, around 15% of increased radiation dose is noted around the dental implants when the patient undergoes radiotherapy. So for that, the secondary dental implant is a standard protocol. It is just like any other dental implant procedure can be done under LA on a dental chair. We replace, here we have placed 4 implants and a hybrid type of processes for this patient. Advantages, it allows more comprehensive assessment of the disease, oral functions and the patient's motivation. Main disadvantages, these implants are basically planned after 6 months or 1 year post radiotherapy. 6 months after, if the patient is not going for radiotherapy, and 1 year we have to wait post radiation. By the time patient gets emotionally and psychologically drained and may not go for the complete rehabilitation. And obviously after radiotherapy, the patient's vascularization and regenerative capacity of the bone is decreased. This leads to the failure of the dental implants. If you see the dental implants in radiated jaw bones, as compared to non-radiated jaw bones, if you have the success rate of 95% in non-radiated jaw bones, we have the success rate of around 70% in radiated jaw bones, even with the fibula also. Coming to the advancements, now as I told that we don't know what will be the exact healing after complete dental implant placement and the fibula. We now have CAD/CAM planning and the dental implant rehabilitation, with which we can plan the case along with the resection and reconstruction. Now this is the fibula guides, fibula tray, and along with that we can plan a dental implant placement guides. So this is the resection, reconstruction and the dental implant placement in the same day with the help of CAD/CAM plan designing. Moving ahead, nowadays there is a recent advancement of join-a-day. We can and what is the exact length of the implants we require. We have placed the implants in the leg itself when the fibula is not detached from its pedicle. And this is the final process on the same day. So the patient comes out with teeth from the OR. So this is a newer advancements in join-a-day. Coming to the one more topic of discussion about the rehabilitation of cancer patients, the external processes. These patients do face some kind of facial deformities, which should be addressed because these patients cannot face the society with facial deformities. This can be planned with the silicone processes. Here the nose is planned and the orbital process is given. You can have combined defects like maxillectomy and the orbital defect. Sometimes there are failures in the flap may get failed because of the age or comorbidities or radiotherapy, and then these can be rehabilitated by using a silicone processes. Implants are also useful for rehabilitation of extraoral defects. Now this is a small boy of suffered with a xeroderma pigmentosum. Now these 2 implants are placed, and now over the years we have changed the processes, but the implants are same. So the most important thing here is implants are serving its purpose from 2004 to 2024, and since 20 years we have changed the process over the period of time. This is one more case. Here the patient had osteosarcoma diagnosed in 2019. Patient underwent total maxillectomy along with sarcoma excision and coronarectomy. First tried with the free leg flap, it failed. Then FLD, which again failed. So we just placed an obturator and patient underwent radiotherapy after that. Again, patient diagnosed with a second primary with a high-grade sarcoma of the right periorbital tissues. Orbital extension was done and suprastructural maxillectomy was done. Here again the patient was tried to reconstruct with left vertical rectus abdominis muscle, but it failed again. But the patient has to go for the radiotherapy, re-RT. So patient was referred to the dental department. So initially we are just given a small patch. You can see the obturator here. We have placed one small magnet and we have just closed this defect for time being so that patient can go for the radiotherapy. And after completion of radiotherapy, we have made a final process with the silicone. Now this is also with the magnet retained with the obturator and the final processes. So this is very important to communicate as far as the multidisciplinary approach is concerned, that your prosthodontist should be aware what you are doing and should be in line with the thing. If we plan the case properly with the prosthodontist, then the outcomes will be much better. Thank you.
Thank you, Dr. Sandeep, for an excellent presentation. So one question is that post-radiation trismus is a big challenge. How are you overcoming that challenge for dental rehabilitation?
So post-radiation trismus is a genuine problem, particularly for rehabilitation. So we have to see the patient pre-operatively, that is very important. Patients who are having submucous fibrosis pre-operatively tend to have more trismus as compared to those who are not having. So in our hospital, we have a setup with the physiotherapist, and they start with the jaw stretching exercise at the earliest possible after the surgery. The only way to improve the trismus is the exercise therapy. There is no other way we can deal with the trismus. And trismus is obviously, that's why the primary implants are quite difficult in some of our cases, because we don't know what is going to happen after radiotherapy, how much the trismus is going to be, and whether we will be placing the process or not. But exercise therapy is the only answer for this.
Taking impression and scanning, everything is difficult.
It is quite difficult over the period of time. We have to train the patient and can make some modifications in impression techniques that can be done.
Thank you.
How do you manage the thick skin panel over the implant for second stage?
So thick skin paddles, obviously if we see the fibula grafting, we have a lot of thick skin paddles. We have to go for the debulking procedures. Now there are two ways. One is like we can just debulk it and keep some periosteum intact. There is one article published by Dr. Vinay Kumar et al. Which gives the subperiosteal dissection of the skin paddle, which gives a better results. And then the fibula can be, it granulates and it heals in a very better way. We can have a better prosthetic space in those cases.
Sulcus creation also is a problem.
Sulcus creation is also a problem because then obviously you have to discuss with the plastic surgeon. There is one way is when you are doing the debulking procedures, take the incision on the crest, put that paddle inside so that it creates a sulcus on the buccal side, and then do the subperiosteal dissection.
Thank you, sir. Excellent presentation, mind-blowing pictures. Thank you very much, sir.
Thank you.
Thank you very much, Dr. Sandeep Gurav, sir, for the comprehensive view on the rehabilitation options. To conclude this session on management of buccal mucosa cancer, I would like to first invite on stage our chairpersons for this session, Dr. Sunil Sidana, sir, and Dr. Rattam Shetty, sir. I invite on stage Dr. Srivalli ma'am and Dr. Usha ma'am to felicitate our chairpersons for this session. I would first like sir to felicitate our speakers for the day. Dr. Tanmay Joshi, sir. Dr. Sandeep Gurav, sir. So please. I request Dr. Srivalli ma'am and Dr. Usha ma'am to felicitate Dr. Siddhana sir. Moving further to our third session on video presentations on management of tongue cancer. For this session, I would like to invite the chairperson, Dr. Amay Pai sir, Dr. Sagar Vaishampain sir, and Dr. Arjun Singh sir. I invite on stage. I invite as a chairperson Dr. Amay sir. Dr. Amay Pai sir is an oral oncologist and will be serving as the chairperson for this session. He is widely recognized for his expertise in diagnosis and treatment, and his contributions would add to the impact of our session today. Welcome, sir. And also, I would like to invite Dr. Arjun Singh sir for this session as a chairperson. Moving to the first lecture. The first session of a video presentation is on the resection of tongue, WLE and total glossectomy by Dr. Sagar Vaishampain sir, consultant oral oncologist. Thank you, sir.
सरांचं कोणतं आहे इथे तू फोल्डरमध्ये टाकलाय ना हो हे ग्लॉसेक्टोमी तुम्ही फक्त सेव करू शकता.
So good afternoon everyone, and thank you for this great opportunity. It is always good to be back to MGM, where I actually started my career after my fellowship from Tata Memorial Hospital, and I really thank the organizers for this opportunity. So the speakers before me have already spoken about management of oral cancer. I'll be specifically talking about the surgery for tongue cancer. So basic workup for oral cancer: you map the disease and you diagnose the disease, stage it, and classify as operable and inoperable. So for operable, the best line of treatment is surgery. Tongue cancer, basically we end up doing, you must know 4 terms. One is wide excision or partial glossectomy, where we remove some portion of the tongue, keeping adequate margins around the tumor. Hemiglossectomy, there is another term, compartment resection hemiglossectomy, where you remove nearly half of the tongue along with the extrinsic muscle which suspend the tongue on ipsilateral side. There is another term one must be well versed with, is near total glossectomy. So in near total glossectomy, you practically remove most of the oral tongue and leave considerable amount of base tongue. And total glossectomy is you remove the oral tongue as well as major portion of the base tongue. Base tongue is base tongue, vallecula, and area which is closest to the epiglottis. So moving on, the first step, and which forms the basis of what will be your surgical excision, is you must do examination under anesthesia for the tumor. Now this is a proliferative tumor, early disease on the left lateral border tongue. Under anesthesia, you can examine the patient without patient having too much of pain. You first check the retromoral trigon area and see whether it is involved by the disease, the floor of mouth area and the gingivolingual sulcus. That will determine whether you are addressing the mandible or not, whether you are doing marginal mandibulectomy or a segmental mandibulectomy. Palpate the tongue tissue beyond the induration and find out how much is the extent of the disease. In the same step, you go and try to feel the posterior extent of the disease. For big lesions, this is a particular step which all of us we do. We have shown it in this video, because whenever there is extensive involvement of the tumor, you must palpate the vallecula at the base tongue area and put a finger on the hyoid, and you should be able to. So the finger width is about 1.5 centimeter. So you should be able to feel your finger beyond the tumor. So that means you'll be able to remove the tumor with good margins. So this is a very important step done at the time when we do the surgery. So this is the first step. This will decide what surgery you will do. So examination under anesthesia. This needs to be done with good illumination. Moving on, early lesion. So where the lesion is removed per orally. Neck dissection is mandatory for all operable oral cancer. So when we do examination under anesthesia, we actually mark the tumor and the induration proper, and beyond that we take at least 1 to 1.5 centimeter margin. Tongue tissue shrinks fast, so you go for wide margins. So even if the lesion is appearing small, look how much margin are we taking, and use every tool to get good access to the lesion. So take multiple stitches around the tumor margins to gain adequate counter traction, and approach the lesion in a three-dimensional fashion. So we call this as millimeter cautery. Have good hemostasis. Request your anesthetist to give a good field, and that should also be the most important thing is operate well. So while doing this, keep a check on the deep margin. So keep palpating the deep margin so you get good base around the tumor. So if you are proceeding in this manner, the last structure that remains at the base is the lingual artery. You identify the lingual artery and ligate it and excise the lesion with good margins. The stitches which we have taken for adequate traction and counter traction, they help in orienting the specimen. Once you excise the tumor, again examining the tumor for gross margins. So there is a beautiful paper from Tata Memorial which says that about 7 millimeter of unstretched mucosa beyond the tumor is good enough as that of a frozen section. That's the defect. If the defect in the tongue is not more than 30% of the anatomical structure of the tongue, then you can easily close it primarily. So this defect was closed primarily. So there is a concept, few people keep that area raw, but I would advise to do a primary closure. Now moving on, hemiglossectomy. So basically tongue is a muscular organ that is suspended by extrinsic muscle and primarily muscles at the hyomental complex. So the posterior attachment are the palatoglossus and the styloglossus. The inferior attachment are the muscles which connect the tongue to the mandible anteriorly and to the hyoid bone inferiorly. Once you cut this attachment, the tongue is available in the neck and you can examine the tumor properly and take margins beyond it. Credit of this animation goes to Prashant. So let's consider the anatomy. So you must know the extrinsic muscle of tongue. So the first and the foremost is the mylohyoid muscle that originates at the medial aspect of the mandible. At the fan-shaped muscle in the tongue is the genioglossus muscle, which attaches itself to the anterior superior mandibular tubercles. and posteriorly it is again a thin slit-like muscle, that is hyoglossus muscle. So whenever you are doing any surgery on the tongue, you must be well versed with the anatomy of the extrinsic muscle. The other muscles which also suspend the tongue are the styloglossus muscle, which are at the posterior aspect, and the palatoglossus muscle. So moving on to the surgical part for hemiglossectomy, ipsilateral pull through. So this is the advanced stage oral cancer where the lesion is involving the right lateral border tongue and goes to involve some part of base tongue. However, it is an operable lesion. So you divide the extrinsic muscle in such a way that you will be able to get tongue easily accessible through your neck dissection incision. So any oral cancer procedure, as I told you, neck dissection is mandatory. We prefer taking neck incision in the horizontal skin crease. The incision is less visible. So this is part of neck dissection. Make every effort whenever you are doing tongue surgery and not addressing the mandible for resection. Preserve the marginal mandibular nerve. One may think of ligating the lingual artery in the neck, so that will aid in hemostasis. So sometimes you can get a linguofacial trunk. In this case, we have a linguofacial trunk which was ligated in continuity in the neck before we address the tongue tumor. So this is not a mandatory step, but as a beginner, this will help you while taking margins around the tumor. The bleeding is much lesser. With experience, you may avoid this step. So you finish the contralateral neck dissection. This is an extensive tumor, so hence both the necks are addressed. Again, preserving the marginal mandibular nerve. This is the most important step. You basically through the same step, you release the mylohyoid muscle from the mylohyoid ridge and anteriorly the neck area where you have already done the neck dissection. The next step is releasing the gingival attachment. So here, if you want to do a total glossectomy, you need to release the gingiva from the entire lingual and take a crevicular incision. Most of you are aware of crevicular incisions. So use the crevicular incision, release the gingival tissue from the lingual aspect, start from away from the tumor. On the involved side, release the posterior regions are less charred. Sorry. And these are the speech outcomes.
Count karo. 1, 2, 3, 4, 5, 6, 7, 8, 9.
So you mentioned about the compartment clearance. Just for the sake of the discussion, can you actually?
And there is a concept of what is called as lingual lymph nodes. The lymph nodes which are closely attached to the closely related to the tongue in the submandibular area, sublingual area. So everything in toto is removed. So basically you release the attachments of the extrinsic muscle on that ipsilateral side right from the hyoid, and you take margins at the midline, so and take a margin at the gingiva. So the entire structure of lymphatics, nerve, the vascular structure in the form of artery and the soft tissue is removed in toto.
Sir, do you clip the lingual artery in the neck if you're doing hemiglossectomy?
Use your cautery judiciously and identify the lingual artery. But if trismus is an issue, if I'm doing ipsilateral pull through, then I might as well identify the lingual artery just deep to the hyoglossus muscle at the greater cornu of the hyoid bone and clip it there.
So in trismus cases, you would go for clipping the lingual artery in the ipsilateral.
Thank you, sir. Moving to the next video presentation of this session on reconstruction of tongue, FARAFF and FALT by Dr. Priyanka Chilbule, Consultant Plastic Surgeon, Associate Professor, KJ Somaya Hospital and Research Center. Welcome, ma'am.
To be presenting here. I'm presenting reconstruction of tongue defects. So, as beautifully explained by Dr. Sagar sir, we have already delved into the anatomy, but here I'm just vascular supply, where a very diverse neural supply. There is no organ which mimics the tongue in the entire body, so we only try to mimic something as close to the tongue as possible. Also, on the other spectrum of it is the fact that tongue has a very good and very wide cortical representation as well, which tells the fact that it is amenable to training after reconstruction. Coming to goals of reconstruction, the primary goal is to the airway protection, restore swallowing of the patient, restore speech of the patient, maintain tongue mobility, and for most importantly wound healing for radiation therapy, which has to be done within the available time frame we have for the patient. The technical considerations for reconstruction would be preserving remnant tongue, because function of the tongue after reconstruction depends mostly on whatever is preserved. And for that to happen, we have to use thin flaps to maintain mobility of the tongue. On the other hand, if most of the part of the tongue is removed, like in near total glossectomies or total glossectomies, then we have to reconstruct, then we have to give a neo tongue to the patient, in which case we have to provide thick bulky flap to provide form and volume. Another very important technical consideration, as we all saw, we have to restore floor of the mouth so that there is no there is a proper seal between oral cavity and the neck, and there is no discharge coming to prevent the occurrence of OC fistulas. Next point would be hyoid suspension, because tongue is a mobile organ, it has to stay in place, and there should not be a volume the volume loss. So to prevent that, there are ways to do it. The first is static, which is hyoid suspension, and second form of it is a dynamic form, where we use free functioning muscle flap like gracilis to sort of reconstruct the dynamic floor of mouth. Coming to preoperative considerations, these are the points that we have to look into while posting a patient for reconstruction of tongue. First is mouth opening. The interincisor distance has to be assessed, which only tells us for axis of resection and the reconstruction. The status of dentition, whether the dentition is good or poor, the status of dental hygiene, the occlusion of the patient, and if there is any plan for removal of the teeth to take care of any remaining teeth for next plan, which is radiation. Status of submucous fibrosis, which will tell us the tissue pliability, helping us in inset of the flap. Whether there was any preoperative chemotherapy is an important aspect, because flap selection depends on it. Then assessing all the flap donor sites is a very good idea while we are seeing patient in the OPD. The commonly used donor sites are thigh, forearm, and chest and abdomen. While looking at the forearm, it's a good idea to have done Allen's test and to check whether patient has received chemotherapy and whether there were any cannulas inserted. For chest, we need to assess the presence of gynecomastia for male patient and female patients for bulky breast. So, flap planning according to the defects. Widely, the defects are classified into hemi-glossectomy, two-third glossectomy, three-quarter, which is near total glossectomy, and the total glossectomy. For hemiglossectomy, like I said, the goal would be to preserve function of the remnant tongue. So we would like to give a thin pliable flap, which is helping in retaining the tongue mobility. The most widely used flap for this is a free radial artery forearm flap, and other alternatives to it. When the flap is not available, we might as well consider doing free ulnar forearm or an MSAP flap, which is a medial sural artery perforator flap. For next defect, which is a two-third glossectomy defect, now the goal has changed. We have to provide bulk and form, as well as there has to be tongue function also. The remnant tongue function also has to be preserved to some extent. So for that, we prefer using a little bulkier flap than the radial forearm. Now the consideration has changed. We have to provide adequate volume. It has to be a bulky musculocutaneous flap. The common flap that can be used is free anterolateral thigh flap. Another alternatives to be used is tensor facial lata flap and rectus abdominis musculocutaneous flap. For total glossectomy, it has to be a very large musculocutaneous flap with adequate volume, and the preferred option is pentagonal anterolateral thigh flap, and alternatives would remain the same. So after the next step in the surgery would be designing the flap according to the shape and inset. So planning in reverse as per whatever defect we have gotten. Most common shape that we use for a total glossectomy defect would be a pentagonal shape. An ellipse, a mushroom or omega shape, a Mickey Mouse shape, or a cathedral shape can be used as per the defect. So this is something like an omega defect for a hemiglossectomy defect reconstructed with a free radial artery forearm flap. This is a classic pentagonal shape defect used for subtotal and near total and also total glossectomies, providing good bulk and volume. And this is something where the tip has been restored. So the tip has been shaped into a Z-plasty, and after inset of a free radial flap, tip has been restored. Coming to flap inset, what are the points to be remembered, and what are the points which are absolutely to be avoided during inset, so that we do not end ourselves into the vicious cycle of OC fistula, thrombosis, and then further flap failures. So while flap inset has to be a watertight closure to prevent OC fistula. Inset on the lingual mandible and RMT are the 2 points where we have to be very careful, and preferably interdental suturing is a better form of inset to prevent OC fistulas. The red flags are poor mouth opening, presence of OSMF, very poor dentition, and if our flap choice has been wrong. So preoperative assessment of all the donor sites and the defect, and communication with your oncosurgeon is very important. Some of the examples of free radial. So here the defect is very small. So what we have done is we have taken a very small free radial forearm flap, fashioned into the defect after assessing the defect, and this is the inset, and because of it we could primarily close the donor site area. This is the next, this is a hemiglossectomy defect and a larger free radial artery forearm flap showing an inset. Here a little more volume was required than before, so that's why a larger flap was taken. Next is a total glossectomy defect along with a segmental mandibulectomy. Here the goal of reconstruction changes to giving bulk and volume. That's why a skin paddle along with a muscle has been taken, and after the inset, this is the volume that we have achieved. So this patient in particular, he did not want any scar on the hand and had specifically requested to avoid scars on the hand. That's why he was planned for a medial sural artery perforator flap for a hemiglossectomy defect. This picture shows the pattern of inset that we do for total glossectomy, which start from the inferior side and then go on to reconstructing the tongue so that it can mimic properly, and this is the volume that was achieved. This is the hemiglossectomy defect again. A female, she requested that she absolutely wants no scars on the hand, and there were no perforators found in ALT dissection. That's why decision was taken to use options. They do not have any kind of sensation, and there is sagging of the flap because of the volume, because gravity is always acting. So to troubleshoot these, let's see one by one. So the new thing that has come up is a neurotization. According to recent studies, sensory nerve coaptation of free flaps in tongue reconstruction has shown to be improved sensory recovery and also clinical function of deglutition and articulation. So most commonly when we are doing ALT flap, we can take nerve to vastus lateralis muscle, and coaptation can be done with the epiglossal nerve. Next is to safeguard the floor of mouth so that chances of ossification are less and sagging is less, and the volume retention is much better even after the radiation. So for this, we can take a chimeric vastus lateralis muscle and fashion it into a diaphragm, which has to be strong. It has to be dynamic as well. This is when the gracilis free functioning muscle flap was used to make floor of mouth, and a gastro-omental flap was used to make tongue. So here, as you can see, the blue part is a gracilis muscle that was fashioned into a floor, or a diaphragm was made, and it was a free functioning, so making it into a dynamic floor. And this whole thing is an omentum, and the pink thing that you see is a gastric mucosa. So after reconstruction, rehabilitation becomes a very important part, and as early as possible rehabilitation has to be started, consisting of swallowing, speech and swallow therapy. Patient has to be well educated, and as well as, most importantly, relatives have to be well educated. So coming to quality of life after glossectomy and free flap reconstruction, several studies have been done regarding it. And the conclusion is that in patients with total glossectomy, feeding tube dependence was not associated with laryngeal preservation or reconstructive techniques, including flap innovation and whichever type of flap was used, but the laryngeal preservation was associated with speech outcomes. The next troubleshooting part is avoiding subtotal and total glossectomy, but it is only limited to the fact that there can be several times when there are only posterior tongue defects. So anterior part, if it is preserved, we can do flow through flaps to establish vascularity to anterior part of the tongue. And there was an article published from Tata. There were several flaps that were done where we have put a free radial artery forearm flap as a flow through flap, and the vascularity of anterior tongue was preserved. To summarize this topic, the aim is to morphologically give a morphologically similar tissue reconstruction, to maintain mobility of whatever part is left, and to provide adequate volume in cases of total glossectomy. Sensory neurotization is a favorable thing to do, as well as floor of mouth reconstruction. PMMC versus free flap, I would say free flaps are a better option because PMMC has tendency to sag down and it may not provide adequate volume, and the mobility is restricted. And very important part is rehabilitation, speech and swallow therapy, which is equally important. Thank you so much.
Excellent presentation, madam.
Thank you so much.
Thank you so much. Any questions from the audience regarding tongue reconstruction? Yes, please.
How you will manage some cases like recurrent CA, which are already reconstructed with any LTR with?
I think that is a very unique question because it depends upon what is
Next
the
set of what
recurrence
is
and
the
what is the
reconstruction.
defect.
Yeah.
So in reconstruction, everything is defect based. So if you can tell us the defects, we'll give you a reconstruction plan.
If it was already reconstructed, it's already reconstructed as per your question. So it depends on whatever defect you are creating. If you had done like a primary closure defect, okay. And then if you are going for subtotal glossectomy, we can get rid of the previous flap if that is also involving your recurrence, and then put in a new free flap. Yeah, we can use either a separate neck, the contralateral neck, which was not used previously, or if that neck is vessel depleted because of radiation, we can also go for the same neck.
Any other questions? If not, then we'll move on. Thank you so much, madam.
Madam, can you elaborate on once we release the hyoid of all the muscular attachment when we excise the tumor, how you restore the hyoid position so that patient can be decannulated early and swallow function is better?
So there are two forms as I have discussed. One is static, one is dynamic. In static we are using hyoid stitch, but it's not always possible, particularly when we are doing free flaps. If the perforator is coming in, then we are avoiding doing hyoid stitch. The next best is static, dynamic form, wherein we are using free functioning muscle transfer. So the gracilis flap is forming your floor of mouth, and it's dynamic because we are doing neural coaptation. Plus we are giving adequate tension so as to restore the form.
Thank you very much, Dr. Priyanka Chilbule, ma'am. To conclude this session, I would like to invite Dr. Amaya Pai to felicitate the speakers for this session. I invite on stage Dr. Priyanka Chilbule, ma'am. Thank you so much for the lecture, ma'am. Next, I invite on stage Dr. Sagar sir. Thank you.
I have learned everything from him, so it is.
So, I request you to stay back, sir. I invite Dr. Srivalli ma'am to kindly facilitate our chairperson for this session, Dr. Amaya Pai. Thank you, ma'am. Moving to the final and the most awaited segment of interactive case discussions. For this session, we have Dr. Prashant Pawar sir and Dr. Sagar sir as the moderators, and there will be an interactive case discussion by Dr. Hitesh Sangvi sir, Consultant Head and Neck Surgeon, Fortis Hospital, Mulund. Welcome, sir.
So after a beautiful video demonstration, entire day I would like to bore you with some decision makings. And one of the cases which I want to discuss is on varicose carcinomas, especially advanced varicose carcinomas. So first on in those situations. So let's first go through the case which we went through. This is a big disease on right cheek involving the buccal mucosa almost reaching the anal-tragus line. Posteriorly it is short of the angle of mandible. Anteriorly you're not able to visualize the lip, but it is not involving the lip. And a lower border of mandible is also involved, but only averting, not involving the bone as of. RMT is free, ITF is free, but there are palpable nodes on the right side. Biopsy was varicose carcinoma, and CT scan showed no bony erosion. It only abuts the masseter muscles, and we operated him for bite. We already saw the video from Deepa Madam, beautiful video on ITF clearance and bite by alveolar resection. We did in this, and it was reconstructed with free anteroidal thigh flap courtesy Dr. Kranti Mahajan. And this is the HPR report which we got. It's varicose carcinoma on HPR itself again. And all these soft factors like perineural invasion, lymphovascular emboli, worst part of invasion, all were negative. WPI of course was type 1. Bone was free or margins were clear, and neck nodes all were negative. 6 months post-op, after a year, then the patient wanted some teeth to chew and to show, of course, cosmesis and functions both. With the help of our prosthetic colleague, Dr. Pratik Chheda, we got this template done, and 3 implants were placed in the maxilla and 1 in the mandible, and he got a beautiful smile like this. Now, this is the entire case, duration of about 1.5 years right from the diagnosis to the receiving or loading of the implants. The question we start with is, first biopsy is negative in such huge cabbage, I would say cabbage on the face case. Would you repeat the biopsy if it is negative in this case? I would take an opinion from Dr. Prashant. I think he is a moderator for the session. Let's quiz him with some questions, difficult questions. So, a cabbage on the face, first biopsy done by Dr. Sagar is negative. So it's an experienced surgeon who has done a biopsy. And would you repeat a biopsy in this case?
So we know that varicose carcinoma also called as Ackermann's tumor. You may go through the entire full thickness and you will still not get a pathological diagnosis because the basement membrane invasion is not typically seen in this lesion.
Correct.
So you have to go by your clinical judgment, and with that kind of a lesion you are never in doubt that you are going to do a radical surgery. So you should never be in doubt, and clinical picture is actually a telltale sign. The varicose carcinoma we always say is a clinical diagnosis. Okay, of course you do the biopsy at least once for the formality of it, and many times for medical legal and insurance purposes we need a biopsy. So that is necessary, but once the biopsy is negative, what says varicose does not mean that you should not do a surgery. This patient, of course we know that we should do a surgery, but many times it's a problem when it's a small lesion. That is when there is a doubt in the patient's mind as well. Okay, so that is when it's a quite a small dilemma. But in this particular patient, we have no, I think what we did was perfect. We did a radical surgery with appropriate reconstruction and rehabilitation.
So this is the experience telling you is, you see a lesion which is bad, it is resected, but what does the literature says? So literature says that, this article was published in 2016, it says that 51% of these varicose looking lesion will turn out to be negative. See, that is 50% will be negative, that means HPR is positive and biopsy is negative. That means biopsies may not be the gold standard in varicose type of looking lesions, which is quite a gold standard in a squamous cell carcinoma. Second most important point is these lesions have hybrid pattern. That means in one part of the lesion it will be varicose, but in other part it might show foci of a squamous cell carcinoma, and incidence is 20 to 30%. And one of the unpublished literature from ACTRAC led by Dr. Poonam has said that the sensitivity of biopsy is less than 40%. That means 60% of these biopsies will be negative, will turn out to be positive on final HPR report. Next question, Dr. Sagar, I would like to come to you. So yes, so negative biopsy, but patient is very, of course in this case it is huge, so it is quite easy for us to convince that we have to resect. But would you use frozen section in such cases? Would it help?
Frozen section for if
for both primary and yeah, because your decision making of whether to do neck or not. Of course, in this case, we have to open the neck and we'll do the neck dissection. But in cases where it is small, you have to open the neck separately, not for reconstruction. In that case, in those scenarios, would frozen section help in getting the primary diagnosis?
Dr. Hitesh, I would like to first comment on basically your premise of these kind of papers is I feel there is no harm doing a biopsy. If you are identifying the lesion as verrucous and if the biopsy comes as verrucous hyperplasia, still you are going to operate these patients. Problem comes when you not operate these patients because the histopathology is verrucous hyperplasia. So role of biopsy as reliability, I don't think it's a very good premise to begin with. If you are offering the patient for surgical treatment. Second thing is role of, if I know that there is, the lesion is verrucous carcinoma and I'm excising it with good margins, I may not be very eager. If the facility is available, I would still get it frozen section, but I'll go for good margins and for a large lesion like you showed, definitely I would do a neck dissection because we never know that this bigger lesion can have invasive focus. So neck dissection, yes.
So you said frozen section, you would not go for frozen section? No, you would not rely on the...
No, he said he'll use it frozen section whenever available. And if it's a small per only resectable, then actually it makes more sense to do a frozen section.
Correct.
Just an additional safety measure that we have made an attempt to rule out a squamous cell carcinoma. If I found a focal invasion, immediately I am done with the neck dissection and we are done with this case. But we also have to always counsel the patient that final histopath may throw up a surprise, and if that shows squamous cell carcinoma, we may have to do a planned neck dissection later.
Absolutely. So another unpublished data from ACTRAC coming in which says role of repeat biopsies. So first biopsy is negative. You think the clade is clinically suspicious. The role of repeat biopsy is limited. It only adds 16 to 17% of additional diagnosis. And second, which I asked him, was the role of frozen section. Again, the sensitivity is less than 40%. So to diagnose a primary lesion on frozen section, sensitivity is low. So of course, if you have the facility, you use it. But even if you do not use it, it's fine. Next, Dr. Sagar, I think coming back to you, is verrucous carcinoma. Frozen section is verrucous carcinoma. Let's twist the question a little. You would do level 5 neck dissection in this case. So of course, 1 to 4 you would do because you're opening the neck. So level 5 you would do?
So no, I would actually not do the
so
level
node
5.
is palpable, 1, 2, 3.
So that's what. So even if that, nodes are palpable.
Yeah, I think you missed it, yes. So nodes were palpable at level 1 and 2 areas.
Yeah, then I'll do the level 5. In fact, in such a large lesion with multiple nodes ipsilateral positive, I may even consider doing the contralateral neck. Even if it is a verrucous carcinoma, because we have the chances of it coming out in final histopathology as a well differentiated squamous carcinoma. This is a very typical, classical case where it sort of ticks into all boxes. Large skin involvement, multiple ipsilateral nodes positive. There is a very high chance that it's a squamous carcinoma hidden there somewhere. So it is not only level 5 of the ipsilateral that I'll address, I'll also consider addressing the contralateral neck here.
Even if it is not positive?
Even if it is not positive on primary.
Okay.
Also, try and understand the biopsy is like you're trying to look at the ocean from a small window. You will only see that much what you can see from the window. You will not be able to see everything. But so the clinical parameters should, give you a threshold of suspicion that we may be dealing with something more invasive. That's why if you're going to do a supramajor surgery, please do a complete, presuming that there may be a focus of squamous cell carcinoma.
Absolutely. I add to the concept that yes, it's a part of the ocean which we are diagnosing, but that is the only way we do for squamous cell carcinomas. So that is the reason why especially in verrucous carcinomas, not like squamous cell carcinomas. It may be different in other part of the area, which we call as hybrid verrucous carcinomas. Yes, Ramay.
One thought is, because we've already done multiple biopsies, we're not able to get one problem why that happens is because it's a verrucous lesion, it's a proliferative mass. So the whole thought process is to get a positive biopsy so that insurance and all these things, logistics are taken care of. When you are saying that you have multiple nodes positive, it may also be beneficial to stick a needle into one of those nodes. You may get a positive result. You may get a metastatic.
But if it's a little node, you stick a nickel needle. Dr.
Yes.
Sagar, FNS you would do?
For diagnosis,
No, I'll not be doing any
FNCs.
I'll not be doing any FNA.
Okay, perfect. So, so what does this? This is the experience of 3 good surgeons sitting in the front, talking about the role of neck dissection in verrucous carcinomas. So we don't not only depend on the HPR or the biopsy through HPR of the lesion, but also the clinical suspicion, which will determine what will be the treatment plan. What does the literature says? Literature says that the incidence of neck node metastasis, occult neck node metastasis, is less than 10% in verrucous carcinoma. So if the lesion would have been small, they would not have done the neck dissection. Next, we move on to, of course, the role of adjuvant radiation in verrucous carcinoma. So, Dr. Prashant Pawar, in this case, of course, the tumor board sat and we decided to give adjuvant radiation, even though it was a verrucous carcinomas, of course, with all those soft factors like skin involvement and T4 disease, but patient did not agree with that and he did not receive radiation. We have kept him for observation. But what would be your suggestion for the young people here sitting on the role of adjuvant radiation in small, less than 2 centimeters verrucous carcinomas?
Conventionally, radiotherapy is never given for a verrucous carcinoma because we know that it's a locally invasive cancer. There is a very low risk of recurrence as well. And more importantly, I would say, especially in a young patient, these patients are predisposed patients, then they have a tendency of a squamous cell carcinoma developing later in their lives, for which we need to preserve that important armamentarium as a part of the treatment in future cancers that the patient may have. So we do not want to use radiotherapy right now because it's not indicated either.
Absolutely. This is again the experience telling you what the literature says is that published literature in 2017, it says that it is reverse. That means it is a serial database. Of course, it's epidemiological data. Each patient was not collected individually, but then all said and done, the evidence says that those verrucous carcinomas who received radiation had poor survival as compared to those individuals who received radiation, though not statistically significant, but trends was reversed. So those who received radiation had 71.4 months of survival as compared to 117. We can go into caveats of the study, but the conclusion is this of this study. So to tell you that verrucous carcinoma is different from squamous cell carcinoma, it is not radiosensitive, it is radio-resistant, I would say. And therefore, I also agree with all the panelists sitting here that the role of radiation is limited in this case. Of course, with verrucous carcinomas. But in this case, where I would agree with Dr. Amay that all the aggressive factors were there, T4 disease, we asked him to get radiation, our tumor board asked him to get radiation, but of course patient was not consenting for the same. Next is the last question. I think I'm almost 15 minutes. Last question is for Dr. Sagar, of course. Implants. So this is my paper, of course, it's a systematic review and meta-analysis, but just for the knowledge of the young individuals who are very enthusiastic on doing implants post-surgery or post-oral cancer surgeries. What is your take on irradiated bone versus non-irradiated bone post-oral cancer surgeries implants?
So non-irradiated bone, absolutely no problem doing implants. Irradiated bone, again, I would study multiple factors. First of all, we know that radiotherapy would reduce bony healing, can have a poor outcome. Studies from Reinstema from Scandinavia, their papers show about 30% uptake or 30% survival of implants in irradiated bone. So I'm a private practitioner. So so frankly, I myself am not very conducive for implants in irradiated bone. It's my bias.
No, absolutely, and that is what the experience says. Even when we do a review of literature, of course, there were a lot of heterogeneity involved in this analysis. But what we got to know, there were trends towards reduced survival of implants in the patients who received after irradiation. But it is not only the factor of irradiation; it's also the factor of when do you put implants post radiation, or whether you are placing implants primarily or secondarily. And when are you loading it? So, Dr. Amay, I think in your, I would say, review of literature, I would not say experience, but in your review of literature, what do you feel immediate placement of implant versus delayed placement of implant, or mandible versus maxilla? Is there any difference?
So regarding this immediate placement of implants, the literature says that in a per primum case, where you're placing the implants in the fibula during the primary stage itself, there is no effect on the implant by the radiation. How far as does it practically work? I really have no experience with that. I have not placed implants.
So collectively, we have 3 surgeons who have more than about 2,000 surgeries. What is the percentage of dental implants, Dr. Sagar, Dr. Prashant, and Dr. Amay, have you placed after fibula?
So I have no experience of placing implants, but there are multiple studies which show that even if the implants
experience. So let's
no
go practically. Dr. Sagar is 10 years, Dr. Prashant is 10 years. In 20 years of collective experience, how many fibulas have received?
So benign disease and disease where we are not radiating every fibula. For irradiation, I just usually don't place. I have never placed implants.
You never placed implants?
I have never placed implants. Not primarily, not secondarily. It's my bias.
Okay. So even Dr. Prashant, in your experience, no implants placed
No
in any
implants
fibula?
placed. So the problem with most of our patients is that they are, complex defects, skin involvement, lack of sulcus formation, trismus. So very rarely do we come across patients whom you see and you feel that yes, this may be a candidate for an implant. So that is the problem. So very, in practically on practice we are seeing patients who are complex defects. Very rarely do you see a small alveolar carcinoma with bone erosion. You're going to do a nice segmental mandibulectomy with a cervical skin crease inclusion. Very rare. That's the reason why I have not placed implants and giving a disclaimer already.
So two important points I would say can come out of it is first, there is a lot of scope for you to come in. A lot of oral surgeons and a lot of dentists can come up and find out the way on how to place implants in these cases. And second is also very important that practically we are not placing implants in any of the fibulas. So all said and done, practically it is still a far-fetched dream for the patient to receive, or I would say for a patient to receive dental rehabilitation post-fibula. So I would end this because I think 15 minutes are over. I would just conclude that for varicose carcinomas, repeat biopsy may not be indicated. You can still go ahead with resection if it is looking clinically suspicious. Neck dissection is not indicated in varicose carcinomas until unless it is aggressive enough, or I would say of advanced stages. Implants is still a far-fetched thoughts in oral cancer cases, but yes, it opens up a scope for all of us to make it a way to happen. Thank you.
Thank you, Ritesh, for a very wonderful interactive session. I would like to call upon the next speaker. Dr. Amay needs no introduction. He's going to present an interesting case.
So it has actually been a long day. I promise I'll keep this extremely short. This is basically just up for discussion because this is something that is not usual. This is something that it is not very conventionally practiced. So we start off with this case capsule. I would really want inputs and sir from both of you all and from everybody else probably who can contribute to it. This is absolutely open to discussion. So we are considering this case of a 55-year-old male. He is a smoker and he presented to the OPD with difficulty and pain in swallowing. On examination, he was found to have a small ulcer on the base of the tongue. Okay. It was on the ipsilateral side. He was biopsy was taken. Biopsy came out to be squamous cell carcinoma. It was a P16 positive. So it is an HPV mediated biopsy positive oropharyngeal squamous cell carcinoma. So according to conventional NCCN guidelines, according to all his EAC guidelines, there were no workups were done. Everything was done, and the tumor board meeting said that we'll push him off for concurrent chemotherapy and radiation. He received the entire course, he completed the course and came back with a residual disease. Now I want to actually have thoughts on this. Now with this type of lesion that is there as a residual disease, what will be, sir, your thoughts on this, sir? How do we go ahead on this? Now he is 3 months post concurrent CTRT. He has just sort of finished his treatment. He's a 55-year-old male. He's really very fed up with whatever he has gone through. Just come out of his Riles tube, and now the doctor tells him that there's a disease back there.
I think it's a very sad situation to be in. But the first and foremost innovation that we need to do is first is a PET-CT scan.
Right.
Okay. To know what is the local extent of the residual disease as well as the status of the lymph nodes. And because it's immediately post-treatment and across the observed disease, there is no need to repeat a biopsy.
Right.
But if you are confused whether it's disease-related inflammation or real disease, then you may as well do a small biopsy as well to prove. It's very rare to have a P16 not responding very well, but these are things that happen.
Right.
And the other things, of course, a part of the workup is that once you have the PET-CT and other information, you would need to do a UA. A lot of clinical factors will determine how you go about a disease. But of course, surgery is the only salvage treatment that we can offer.
So some key points here, like sir said, we have already taken him up for scans. We have ruled out everything. There are no neck nodes. It's only this residual disease that is left behind. And the good part is that he is having a functional tongue, as in he speaks well, he is able to swallow. It's only the pain that is troubling him. PET-CT scan is absolutely clear. So now the only thing that you can offer to this man, if you are offering him any treatment of any type, is to offer surgery. Now to move ahead, sir, what is the surgery that you think this will entail? So here we see that this is just at the midline. It's just at the midline. Clinically, it is slightly in duration, is just crossing. So you can actually feel that it is just crossing the midline over here. Over here, you can see it is entirely in the base tongue. There is no lesion intraorally. There is nothing that you can actually see on the oral tongue. It's entirely on the base tongue region.
I think looking at these scans, what I am looking at is a near total glossectomy with a bilateral neck perhaps and a free flap reconstruction.
Right. So conventional plan would actually entail us to do a near total bar a total glossectomy. So that would actually sort of, we would be getting rid of his entire tongue, near total or sort of entire tongue. The point of contention here is that the patient straight away says that if I am not able to speak, if I am not able to talk, I don't want to get the surgery done. So everybody has offered him this treatment. They have said that we'll take the entire tongue, near total part of the tongue out, and he is not ready for surgery. Now he says that I am ready to get anything done, but you have to save my tongue. So the problem that, or sort of his contentions was, first is that he'll be having a loss of tongue function, speech, swallow, everything will be gone once he go ahead with this conventional surgery. And that is the reason why he is not sort of convinced for a radical surgery. So now the surgical options that we have is now a total glossectomy, or to do a base tongue resection via mandibulotomy approach, that's the translabial transmandibulotomy approach, or to do a TORS. Now the challenges that we faced over here is that the total glossectomy part was already out because he said that he did not want to get it done if there was a functional deficit. The mandibulotomy approach is again out because he's a candidate who is post-radiation. So the moment you touch his mandible, the moment you touch it, there is also a very high chance that he may actually land up with an ORM. So this goes out of question. TORS again is out of question because, as we know, again, the financial constraints, the other logistic constraints, not everybody is actually trained to do. So we came up with something called as a parapharyngeal space, transpharyngeal approach for this resection. So I'll just have a small video as to how we did this resection. So to begin with, so this is a ideal classical sort of picture where the entire ipsilateral neck has been addressed. So we can see here, this is the posterior border, posterior belly of the digastric. That's the anterior belly of the digastric. This is basically the hollow that earlier housed the level 1B, and that's from where we'll be gaining entry into the parapharyngeal, into the transpharyngeal space. So here we see that we are actually going between the mandible and the space. We are actually cutting through the pterygomasseteric sling. So that is where it actually starts lifting. This mandible starts lifting up. And now we start sectioning this posterior belly of the digastric so that we could approach this axis, approach this area. Now care that has to be taken during this is that we have actually given the facial artery just over here for reconstruction. So we have to make sure that we keep an eye on this artery when we are actually sectioning out the digastric. The posterior belly of the digastric is now being cut. So once the posterior belly of the digastric is cut, what we can see just under the posterior belly is the facial artery, the common facial belly, and that's the hypoglossal nerve. The hypoglossal nerve again will have to be cut because it's the ipsilateral side. It sort of is cut it is cut to gain access into the A. So once the hypoglossal nerve is cut, the next space that we sort of land up over is the carotid space. That's basically the space that encompasses the entire carotid vessels and the IJV. So here we have the hypoglossal nerve which we are cutting. So there is the facial, that is the hypoglossal nerves that have been cut. Now the next anatomical structure that we have is the lingual artery here. So that's the common facial, the linguofacial trunk that we are seeing. So this is the part of the IJ with the other part of the common facial vein that is there. So we'll just we sort of ligated it. So here you see this is the lingual artery now. That's the branches of the external carotid artery. So that's the lingual artery that is now coming into the picture. So this dissection is completely inside the carotid space now. We are actually dissecting across into the carotid space. So that's the lingual artery which slowly you can see that it is getting exposed. So this is the last bit of vascularity on the ipsilateral side for this side of tongue. So once this is taken off, the entire vascularity of the ipsilateral tongue is sort of taken care of. So you can actually do a very good bloodless surgery over here. And so this is the last part of the vascularity or the last part of any structures of the carotid space that are left. So immediately medial to the carotid space will we have our pharyngeal space. So that's basically the part from where we will gain entry. So whenever we do laryngectomies or where we basically gain entry into the vallecula, so this is the space from where we actually go in. So these are all at the greater cornua of the hyoid bone. So this is what we are palpating at the greater cornua. This is basically what we are palpating at the greater cornua. So immediately medial to the greater cornua, we will be having the vallecula. So we will be making a small cut and entry into the vallecula. We'll see. You
can also put on a large artery.
Right, sir.
To poke there to show where you are.
Right, sir. So there we have actually sort of cut through the pharyngeal mucosa. Now slowly you'll, yeah, so that there we see, that's the pharyngeal entry, that's the pharyngeal mucosa that we have cut. So we have gained access into the behind part of the tongue. So basically this is very close to the vallecula now, and there you can see the epiglottis. Yeah, so that's the epiglottis that we have. So basically everything beyond this over here will be the tongue. So that's the epiglottis. So this is the entire tongue that we have in picture. Now slowly you can have this entire base tongue to be resected under vision. So the part that we could not even see for examination, we part could not even see for palpation, is we will be doing this entire resection under vision with no endoscopes, with no need of robotics, with no need of any other fancy material. Just under vision this entire base tongue has been removed. Now the challenge that we actually faced is, it was the resection that was crossing midline. So if at any point of time if we encountered the contralateral lingual, so all these efforts would have been futile. We would have to knock off the entire tongue. So by God's grace we have been really lucky that we did not actually reach there. So that's the entire base tongue lesion that we had seen in the MRI that is sort of coming out. You can appreciate as to how well good controlled margins you have over this lesion, because this type of vision and control over the margins is very adequate for you to get a very good margin. We reconstructed this defect with an ALT. The concept of doing it is because we needed a thick flap. Ideally, when you have a good thick flap, it will actually help to elevate the entire the epiglottis so that the function of the larynx is preserved. And we could actually decannulate and sort of remove the Ryle's tube for this guy on day 21. He is completely on oral feeds. He is off his tracheostomy tube. So this is one of these methods through which this is one of the approaches through which we could actually do a bilateral base tongue resection. So this is just something that I wanted to point out.
I think a nice video. I just want one comment on.
Yes,
the resection remains the same.
Right, sir.
No matter what approach you do.
Right.
And the other thing that I could do the same thing. You can still do the same thing by doing a pull through.
Right, sir.
Okay. You will have all the access.
Right, sir.
You'll remain the same amount of tongue will be remaining.
Right, sir.
And your reconstruction also will be easy.
Sir, the only issue with the pull through method is that when we are actually hitching the tongue back, we will be the tongue will actually get hitched to the mandible. So there will be no sort of mobility to the tongue. That was one of the reasons. So other thing that we did in this case was we inserted the flap slightly anterior, as in because we needed something to monitor intraorally, because this defect was completely behind the tongue. So we inserted the flap slightly anteriorly. I had a photo, I'll just actually forgot to put it out. We inserted the tongue slightly anteriorly so that we could monitor it. What helped in that is because it was slightly anteriorly, the entire tongue could move. The floor mouth, everything was preserved. So what was removed was just the ipsilateral geniohyoid, genioglossus, these muscles, and the mylohyoid. Everything else was preserved. The anterior tubercle muscles, the contralateral mylohyoid. There was no need to stitch things back. So speech and everything is as good as nothing has happened, as of yet at least. Now God knows further.
Great. Thank you so much, Amay.
Thank you.
Any questions from the audience? I think we'll wrap it up now. We're already late.
Thank you, Dr. Amay Paisa. As we nearing the conclusion of this academic feast, I would really like to thank all the speakers and moderators that we had in today's session. I would like to invite on stage our chairpersons and moderators for this session, Dr. Prashant sir and Dr. Sagar sir, to felicitate Dr. Amay Paisa. Dr. Hitesh Singhvi sir, may we please invite sir on stage. I would also like to invite Dr. Pranav Sathya sir. Thank you, sir. May I request Dr. Shivali ma'am and Dr. Usha ma'am to kindly join us on stage and felicitate our chairpersons, Dr. Sagar sir and Dr. Prashant sir. Ma'am, chairperson. Sagar sir. I would like to invite Dr. Usha ma'am to kindly render the vote of thanks for this conclave today.
Good evening, everyone. Now, as we draw the wonderful conclave to a close, I would like to take a moment to express our sincere gratitude to all the dear ones who made today's event a memorable one. Firstly, I must mention our mentor, our guide, our beloved director, Dr. Sudhir Kadam sir. Thanking him is like stating the obvious. He has always been a guiding force. We extend our heartfelt thanks to our management for always encouraging us. The very presence of today's distinguished faculty from the Institute, which has been the beacon of excellence in the field of oncology, in spite of their busy schedule, is a reflection of commitment towards discipline and profession. Our profound gratitude to all the faculty from TMH and Accredited, Dr. Gauri Madam, Dr. Prashant sir, Dr. Deepa ma'am, Dr. Amit Janu sir, Dr. Swapnil sir, Dr. Vidisha, Dr. Rathan, Dr. Hitesh, Dr. Shivakumar, Dr. Tanmay, Dr. Priyanka, Dr. Pranav, Dr. Arju, Dr. Richa, Dr. Amay, our alumnus Dr. Arjun, and our dear ex-colleagues Dr. Sagar and Sandeep. Sincere thanks are due to Prashant sir for his efforts and guidance to bring this event to life. Hospital Director, MGM Medical College and Hospital, Lieutenant General retired Dr. Salgotra sir richly deserves our gratitude for his ever-time support. Many thanks to Dean, MGM Medical College, Dr. Nashetti sir for unconditional help always. I am proud to say that our department is fortunate to have a leader who not only challenges us to excel, but nurtures an environment where innovation and collaboration thrive. Thanks with love to our outstanding dynamic head of the department, Dean MGM Dental College, Dr. Srivali Natarajan, for bringing out the best in each one of us. Thank you, ma'am. No one can whistle a symphony. It takes a whole orchestra to play. I appreciate each one of organizing team for playing their role right. Special mention for Padmakar and Parikshit. Heartfelt thanks to all the heads of the departments of MGM Medical College and the Dental College for sparing their valuable time with us. Sincere thanks to all the chairpersons, Dr. Kalpana ma'am, Dr. Yogesh sir, Dr. Ujjwala and Dr. Pranay Pardesi for MSDC observership. If time is money, you have spent million on us. Further appreciations are due for our budding rock stars, our dear PGs, interns, volunteers, rangoli makers, pot painters for their quality support. Big thanks to media head Dr. Avinash. Special mention for store in charge Mr. Atish, our IT team, Sanket, Kumar, Praveen, electrical team, audiovisual team, housekeeping team, our non-teaching and our green cafe portion also, who supported us round the clock. We are happy to acknowledge our sponsors and Orthomax for their financial help. Finally, thank you all wonderful students and delegates for your active participation and engagement throughout the session. Let's continue the conversation, collaborations, and carry the knowledge we have gained today into the future. Thank you once again, and we hope to see you all at future events. Thank you.
Yeah, I would also like to thank Dr. Usha herself, who's been responsible for the excellent hospitality and actually putting this program together. And with her, Dr. Sneha and Dr. Meghna, who's hosted the whole function. Yeah, thank you.